immunogenetics, particularly as pertains to HLA typing. So, no? This doesn't work? Went up there.
The gray one is the next one, the forward.
Okay. This one, right?
Yeah, this one is the next one.
It's stuck.
So this doesn't count from my 15 minutes.
You were right. Absolutely forgiven.
I just tested it. It is working, so I think it's the dongle.
Many titles. Right, so before we get started, we will have transmission through Zoom. Thank you, everyone that is in here. We will have transmission through Zoom and YouTube, and they are going to send me the link for the YouTube, so it will be much easier for people to watch from everywhere and to be saved for later, so you can use with the fellows. It'll be very good. If we want to start without the control, would you pass the second slide? Would it be possible?
Okay.
All right,
Yeah,
we can get
that's,
started.
Okay.
Just
So
next.
just very quickly, the structure of HLA, the inheritance of HLA, functions of HLA, typing methods of HLA, and HLA WHO nomenclature. And actually, the most practical part of this talk is reporting and interpretation of HLA typing results. Next. Okay, so the HLA molecule, actually, I would say this is the master orchestrator of any allo process, because it's our identity. It's what distinguishes self from non-self. So as long as we are in the allo anything domain, either allo bone marrow transplant, allo CAR T, allo anything, we will always be governed by HLA. And that was discovered by Jean Doucet in 1953 that qualified him for Nobel Prize in 1980. Next. So class 1 HLA is made of one chain that is the alpha chain. This is the polymorphic part that distinguishes one individual from another. And the beta 2 microglobulin that is monomorphic. It is similar on all individuals. Class 2 is made of two chains, the alpha chain and the beta chain. Beta chain is the most polymorphic. Alpha chain in many of the molecules like DR, and they are monomorphic, they are the same. But in DQ and DP, both chains are polymorphic. Next, please. And this is like the major scheme of things where the HLA lies. Next, please. Okay, so this is the classical class 1 MHC. Sometimes I get the question, what's the difference between HLA and the MHC? MHC is the major histocompatibility complex of genes. So this is actually refers to a genomic region that encodes the HLA molecules. MHC is universal to all species. HLA, as the name implies, it's human leukocytic antigen, so it has to be in human. And there is equivalent, there is swine leukocyte antigen in pigs and so on. And it has to be expressed on the surface of lymphocytes. So that's why it is called human leukocyte antigen. For example, this is the class 2, the classical MHC class 2, which is the DR, DQ, DP. And as I mentioned, for the DQ and DP, both alpha and beta chains are polymorphic. Next slide. Then we hear about things like MIC-A, where that falls in the major scheme of things. Is it HLA? No, it's not, because it is not expressed on the surface of leukocytes, so it doesn't meet that definition. And we refer to it as non-classical class 1 molecules. Next. And HLA is inherited in blocks, so it is not like we get each HLA locus independently from other loci. We get them in haplotypes. So for example, if the father typing is at the A locus 1 and 3, at the B locus 8 and 14, at the C locus 10 and 17, and the mother typing is at A2, A10. This is a very old slide, so 10 is like the 25 and 26, and there is 7 and 16, and at the B locus, and the DR 11 and 8. We can see here that the 1 and the 8 and 10 travel together, and that's what facilitates the haplotype, haploidentical transplants, because always there is a 25% chance to have HLA identical siblings, and there is a 50% chance to have haploidentical, and there is 25% chance to have complete.
Yeah, we just have Zoom linking. It's okay, Dr. Cordero.
Okay.
I'm sorry.
Okay.
Don't worry.
Okay. And there is 25% chance that the two siblings do not share any haplotypes because they inherited the opposing haplotypes from each parent. Next, please. And actually, haplotypes are inherited, are structured differently in different populations, and that's what leads to the difficulty in finding matched donors in unrelated registry that are predominated by European and North American donors. So their haplotypes, because we agreed HLA is not going to be inherited locus by locus, it's going to be inherited in haplotypes, and these haplotypes are going to be different in different populations. So South Americans are actually going to have different haplotypes. I mean, not necessarily entirely different, but they would have some haplotypes that are not well represented in Western predominated registry. And actually, last month, there was a workshop in Japan where we facilitated workshop that looks at haplotypes from different parts of the world. Next, please. This is the report of a previous workshop when we looked actually, this is the 17th workshop, when we have data about haplotypes from many parts of the world, including Argentina, including the Caribbeans, and the different parts of Europe and the US as well. Next. So next. So why we have HLA? It is not only to make the life of transplanters difficult. It actually serves a purpose. And it protects us from microbes because they would look different. They would be represented. The HLA is the display, if you may, that present peptides, foreign peptides. So those could be of microbial origin, and they would be recognizable by the immune system. So they play a very important role in microbial immunity. And if we have immune deficiency in which there is no MHC, that wouldn't be a good thing because these cells will be vulnerable to infections. It's also anti-cancer. It's critical in anti-cancer immunity because if we didn't represent the mutations, that carcinogenic mutations are actually not the exception. It happens in every one of us every day, but they get eliminated before they become larger cancers that the immune system cannot deal with by just these MHC molecules presenting these carcinogenic peptide products, if you may. Next. But of course, they lead to, in the course of doing all these good things, they lead to bad things, such as rejection of solid organ transplants, or even primary failure of graft in bone marrow transplant, or graft versus host disease. And of course, they could lead to autoimmunity. Next. So typing methods, it started with serology. So basically, this is how HLA was discovered, that sera from multiparous women or people who received a lot of transfusion, they would react against lymphocytes that have the antigen for which there are antibodies. Next. Then started different methods of molecular testing that actually looks at combinations of patterns that are unique to different HLA genes. So every allele would have specific sequence, and if we spot different parts of it, then we would be able to identify which molecule. So this is probably the least expensive, least complicated method of HLA typing. It kind of went by the wayside. I don't think it is still popular. Next, please. Then the Luminex, this is actually one of the commonly used methods for low and intermediate resolution typing. And it actually create probes that hybridize to different parts of the sequence of HLA alleles. And based on the hybridization patterns, we can tell which allele is there. Next. And of course, there is the Sanger sequencing that is no longer done in most part because next generation sequencing is a lot more higher throughput, less expensive. Next, please. And there is real-time PCR that is actually a glorified method of the SSP. It looks for specific patterns, whether it is present or not. If it is present, you get a peak in the right place. If it is negative, you find negative. And based on the combination of which parts of the sequence are positive, which parts are negative, you identify which allele is there. Next. So this is the nomenclature. The first part is the locus. So this is allele at the C locus. The asterisk denotes molecular typing. The first field, which is between the asterisk and the first colon, shows the type, which oftentimes correspond to the serologic equivalent. The second field, which are the O2, is the allele of the same antigen group. So this is the subtype. And the third field denotes silent substitutions. So there are different genomic sequence differences, but encodes the same amino acid. So it is silent, so it doesn't affect the protein structure. And there is the fourth field. It denotes the differences in non-coding region. So also it doesn't affect the structure, but may affect the function like level of expression. And then the last part of the allele name could be present, couldn't be, it may not be present when you have expression variant. So if there is allele that is null, it is not expressed, or it is low expression, could be L, or could be secretory, which is not expressed on the cell surface, denoted by S. Next, please. As I mentioned, for the most part, the first field corresponds to the serology, but there are exceptions we need to be mindful of. And this is very important when we are looking at antibody for donor-specific antibody. We need to know these things so we can tell when there is DSA or not. So you will never, typically you wouldn't find antibodies against 1501. But you need to know that when you find very high level antibody against P62, and your donor is 1501, then you know that this is donor-specific antibody. And the same goes for this list. This is just an example. This is not a comprehensive list. Next. The T-cell epitope. Probably some of you heard about the permissive DP, non-permissive DP, and it causes some confusion among people. So next, please. So basically, it grouped DP alleles into different levels of immunogenicity. So level 1 is the highest level of immunogenicity. Level 3 or 4, because there are two classifications, is the lowest level of immunogenicity. And the way I explain it to residents and fellows, I say that if you have the high immunogenicity, like the rich people, they have a lot of money, nothing bothers them, everything is inexpensive for them. The low immunogenicity are poor people. Everything is too expensive for them, everything bothers them. So if you have the donor and recipient in the same immunogenicity group, the donor and recipient there is no GVHD, there is no rejection, right? But if you have them in different group, then the poor person is gonna react and be annoyed by the rich person. So the low immunogenicity, how the recipient or donor is gonna mount immune response against the high immunogenicity. And based on this, if they are the same group, they will be permissive. If they are different, then if the recipient is the lower immunogenicity, then this is gonna be non-permissive in the host versus graft direction. If it is the donor that is lower immunogenicity, this is when you have graft versus host disease. Next. And of course, that has been shown. This is, of course, is being challenged by PTSI, but if we talk about non-PTSI regimens, it has been shown that the permissive actually yields to outcomes comparable to DP matched. Next. So this is the NMDP policy for typing. There needs to be high resolution typing on all primary donors requested for workup. Of course, the policy is mainly geared towards unrelated, but I think there is a lot of elements of it that are applicable to also related. So for example, having typing on a buccal swab. I don't think this is unique to unrelated. I think either way, if you have a malignant condition and you do peripheral blood, there is a risk that you may miss loss of heterozygosity, which is a mechanism by which leukemias lose expression of HLA to evade the immune system. The patient, there needs to be verification typing because we are all human, we make mistakes. There could be mislabeling of samples, there could be, there could be sample switch in the lab. I mean, these things hardly ever happen, but if it happens, we need to have safeguards to prevent them from happening. And we need this actually before what is known as no return back points. So you don't want to realize that, oh, that's not actually the donor after you give the patient conditioning to transplant, or after you did bone marrow harvesting, or after you give the filgastrum or what have you. Whichever happens first, you need to do the verification typing before that. Next. So I'm sure my friend Damiano is going to give a lot more elegant presentation of this, but until that publication, HLA wasn't part of haploselection. Until this paper that showed, and I'm just going to give you very few things because it's relevant to reporting. It's very important. So next slide. It was shown in this study that some combinations of matches or mismatches may affect the outcomes. So for example, DRP1, if you have mismatch, you would have less relapse. Next. If you have DPP1, I showed you the results historically before PTSI. The non-permissive was regarded as favorable compared to, the permissive was more favorable than the non-permissive. In this study, in this context, in PTSI, in haplo, the non-permissive was more advantageous. Next. And that actually contradicts the NMDP guidelines from 2019 with next, which actually favored the DP permissive. Next. And based on this, there is this, of course, I expect you all to know this and can do it by hand, or you can use it as CIP-MTR tool that you enter the typing of different donors, and it would give you disease-free survival projections of different curves with different donors. Next. So I think this is really the most practical part of this talk, and all of what I described just to lead into this part. When you report HLA typing, there are fundamental questions the BMT physician needs to know, and you need to communicate them in the clearest language. I look at reports through my role with the NMDP from all over the country, sometimes from international, and they tell me we can't understand those reports. I tell them, I can't understand it either, and I've been in this business forever. And you need to communicate. Do we have HLA identical donor, or we have a haplodonor, or the donor and recipient don't share any HLA haplotypes? This question needs to be communicated in the clearest language, first thing in the report. Then we need to indicate mismatches if relevant to the program. Meaning, we don't want to clutter the reports with things that are nonsensical, doesn't mean anything. If your clinicians don't factor in permissive versus non-permissive DP, then reporting them is just silly. It bothers everyone. Reporting KIR ligands, reporting MEC-A, if it is not part of your clinician's donor selection scheme, then you shouldn't bother them with this. Next. So in summary, HLA structure and function, it is really a critical cell surface protein governing immune responses and transplant compatibility. It is inherited in blocks, haplotypes, which allows us to do haplotype transplant. And I also always emphasize and say, is this equivalent to having 4 out of 8 mismatches? No, because we use this HLA typing as the milestones, if you may, on a highway. So if you're having 2 highways and you know it is 1 block and the milestones are identical, then the assumption that everything in between is identical. But if they are completely different highways, then having the similar milestones doesn't necessarily indicate that everything in between is immunologically similar. And the HLA typing methods and reporting results need to be appropriate to the clinical context and practice in your center. Next, I think that's probably. Thank you.
Thank you so much, Dr. Askar. We'll make the discussion later. Thank you so much. And now I have the pleasure of asking Dr. Damiano Rondelli to talk to us about mismatched family donors. Thank you so much, Dr. Rondelli.
Thank you, Adriana. I need my slides, please. Thank you. It was great. First talk was very helpful to give everybody the sense of the HLA typing. I'll try to be more practical and clinically. Is that me? I swear. There's an echo. And a baby. Wow.
And the automatic stuff.
Poor baby.
What are they doing?
Okay. I hear my voice. I don't think you need to hear me twice. Okay, thank you. So you just heard in the previous talk very well explained the HLA typing. And this is a very much simple way to explain how we usually have, when we look at for a donor in the family, every person inherits a haplotype from mother and fathers, and the different combination that were very well explained can be very simplified in this graph, where the sibling, the patient, our patient, okay, they don't want me to talk. It's on purpose. So our patient will have to find a donor in the family as a sibling and has only 20-25% probability to have a sibling fully HLA matched. Next slide, please. Next, próxima, por favor. So, well, the practical way we use when we look for a donor We do the HLA typing of the patient, and we have the HLA typing of the siblings, if the donor has siblings. That can be done at a low resolution HLA typing, especially if in your hospitals there's a cost associated with HLA typing that may be charged to the patient. So low resolution HLA typing is quite cheap. And in that way, you test the first batch of possible donors that are the siblings, brothers and sisters from the same parents. If you find a donor, 10 out of 10 HLA match, you're good, and then you confirm, as you heard, the HLA typing. We usually confirm with the high resolution typing for at least ABCDR. Now we also test for DP and DQ. But then you're done with the donor. You have a matched sibling, and you can go ahead. Next slide, please. If you don't have a matched sibling, the first option in our sites, at least until recently, was to look for an unrelated donor.
Recording stop.
In the same family, this is the case of before, this patient, if you looked at people who could be only 50% compatible, haploidentical, in this case, this person would have at least 4 people that could be haploidentical to the patient, because the parents are by definition haploidentical, and most of the other siblings will be haploidentical. You can expand this to other relatives. You can look at cousins and uncles and grandparents. And so the probability to find a donor for any patient within the haploidentical setting can be over 90%, which has been a huge change in the practice. Next slide, please. Next. So going back to what I showed before, so we had tested our siblings. They are not matched, so we looked for the haploidentical option. And and we see that we have multiple possibilities of donors that are at least 5 out of 10 or 50% compatible. In these cases, we, in addition to we do the testing by a high-resolution HLA typing, but we also look for antibodies. That's going to be done with the initial panel PRA, but also we do a cross-match, basically testing the serum of the patient against the lymphocytes of the donor to see if there are actually a reactivity. And in that case, you can actually measure the donor-specific antibodies, class 1 and class 2. And this actually can be a major barrier to haploidentical transplant because this is not so uncommon. So you can select among all the possible haplodonors those who actually don't have a high titer or no titer of antibodies. For those who actually have a high titer, you can, but that's another topic, a topic for another lecture, but you can do desensitization to try to eliminate the antibodies up to some threshold of titer. And now the challenge. Oh, so this is another, just to show that, slides from some years ago, that the haploidentical transplant has become extremely useful and extremely popular. This is US data, and I'll show you afterwards the global data, because both haplo and unrelated donors can now be selected, if not, even the unrelated donors can be not compatible. So haplodonors and mismatched unrelated donors have really increased the number of transplants that we are doing whereas you can see the green line, the matched sibling curve, does not really increase over the years. In the global setting, you can see there's a paper from the WBMT. It's actually, can move the top, the right figure. In Asia, the haploidentical transplant have been increasing very, very quickly, very rapidly. Same thing also in Europe and North America, and some are also in Latin American. But the reason why this haplotransplant is actually increasing is because, especially outside the United States, or Southern Europe actually, families have many siblings, have many children, so there are more opportunities to find an haplodonor, and especially the costs and availability of the donor is much easier compared to the unrelated option. No, sorry. All the story of the mismatch-related transplant is now possible because of you heard before, the post-transplant cyclophosphamide. For those who actually want to start a transplant or want to start developing allogeneic transplant, this is like a very important information to have, because the post-transplant cyclophosphamide has changed completely the way we do transplant. Now also, within the matched donors, we give PTCide to almost to every patient. Why? This actually was a discovery that made by the people in Baltimore at Johns Hopkins that studied before an animal model and then translated into a clinical trial to show that the lymphocytes, the T cells of the donor, the incompatible T cell of a donor, will react very quickly after the transplant. The clone that really could cause an acute GVHD reacts quickly after the transplant and peaks, the proliferation of the T cells, peaks on day 3 after the transplant. So they did the study where they showed that if we give a high dose of cyclophosphamide on day 3 and day 4 after the transplant, you eliminate this very alloreactive T cell clone that would cause a hyperacute GVHD, a lethal GVHD. And by eliminating that clone of T cells, basically you make the transplant almost the same as a matched transplant. The purpose of the cyclophosphamide was shown by the same team not only to eliminate the T cell clone, but also to favor, in particular, the expansion of regulatory T cells, which are T cells very rare to find, but if you can expand them, that have an immunosuppressive function. So the initial trial that was actually open up the gates to the haplotransplant is still very, very utilized. What we call a non-myeloablative conditioning regimen, so a dose of chemotherapy and radiation that is very well tolerated, not very toxic, with fludarabine, a very small dose of cyclophosphamide, and the total body radiation at 2 gray, so very small dose of radiation, which is only helpful to immunosuppress the lymphoid system, but is not really toxic. And then on day 3 and day 4, as I mentioned before, the cyclophosphamide at 50 milligram per kilo per day. And then the patient would have a GVHD prophylaxis with tacrolimus for 6 months or a year, depending on the patient, and only a short course of mycophenolate. The original study of Baltimore was very focused on using bone marrow cells. Of course, bone marrow has less lymphocytes, so you would be a preferable source of stem cells when you're afraid of GVHD. This has become quickly impractical for many centers who don't do bone marrow harvest, and it was actually proven that peripheral blood stem cells, haplo stem cells, actually have pretty much the same results with post-transplant cyclophosphamide. The initial studies comparing the CIBMTR data, the registry data, we're looking at the outcome in the registry of haplodonors versus unrelated donors, saying that actually there was no difference in both in a myeloablative regimen and a reduced intensity regimen, despite the fact that the reduced intensity had a slightly higher relapse rate, but not significant. So there was not a difference. Patients with MDS over 60 years of age This was, I remind you, it was a non-myeloablative regimen, so a chemotherapy that can be given to any age of patients. So the analysis also comparing the registry data of a matched sibling, unrelated or haplo in older patients with MDS did not show a difference in outcome. It's too fast. Then it was compared haplo versus matched sibling, still in the registry, and yet there's no difference in the registry outcome, in outcome in disease-free survival and GVSD between the matched sibling and the haplo donors. Goes too fast. Yeah, this is older patients. There are also nowadays there are many actually conditioning regimen that can be utilized in a haplo transplant. Not only the non-myeloablative, but also many myeloablative. One of the most common regimen that is used around the world is a regimen with fludarabine, busulfan, and tiotepa, which actually was proven to be very effective in many high-risk patients with leukemia, MDS, even ALL. And this is actually very common and does not include TBI, which is very important because many centers do not have access to a radiation oncology site and cannot give TBI. Now, this is actually a study that we did years ago on a group of people of patients with sickle cell. And our initial experience was actually that despite the fact that I told you that everybody has a donor in the haplo setting, we face several barriers to the haplotransplant protocol. This is a sickle cell population with major social issues, and some of them have been, so insurance, for example, we're not so sure. We're not covering initially the haplotransplant. Now it's easier. But we had this only to show that actually almost 30% of the patients had DSA, donor-specific antibodies, that prevented them from having a haplotransplant. So it's not as straightforward as we want. Now, PTSI has grown very quickly, and some question that have raised was like, is a haplo donor equal to a matched sibling? Do we have are we confident? Or an unrelated donor? If you have the big question has been always, if your patient is an MDS patient and is 60 years old, his siblings will be kind of his same age, between 50 and 70. So is it better to have a 65 years old matched sibling versus the son of the patient who maybe is 30 years old and is a haploidentical? And this question has been going on back and forth for a while, and I'll show you some of the data that were developed. Is a one antigen or unrelated donor better, worse, or equal to a haplodonor? And the other thing, actually more important, especially in patients in countries with low resources, what the cost is. The cost of the timing of the cost of the haplotransplant can be the defining elements to make your decision. The timing is because the donor is already there, and the cost is much, much less than than unrelated transplant. Johns Hopkins, a few years ago, published a paper showing that in their series, the age of the donor was a key factor in the outcome of their non-myeloablative transplant, no matter what the age of the patient was. You see these three columns, the recipient, young recipient, recipient 46 to 65 and above 65, and the blue line is the young donor below age 30. In every quadrant, you see there's an increased survival of patients if the donor was less than 30 years old. There's a recent paper that analyzed in the registry over 10,000 patients, and they selected, looking at, the question was, if your patient is 50 years old or older, and you have donors that are matched siblings 60 years old, unrelated haplo, or mismatched unrelated, younger donors. And what is the outcome in these groups? So they picked the PCSI patients, of course. These are all post-transplant cyclophosphamide. There are about 4,000 patients analyzed. And this is the answer, the paper report, the data that was shown. If you look at the overall survival, 5 years overall survival. 5 years of survival, the METS donor, against METS donor 60 years of age, the survival is not significantly different compared to a younger haplo, younger unrelated, or younger mismatch unrelated. It was almost significant with the unrelated, young unrelated, but when they compare the unrelated versus the haplo, there was a small difference in favor of the match unrelated versus the haplo. The same difference actually was seen in disease-free survival. No difference between the match sibling and the haplo, but a younger haplo donor and a younger unrelated donor is the best option for the patient. And that's related to the difference was mostly because of non-transplant related mortality. No difference in relapse. And these are the survival curves that reflect in 5 years the difference. You see actually that, I don't have a pointer, but the bottom right is a relapse survival curve that the matched sibling seems to have a tend to be a higher relapse, but is not significant. These are retrospective data, so they have some, of course, they're not perfect, and they should be validated in a prospective study, but it's 4,000 patients. No difference, surprisingly, in GVHD. So the graft-versus-host disease did not differ in any combination of haplo, mismatch unrelated, unrelated, or matched sibling. Chronic and acute. So, as a sort of summary of this presentation, like, if we looked for a donor for your patient in a low-resource country, if you have a match-related donor, which is 20-25% of your option, you can use peripheral blood stem cells. The timing is easy because you have the patient and the donor available. It doesn't cost as much. You don't have to worry about donor-specific antibodies between matched siblings. We don't test for donor-specific antibodies. We have to check for CMV and age, and of course, we didn't talk about the donor's sex, but male donors are always better. In a haplo setting, easy to find a donor. There's sabotage here. You can use peripheral blood.
Sir, would you turn off the echo? You can use this one. Is it?
The cost of a haplo transplant is, can you hear me?
Deep apologies for the technical issues.
Thank you, Dr. Rondelli. For our next conference, we want to welcome Dr. Nina Worrell from Austria. She's going to talk us about the donor safety.
Thank you.
Thank you.
and we hope it goes smoothly.
So, nothing.
Poner los
could I get
slides, por
my
favor?
slides, please?
Gracias.
Thank you. That's. But,
Is it yours?
yeah, but this is. Okay, thank you. So I will now talk about the donor safety. So I will come from the other side, maybe. So why do we need donor safety? Because we know that donation is generally safe, but unfortunately also deaths in donors have occurred. And there is no direct physical benefit for the donor to donate. But without our volunteer and related donors, we could not perform the transplant at all. And as we heard, more and more younger donors and also minor donors are donating, and the donors really need the confidence that we put their safety first. Sorry. So these are the reported fatal events globally, coming from the EBMT published by Jörg Halter in 2009, where we had 5 deaths recorded. From the US, Mary Horowitz reported 3 of 9 fatal events which have been seen. There was 1 in the Japanese society, 2 in South America, whereas 1 was really a tragic one in Chile, where a very small child, 4 years of age, was donating on a apheresis device for his sibling, and after 2 times approach to collect the cells, they did a misplacement of the line and the patient died during the collection. And the WMDA also reported in an alert 3 donor deaths, bone marrow and peripheral blood stem cells. So there are also serious adverse events. This is a large study from the National Marrow Donor Program. The earlier one covering the bone marrow donations, more than 8,000. And they reported approximately 4% of severe adverse events, which mainly are mechanical injury due to the collection site, bone or nerve. It's anesthesia and infection problems, but also seizures and also deep venous thrombosis, which has often or more often occurring in peripheral blood stem cell donation, but the total percentage of adverse events is much lower in peripheral blood stem cells, but you have also those CVC complications, which is really an important thing to consider before you clear a donor. Hospitalizations and other adverse events covers splenic rupture, which has been also touched by Yoshi on the FACJC workshop on Wednesday, and intracranial bleeding due to low platelet counts after the collection. We have published on behalf of the WBMT, together with experts from the EBMT, the CIBMTR, the National Marrow Donor Program, and the WMDA, suitability criteria for related and unrelated hematopoietic stem cell donors. And this was done to support decision-making, to minimize the medical risk to donors, but also to protect recipients, for example, from transmissible diseases. We have a very comprehensive supplementary material, a list which has been updated from a previous publication, and this includes now also clonal hematopoiesis, communicable diseases, and the reporting of severe end product events and adverse reactions, and also the need for donor outcome registries. And there are also additional sources published by the WMDA, that's the Donor Medical Suitability Working Group, who has published this. And it's on the homepage of the WMDA. You can look for different diseases and how to, whether you could clear a donor or not. So what you need, of course, when you are dealing with donors is that you need standard operating procedures for the donor workup and the collection for bone marrow and peripheral blood stem cells, and this has also to include informed consent. And there it's really very important that the donor knows when he withdraws the consent at a certain stage, when the patient already started with the conditioning regimen, that this is really harmful for the patient. So it should not make pressure, but they should really know what they are consenting when they consent. We do have the FACT-JC standards, which are more from the quality side. And what is here very clearly defined is that you have to assess the donor health under the supervision of a physician who is not directly involved in the patient treatment, because this causes bias. So this divided responsibility is really important. We have this established in our hospital, and this works perfectly. But you need also someone who is experienced in the collection procedure. So just send him to a general practitioner would not make sense, because they have not really an idea what bone marrow collection is or an apheresis procedure. In Europe, we also do have the European Directorate of Quality in Medicine, and there we are working on different guides for the organ donation, but also for tissue and cell donation collection, like the substances of human origin. And here is a specific chapter for the hematopoietic stem cell, and this also deals with the clearance of the donor, what you should check, when you should check, how to deal with side effects, and also how to do biovigilance and the evaluation process. And not to forget that we are really encouraged to establish a donor follow-up system in our centers. And recently, the Latin American BMT group is also finalizing recommendations for related HPC donors, and I think this will be published later this year, hopefully. What is the difference between related and unrelated donors? So that's first the age. Unrelated donors are mainly between 18 and 55 years. Some registries allow donations up to 60 years. Related donors can be from a few months to more than 70 years of age. You have a more restricted dosage of GCSF, so you would not expose an unrelated donor to more than 10 to 12 microgram per kilogram, but that can easily happen if you have unrelated donors who do not mobilize properly. Then a lot of people increase GCSF doses. Also, the number of donation is different. It's more regulated in registry donors, like maximum of 2 donations in a row, where it is maybe unlimited in the related setting. Using new mobilization approaches is more conservatively used in unrelated donors, but more liberally in related donors when it comes to binding inhibitors, for example. The donor motivation is also different. You have the altruistic donors in the registries, but you have more the emotional relationship in the families, of course. So there is a higher pressure to donate for this recipient. And also the medical clearance is in the registries is really completely independent from the treatment side, what is not the case as mentioned before, and there's a possible overlap with the patient care team. And it's also a problem that if a donor is not suitable due to, I say, an infection, this will be communicated in the family, and this also causes a severe problem sometimes. So what are the considerations for related donors now? So there is experience in handling related donors is low in some centers, so especially when you start with your new program, maybe you should discuss donor clearance with other centers who have more experience already, because those related donors are more likely to be cleared despite they have maybe medical conditions. This could be cardiovascular or endocrine conditions, especially in elderly donors. And related donors are also more likely to experience adverse events and have a slower recovery in that setting. And this is really published, and a lot of those publications come from the National Marrow Donor Program. And as mentioned before, we have some donor deaths which have been reported. So for that, it's really important to consider the donors properly. In comorbidities, you have to quantify the risk because donation is not 100% safe. We unfortunately do not have a lot of evidence because all those evidence we have is extrapolated from patients and they are dealt differently. So we do have no possibility to measure if a donor with a coexisting medical condition will have a better or a more less good experience in donating because we do not measure this at the start of the donation and retrospectively then thereafter. related donors are more likely to be cleared despite these existing problems. And so if you are unsure, always better to stay on the side of caution and look maybe for another donor if possible. The best, and this is also what you have to consider, is to exclude a donor before typing for HLA if there are any conditions, because if you have then a condition like a myocardial infarction 1 year before the donation, but he's the only suitable donor, it will cause really high pressure to use this donor, and this is maybe not the best. And for unrelated donors, for registry, of course, it makes sense not to recruit, because then you have him in the registry, and then when you want to take this donor and he's not available due to medical conditions, then you start again with searching. The exclusions for a donor may be either absolute or qualified, like cancer or asthma. They can be also time-dependent. In a new diagnosed hypertension, when the hypertension is under control, of course, he can donate. Could also be route-specific, like bone marrow, when they have problems with their spine or gout, they would maybe not donate peripheral blood stem cells. There are factors predictive for experiencing more adverse events and a longer time for recovery, and these are female donors per se, who have experienced more adverse events by donating either peripheral blood stem cells or bone marrow. These are the related donors. These are elderly donors. They have more persistent pain, but also they mobilize less cells, so they need maybe more collection procedures, longer collection procedures. They will then have higher volume to be processed. They will lose more platelet counts after pheresis, so this is an addition of problems. Donors with a higher body mass index may also achieve more pain, especially when you have a bone marrow collection in those donors, because there is a lot of tissue you have to puncture before you come to the bones. The regional anesthesia or longer harvest procedures also are associated with more complications. And if donors have a lower score of quality of life pre-donation, this will not change after donation. We heard that haploidentical donors are more and more recognized because of the expanded use and the good outcome, comparable outcome with the matched unrelated donors. And what I looked for is a recent paper from Sebastian publishing the WBMT experience, and here you see how the increase in the family HLA non-identical donors is, which is depicted in orange. And when we compare this to our EBMT data in the Latin American region, 82% of the donors are related donors, so as they are also maybe more affordable. And in the EBMT or in the centers reporting to the EBMT, it's only 44%. So what are the reasons? So that's either first the financial burden that influences also the selection process, and haploidentical is cheaper. That's what Ricard also already said. In the haplo setting, you also focus on age, but the question is whether it is ethical to use a minor haplo donor if you have an HLA identical related donor who is the same age or older. What degree of increase in medical risk raises red flags in minors? This is also what we have to consider. There are no clear data available in minors with respect to comorbidities and risk of donation. And what about multiple risks like obese teenagers with diabetes? So this is also something you have to consider. The ethical issues in pediatric patients are, and this is really would not be possible in some of the European countries, that you go to minors to donate for their parents, because this is really an emotional and a financial dependency to the one. So the question is whether true informed consent can be given in these donors. There are also factors with increased risk, and this has been published by Galen Switzer, who is working a lot in this field, that donation at very young age, and that when you donate high volumes of bone marrow compared to the body size, they have really more problems and pain. And interesting was an outcome analysis of the youngest donors below 7 years of age, where the parents thought that this was the best the child could do, but for the child it was the worst thing it has done, because all the focus was only on the recipient and they were prone to a lot of pain and problems. So this is also what you have to consider. And there is a significant decrease in quality of life after donation in the youngest children. So this brings me to the outcome registries for stem cell donors. So there is information on short-term, but not on long-term outcomes. So we do need this. The reliable information on frequent early events and reactions associated with the donation are lacking, especially for the minor population. And we have looked this up also in the EBMT registry, where very few minor donors are reported, unfortunately. Most data are available for matched unrelated donors, but also only in the short term. So they follow up this on a regular basis until 1 year, but then you don't have any data anymore. The recommendations for a minimum data set have been already published by Jörg Halter in 2013 under the auspices of the WBMT. And since 2013, we do have a donor outcome registry incorporated in the EBMT patient outcome registry. This is voluntarily to be used and unfortunately covers only 5% so far of the donors, but it would be possible to also include unrelated donors there. And as a summary or conclusion, donor safety has been recognized as an important issue, of course, and despite the mobilization and donation are really safe procedures and are done very often globally, serious or fatal events are rare, but they may be present, and especially late effects may only be detected if you have a large amount of data. We do have international quality standards published by FACT-JC, and they already provide examples and guidance how to handle related and unrelated donors. Related donors are different to unrelated donors, so they would often not qualify as an unrelated donor due to age or comorbidities. And to ensure donor safety in short and long term, we need outcome registries like the EBMT registry or at least a national registry. And with these thoughts, I want to thank you for your attention.
Thank you very much, Nina. If you want to stay here, and would it be possible to put Dr. Codera's video while we invite Dr. Rondelli and Dr. Oscar to come up here, and Daniele from Brazil. Thank you so much, Daniele.
Sorry to interrupt. I'm just going to
Redon.
take a minute to make an announcement. I would like to sincerely apologize for the inconvenience we had some minutes ago. It seems to be the Zoom call got a little bit of a hacker attack, and they were spamming their microphones despite our controls over the Zoom call. And that's the noise that you heard. It was a mic spamming. We couldn't shut that. We couldn't shut the audio for them. It has already been handled, and I again offer my sincerest apologies and hope we can move past that and continue with our lectures. Thank you very much.
Thank you, sir. Thank you. Dr. Codera, we are seeing you. Thank you. Yeah, we can hear you. Would you like to say something to us?
Thank you, Adriana and Luis. Dear colleagues of Panama and Latin America, before my talk, I express my deep sympathy to the people of Venezuela under the disaster. I hope the daily lives will be recovered as soon as possible. Now, recently there are several modalities to choose donors. But to get the long-term sufficient outcomes for patients, HLA well-matched young donors are desirable. At the current one-haplo mismatch transplant among family members, donors may be senior, especially at the case of parent-to-child transplant, resulting probable unfavorable outcomes of patients and possible severe adverse event at donors. Because of that, I recommend to develop your blood and marrow donor bank
Where is Reggie?
further
Reggie.
by recruiting especially young donors. Now, only such a volunteer donors, but also for family donors to keep donors' safety is critical. In the past, several mortality cases were reported. Such an event deals severe damage to the development of HSCP. I propose to make a system for the immediate report of several events of donors if it happens, open the outcomes, and share the information with other teams not to repeat the same event. Vigilance and surveillance is a word which WHO sometimes uses for organ transplantation to avoid organ trafficking and transplant tourism. But I say it is also true in hematopoietic cell transplantation by another means.
Maria Benzo.
Thank you for your kind attention.
Maria Benzo. Thank you, Dr. Codera. And I'm sorry, I'd like to ask Reggie to come in here. Reggie Melkin, yeah, you are in the panel, and Dr. Alejandro Vernaza, and we'll be standing there. So if you have questions, would you raise your hand? And no, we will give her a seat. You're important. Sit down. No, it's fine. And thank you. Doesn't matter. Or giving the chairs to them. Yeah, that's fine. So for those who are not used to marrow donation, I would ask Nina if we would explain to people what they go through and what do we do for replacement of blood, how to be careful with anemia and pain, just the simple things.
Yeah, so for bone marrow collection, you have several recommendations. So you should.
Presentation.
Another one?
Yes, I need it because Panama is the only place with one national laboratory. So it's a message.
Oh, all right.
Will be fine? Yes, okay, please. I need to present something about the Panama laboratory, the only one laboratory that we have in Panama. It's important.
Yes. And do you have slides up there?
Yes, yes, yes.
And are they putting it up?
Yes.
Would you be so kind?
See.
Would it be possible to put the slides, to put his slides
Professor
up?
Bernaza slides, I gave it. Sí,
Would you,
es
please?
importante que hablemos de lo de nosotros.
That's yours.
That's me,
Go,
that's
go,
mine,
go
yes.
ahead, we'll listen to
Okay.
you. Go ahead.
I'm sorry, but I need to talk about our transplant laboratory in Panama. It's a country in which we have only one transplant laboratory for all the transplant procedures.
Too fast. Just.
Okay, go back, go back, go back.
I can give you the slides if you want.
Okay.
Goldilocks speed.
I am an immunologist, but I am a lawyer too. So for me, it's important to talk about the principles. The practice of organ tissue or cell transplantation in the Republic of Panama is carried out in strict adherence to ethical standards. It is based on the principles of altruism, equity, justice, solidarity, voluntariness, its non-profit nature, confidentially, and is executed without distinction of any kind. Which is the quality positive of our National Transplant Laboratory. The National Transplant is responsibility for performing this compatibility storing necessary to execute anatomical components transplant from renal, liver, heart, and bone marrow transplant. The laboratory continues to improve its quality management system, focusing on the specialized and professional care equipment with the most advanced state-of-the-art technology. This guarantee timely, reliably, and accurate results committed to the Panamanian population, while ensuring top-tier quality and compliance with all institutional requirements and current legislation. Here is our process map. In the first, we have the requisites of the patient. In the last, the patient satisfaction, and all the key process for performing the pre-analytical, the analytical, and the post-analytical, and the strategic process, manager direction, administration, ASHI and AFI quality, one of the most important points, the ASHI quality control, the biosecurity, technology, shopping, hygiene, resource, and maintenance. Evolution of transplant in Panama. The National Laboratory of Panama starts in 1973, 8 years after the cytotoxicity test. And then we performed in 1990 the first living donor renal transplant. In 1998, the first deceased donor renal transplant. In 200, we performed the hematopoietic organ, first identical hematopoietic stem cell transplant. In 211, the first liver transplant. In 212, haploidentical transplant introduced. In 216, the first successful heart transplant. And in 219, first unrelated donor transplant. So, our laboratory is responsible for all the procedures of all the transplants. So by that reason, it's necessary to our laboratory to have the best technology to be agreed with all the transplants. Okay. Okay. Now, the different process, the different factors, the most important, HLA matching. This is one of the most important points of our laboratory. And then we follow some donor selection algorithm. The phase 1, initial evaluation and family screening. The phase 2, baseline immunological and genetic testing, including SOSP first, and then the blood group classification. And then we determine using high resolution, NGS for the tissue typing. And then in advanced biological, we perform. For us, it's important the immunological tolerance of the patient and the donor. By that results, we are using all the NEMA, NEMA, we use it for the immunological tolerance in the haploidentical transplant. But now, we perform the analysis of class 1 and class 2. We determine all the antibodies which has the recipients, and we determine by LSA, and we perform all the cross-matching. The virtual cross-matching and the real cross-matching we perform in all the kind of transplant. And the important is to reduce reaction, graft success, and graft versus host prevention. This is the algorithms. We follow the algorithms in all our transplant. Look at that. We first try to identify the donor identical, then the haploidentical, and then with non-related donor. We follow all of them and finishing. This is for the haploidentical. We have the algorithm. We have to follow it. It is right, and we have to do what is right in haploidentical. This is in the donor structure of the haploidentical. This is what we follow in our laboratory to bring to the medical doctor all the information. And then we have a list of unrelated donors. 870 persons told me, yes, if you need my blood for an unrelated donor, being an unrelated donor, I will give you the blood. By that reason, we perform 2 of unrelated donors in our country. Haploidentical donor, IMA. We use the HLA matchmaker too to determine the epitopes of the against the donor has antibodies. I'm finishing. And we use the HLA registry for determining for class A, B, C, the RB, etc. And then we used to the KIRK, evidentemente the KIRK for the donor, you know, and we determine if it's neutral, is better, or is the best. But one of the most important items with this, who said that we are exact in our procedure? We are exact in our procedures because we are involved in the ASHI, external quality control, from 2003 and now at the present. And then we are involved too in all the procedure in which MASHI has the control. In the future, we want to have the EFI control, quality control too, to be sure that we are giving to our medical doctor all the true information that they need for the best chance of the donor. Thank you.
Thank you. Thank you very much. We are sure Panama is very proud. Thank you very much. Excellent. Thank you so much. All right.
Expand for 10 minutes or so.
Daniele Oliveira, you can come back, Reggie. So 5 minutes. All right. I think it's the years. Would you talk to us about bone marrow donation, Nina, since we, very briefly. Edeyo?
Yeah. So bone marrow donation, you have to consider first, of course, the hemoglobin content of the donor and maybe give iron supplementation already in advance. You should not collect more than 20 milliliters per kilogram body weight of bone marrow. You should use several puncture sites and don't collect too much in one aspiration, of course. There is a problem with the collection kits, so I'm not sure whether you have ones available. We have now we are now using Mako Pharma, just phlebotomy bags, because they have a scale, and you can connect a log syringe, and they are wrapped, that you can use this in the operation theater, and it's sterile, that's good. We use ACDA in combination with heparin, put it in the bag, and then we just flush the line at the end of the collection. And we also validated the scale with the volume, just to see when you put it on the line and you see the volume, that you not end up with too much or too less. And we have also a calculation how many cells are in 1 milliliter of bone marrow. So we do a lot of collections, approximately 20 a year, so it's not a lot, but it's a lot because we collect from a registry. And then you can calculate also how many cells or volume you need for a recipient, but always have the donor in mind. And if the hemoglobin level is low, maybe do not use really the 20 ml, because then you will drop the hemoglobin in the donor below a certain number. And yeah, pain, of course, is not that issue. Afterwards, it's if you use pain relievers, it's fine. What our anesthesiologists always ask, if they could give steroids during the collection, because that's better to avoid nausea afterwards. But we ask them to do this after we end it, because otherwise you maybe end up with a lot of neutrophils in the product. So that would be my recommendations. And you have also then inline filtration, because there are transfusion filters which are not only with the spike, they are also inline, so you can use a sterile connecting device to connect the bag with the filter without spiking it, and then you can very easily filtrate the product.
Thank you, Nina, very much. Amado? Would you get him the microphone? Thank you. Dr. Cardus from Colombia.
Thank you. My question is for Dr. Rondelli. Now, you know, it's a tendency to decrease the dose of cyclophosphamide, maybe without a strong scientific evidence. What is your opinion to decrease the dose from 50 to 40 to 25? What is your opinion regarding that one?
the major side effects of high-dose cyclophosphamide is a possible cardiac toxicity. So there are multiple clinical trials being done as we speak on reducing the dose by 50%, by 70%. I strongly believe, and I hear a lot of people asking, can we decrease because the patient has comorbidities? I think we must rely on clinical trials, on prospective studies, because there is also evidence that when you cut the dose of cyclophosphamide, you increase the risk of GVHD. This is well known. There's a study done in Europe, in France, where they tested a lower dose, a 70% reduction of cyclophosphamide in elderly patients receiving a reduced intensity conditioning regimen by adding a small dose of ATG to the conditioning regimen. And then that data actually was quite encouraging. It's not a randomized study, but I think it makes sense but you're going to pay for it. So if you decrease the cyclophosphamide, it's safe, but you may have a higher risk of GVHD. So adding small dose of TG or modifying other protocols, I do not recommend. It's very easy to make it up. People say, well, I have a patient who did well with the 25 milligrams instead of 50. I think it's a risk that we are all taking. I urge people to rely on clinical trials.
Thank you.
Thank you. Can I ask to Dr. Daniela Oliveira, how do you start the research for related donor in your country?
Or here.
Or here if we want to look forward. Como quer procurar no registro, pode? Exacto.
Sorry, I got that. We are, I'm here on behalf of the Brazilian Registry, REDOM. I suppose that some of you, I hope that many of you know REDOM. And we have worked for more than 30 years and on a routine basis. So it means that we are open for other registries. But as I explained yesterday to Adriana, we work to assure that the donation is safe for donors and patients. And one of the conditions to make this is to keep this relation among registries. What does it mean? It means that, for instance, if a physician from Panama needs a Brazilian donor, our recommendation is to try to keep this communication between organizations. We don't give direct feedback to patients. Sometimes we can give information to physicians, but on a safety perspective, we have to try to reinforce the role of organizations, and that's why the registries, they are important.
So the Panamanian registry should be asking REDOMI for the search?
Yeah.
Perfect.
So we know that some countries, they don't have like a formal registry. And when it happens, we also have an internal procedure to keep this communication. And 4 years ago, we achieved the WMDA accreditation, and one of the standards is exactly to do this way.
Thank you so much, Daniele. We have a question in the back. Would you please tell your name?
Yeah, it's Marlene Chavez from Costa Rica. I have two questions. One of these, when is the best performed pre-transplant antibody screening? When is the best time? And what is the view on selecting a donor with a lower HLD compatibility in the context of high risk of leukemia? This question is related with the last WBMT French group show in the presentation a logarithm of Chinese group. They explore how choose the HLA with less, not too less, but some mismatches. As a tool to leukemias of high risk. And the third is, can we reject a donor for conflicts in the family, not direct the donor, but sometimes the donor say yes, but the wife or the husband have conflicts with the patient?
Yeah, well, the third one I can answer, yes, it can be rejection, but so let's say comprendido. Primero, ¿en qué momento hacer la pesquisa de anticuerpos antidonante? At what time to do the
Okay. So
the period,
actually,
yeah.
we discussed this a lot at the NMDB, and the guideline and the policy recommends doing it on initial evaluation with the understanding that it needs to be updated if the time of transplant takes longer than 30 days. So in an ideal world, you do not proceed to transplant with the antibody testing results that are longer than 30 days. And that's not taking into account patients who receive a lot of transfusions. If patient is receiving a lot of transfusions, then we need to test them 2 to 3 weeks after the last transfusion. And if patient is transfusion dependent, they are receiving all the time until time of transplant, then for these patients, we try to get testing at day -7 and day -3.
And if I can add one thing, there are patients who actually have a titer that we do it at the beginning, when we type the donors, but you see a titer that actually is borderline, or it's not 0, it's not 5,000, maybe like 1,000, or so you need to monitor that to see, because it's going to, in the month it takes to get to the transplant, it could spike up to very high, or it could be lower. So that makes a big difference. So you have to know it in advance and repeat it.
And how to pick that donor? There is a website that we'll get from Dr. Rondelli and give it to you. And the last question, please, Dr. Niederwieser.
It's rather a comment. I would be very careful. I am not against haploidentical transplant.
Good.
But if you have possibilities to have HLA identical donor, use the HLA identical donor. The reason is that by killing not only the alloreactive T cells in the graft, you are killing also the T cells which are reactive against viruses and against other things, which can be transmitted from the donor to the recipient. And I don't think that's a problem in Chicago, because they have a very, very good virology, they have a very good treatment, they have everything. But in developing country, you have to make sure that this happens. You know, you can use both, of course, but you have to realize that you need a very sophisticated laboratory behind you.
Thank you very much. So for everyone to understand, Dr. Niederwieser is raising the issue of viral infections after haploidentical transplant, because it happens very often and they can be very dangerous, so we have to pay attention to it. So with that, I thank you very much, all the panelists. Thank you very much. You'll have to move on. Thank you.
Now, we are going to continue with Session 8, Emerging Infectious Diseases, with chairpersons John Snowden and Ana Belén Araúz. We invite you both to come up the stairs.
Hi, good morning. For us, it's a pleasure to introduce you to the session of emerging infectious diseases. I'm Dr. Ana Belén Araúz, infectious diseases from Panama, and I co-chair with Dr. John Snowden from UK. So for our first talk, we have Dr. Clarice Machado from Brazil, and she, via Zoom, and she's going to talk to us about emerging viral infections related to dengue, Zika, chikungunya, yellow fever. Welcome, Dr. Clarice.
Hello, everybody. Thank you for the invitation for this nice workshop. And my task today is to talk about the emerging viral infections that are especially in the Americas we have today. These are my disclosures. And I prepared a small agenda. Clarice, sorry, hi dear. Adriana, we are not seeing your slide in presentation mode, so it's not moving. No. It's the small way. I don't know if you want to unshare, put in presentation, then share again. Zoom is tricky. We are still seeing the small ones. Then, colocar no seu computador já em modo apresentação. E aí pedir para share já grandão.
Hi, I'm Dr. Castillo. I'm going to be helping you a little bit. On the bottom side of your screen in the Zoom call, there's going to be a rectangle with an arrow that says share. Besides that rectangle is a little bit of an arrow pointing up. You need to click it and then select the whole screen. When you select the whole screen, then when you share it and put it in presentation mode, then we can see it as a presentation. Now, on the right side of your screen, that one. There. Now, on the upper side, it says exhibir configurações. I just butchered that. To the right? The next one to the right? The middle one? Now, the first option. Alternar. Thank you very much.
Thank you, Clarice. Thank you. Well, hope it works now. Is it moving? Yes.
Yes, it is. Yes, it is.
Okay. So these are the relevant arboviral infections that we have to worry about, especially in the Americas. Dengue, Zika, chikungunya, West Nile, and yellow fever. And dengue, Zika, and chikungunya are the most important because they are more frequent. And as I can show here, in 2024, we had a huge increase in the incidence of reported cases of dengue. In comparison to the year before, we had a more than 6-time increase, and it was due to a huge epidemic in Brazil. And besides these viruses, other protagonist is the mosquitoes. So we have the Aedes, the general Aedes for the dengue, Zika, chikungunya, and also for yellow fever in some places, and also the hemagolus. So where we have mosquito, we have problems. And these are the areas in the world about where we have Aedes and transmission of dengue, Zika, chikungunya, and yellow fever. You can see the blue zones we have the transmission of the 3 viruses, dengue, Zika, and chikungunya. The green, 2
two of the three viruses, the pink only chikungunya and the purple only dengue. So we have the spread of the mosquito in all over the world and in tropical countries where we have the infection, we have the people are at risk. So besides the mosquito, we had also other modes of transmission like transfusion and also organ transplantation. So who is at risk to acquiring these infections? The transplant candidates, recipients, and donors who live in these regions or who travel to endemic areas. Also, candidates, recipients, and donors who receive blood transfusions in such regions for any reason, and all stem cell transplant candidates, recipients, and donors who are we have a few reports of non-vector transmission in stem cell transplantation. Of course, vector transmission in endemic countries is the most important mode of transmission. But we have several reports of graft transmission of dengue, and also for Zika and dengue transmission by platelet transfusion. So, so far we don't have any report of Zika and chikungunya transmission by the graft. But we have one report of yellow fever transmission by the graft. 24 months after transplantation, and patients without GVHD and without the use of any immunosuppressive drugs. But they are not completely contraindicated in these situations. Have to fulfill these criteria to receive the vaccines. Two dengue vaccines we have currently in Brazil, Qdenga and Dengue Vaxia. Dengue Vaxia only for patients who are seropositive to dengue can receive this vaccine. Qdenga doesn't matter the previous exposure. And chikungunya is only one dose vaccine. We have no data of the safety and efficacy of these vaccines in stem cell transplant patients so far. We are planning a prospective study soon. What we have observed concern to live attenuated vaccines, the low compliance to these vaccines, especially in autologous transplant patients. It seems that autologous patient doesn't need to be revaccinated. What is not true. They need to be revaccinated. In this study, we observed that we analyzed the measles and yellow fever vaccines, and you can see here, only 21% of the patients, allogeneic patients, had been vaccinated, and 50% of the patients had received the yellow fever vaccine. Not only the allogeneic, all the patients. And when we analyze the variables associated with the compliance to vaccination, you can see that for measles, allogeneic patients received more measles vaccine than autologous transplant patients. And of course, time from transplantation was a risk, a variable associated with compliance to vaccination, because physicians believe that as far as they are far from the transplant, they have better immune reconstitution and then they will respond better. What is completely comprehensible, but the patients don't need to wait 5 years to be revaccinated if they are okay. So we have to pay attention to this compliance to the vaccines, especially showing the study that the autologous were less vaccinated than the allogeneic. So how to handle? Pre-transplant evaluation. We have to checklist investigate symptoms in the previous 30 days, recent travels, exposure to outbreaks, and transfusions in endemic areas. So this is a part of the pre-transplant evaluation, especially during outbreaks. Also, we have to check if donors or candidates have recently received live-attenuated vaccines. So this pre-transplant evaluation will guide you to monitor to the deferral policies in case of a suspect exposure, and also to treat in case of needed these infections. So when we diagnose any arboviral infection, the first step is to classify concerning to severity, because this will guide you how to manage these infections. The World Health Organization defines severe arboviral disease, who are the patients who require hospitalization, including the presence of warning signs and complications. The warning signs are abdominal pain, vomiting, effusions like ascites or pleural effusions, mucosal bleeding, lethargy, hepatomegaly, or hemoconcentration with platelet decline. And severe disease is defined by plasma leakage, shock, severe bleeding, or organ failure. So Non-severe are patients without these characteristics of severe these illnesses or warning signs, and these patients can be treated on an outpatient basis. Non-severe diseases can be, hydration is the key for the treatment of arboviral diseases, but non-severe disease, they can receive oral hydration and treated symptomatic drugs only for pain or fever. Avoid non-steroidal anti-inflammatory drugs. Avoid systemic corticosteroids unless the patient is already receiving due to graft-versus-host disease. And transfusions of platelet as needed. Severe diseases, you have to do intravenous rehydration, prefer crystalloid over colloid, platelet transfusion, the same, avoid non-steroid anti-inflammatory drugs, avoid systemic corticosteroids and immunoglobulins because of absence of evidence of benefit. There's studies showing that there's no benefit in use them. Of course, in transplant population, in case of graft-versus-host disease, the patient is already using corticosteroids, you have to keep them. It's also important to remember that children can have more complications and they have a tendency to abrupt circulatory decompensation, so they need more close assistance and care. And concerning to postponing donation in the case of you have situations of a donor with dengue, for instance, or chikungunya or other arbovirus. If the donor has a confirmed or suspected dengue, or had a febrile illness in endemic area or during epidemics, the deferral period should be at least 4 weeks after resolution of the symptoms. In case of diagnosed dengue and the donor had severe dengue, the recommendation is 180 days, 6 months after cure. And if the donor had received the dengue vaccine, wait 4 weeks for donation. In the case of chikungunya vaccine and yellow fever vaccine, is also the same period, 4 weeks after vaccination. The referral period for chikungunya, at least 4 weeks after symptom resolution, and Zika, the period varies and there's not a consensus about the time, and many authors recommend from 30 to 180 days. And finally, what we have to worry, remember that investigation of the epidemiological risk is mandatory in endemic areas and also during travels. If the patient or the donor had traveled to an endemic area, we have due to the similarity of the symptoms and the clinical manifestations, we have to have a high index of suspicion. It's a flu-like syndrome. Concern to severity, dengue and yellow fever seem to be more severe than Zika and chikungunya in stem cell transplant recipients, and also with higher mortality rates. Concerning to immunosuppression, there is no evidence of benefit of decreased immunosuppression if the patient had an arboviral infection, if they are taking immunosuppression to control GvHD. You have to handle this very carefully, and if you want to decrease, do it with wisdom to not provoke a GvHD flare. Asymptomatic cases and the lack of serology specificity hinder the implementation of safety measures in blood banks and stem cell donation. So we don't have a restrict policy to this. We have just to be aware of the problem and, if possible, to test. And also, I would like to remind you about the compliance with live attenuated vaccines following in stem cell transplantation, especially in autologous transplant patients, that they can be vaccinated and they should be vaccinated. So, and I finish here. Thank you.
Further discussions with the panel, and I think Professor Machado, you can stay, can you, for the discussion? Or was she recorded, or? I think you heard me the first time. Mauricio, thank you. Okay. Are we all good to go? Okay, thank you, Professor Beltran from PAHO.
Thank you. Thank you. Good morning. Good morning, everyone. Can you see my screen?
Yes, Dr. Beltran, we can see it. Just a thing. You need to display settings and then change it, please. Swap it. Yeah, thank you very much.
Okay.
Now we can see it in presentation mode. You can start right now.
Thank you for inviting me to this panel. I will share an overview of Chagas disease in the context of hematopoietic cell transplantation. Focusing in the three key areas: screening, surveillance, and early detection or reactivation. I will begin with a brief overview of the epidemiologic Chagas disease, and then discuss implication on transplantation, and finally review the current situation approach to monitoring and detection reactivation. Sorry, I have a problem. Can you see correctly my screen?
right now it's inverted to us. It is on revision mode for us. We can see it, but it's on revision mode. It says Chagas disease remain one of the most important parasitic diseases. It's on revision. You need to swap it for us on the display settings. Up the thing you did before. Okay, now you have stopped sharing your screen.
Mauricio, if it's possible, you can switch on your camera, please.
Yes, can you give me them?
Now you need to share your presentation. You can
Yes,
see.
Now,
Ahorita está cargando.
yes.
Okay, now you need to start the presentation.
Can I see?
Yeah, we can see it, but on revision mode. You need to go up display settings. The round on the middle one, the middle one. This is show taskbar, that one.
Now,
You click on display settings and then the first option that says swap. That one. It's okay.
yeah. That's okay?
Perfect.
Yes.
Sorry, thank you for your patience.
Not a problem.
According to the epidemiological situation, Chagas disease remain one of the most important parasitic disease in the Americas. It is estimated that between 6 or 7 million people worldwide are infected with T. trypanosoma. In addition, 21 countries in the Americas remain endemic for Chagas disease, highlighting its continued public health problem. But significant progress has been achieved through vector control and blood safety interventions. In general, in Latin America and some countries like Caribbean, and the screening for blood donor is 10% that the units 10% in blood donors. However, other routes of transmission persist, including congenital, oral, transplant-associated transmission, and reactivation in immunosuppressed individuals. At the same time, international migration has profoundly changed the epidemiology of the disease. Today, individuals living with Chagas disease can be found in North America, Europe, Asia, Oceania. As a result, in an increasing number of transplant candidates and potential donors are native from areas of risk, making Chagas disease an essential consideration in transplant program. What is the problem associated with the HT? In immunological individuals, chronic infection can remain silent for decades. However, in hematopoietic cell transplant recipients, immunosuppression facilitates parasite replication and increases the disease of reactivation. Recent reviews report that the reactivation incidence is approximately 36% in transplant population. the period of when the immunosuppression is most intense is obviously increase the risk for this reactivation. Although reactivation is less frequent in autologous transplantation, but the risk is not eliminated. Failure to detect reactivation early can lead to significant morbidity and mortality. Primary donor-derived infection is rare, but can cause severe acute disease in previously uninfected recipients. Therefore, screening is necessary. Fortunately, Chagas disease is not frequent in complication. However, when it occurs, it may present with persistent fever, cardiac, and neurological manifestations, or severe systemic disease. The major challenge is the initial reactivation can be completely asymptomatic. Therefore, waiting for symptoms to appear is not an inadequate strategy. It's not an adequate strategy. Now, we know the PCR can detect parasite some weeks before clinical manifestations. This has shifted our approach from the diagnostic established based on disease symptom to activate early detection. Yes, PCR was the principal effort to detect the reactivation. In pre-donation and pre-transplant evaluation Chagas disease, the first step is comprehensive epidemiological assessment for both donors and recipients. We should evaluate country of origin, in this case, birthplace, and living up later years, or recently live in endemic zone, residence or housing condition or exposure. The exposure, for example, are Pito triatomine vectors or Vinchuca, I don't know what is mentioned in this country. Family history, previous history of transfusion and transplant is very important, and other clinical aspect that you suggest Chagas disease. It's very important that the epidemiological risk is not only determined by the origin or birthplace. In this case, this is very important for transplant. HCT is a good epidemiological history, is the most valuable and cost-effective tools to identify donors or individuals at risk. Once epidemiological risk has been identified, appropriate serological screening should be performed. The term recommends is ELISA for T-cruce or a chemiluminescence or AIF. IFA. Ideally, 2 tests is on different principles to confirm the infection. Is applied on all potential donor and recipient and potential donor and recipient with epidemiological risks. A risk assessment and screening result define several risk scenarios. If donor is positive and recipient is negative, transmission, the risk is transmission of T-Cruz, the Chagas. For this reason, is recommended exclude donor in HCT scenario. If a donor is positive and recipient positive, is possible transmission or reactivation, the Chagas disease. Recommend exclude donor and monitoring the recipient. When donor is negative and recipient is positive, the main risk is reactivation during immunosuppression treatment. It recommends serial PCR monitoring. When both negative, minimal risk, recommended standard follow-up. Post-transplantation in patients with confirmed chronic infection or significant epidemiological risk, surveillance should begin before the condition and regimen. This is the start before the monitor, the condition and regimen. Monitoring should continue through periods of intense immunosuppression, followed include regular clinical assessment, parasitological tests when these are available, and serial molecular monitoring using PCR. The objective is not to wait for clinical disease to occur. Rather, it is to identify reactivation during the preclinical phase, when intervention can prevent serious complications. In this regard, PCR plays a role similar to surveillance strategies used for other opportunistic infection in transplant recipients. I invite you to consult this document, this PAHO document on Chagas disease and immunosuppression. Post-HCT surveillance, there are two major categories of learning or two criteria: clinical indicators, unexplained fever, and skin lesion, myocarditis, or neurological manifestation. In laboratory criteria, a positive PCR, positive serial PCR, and or rising parasitemia. In this case, it's recommended to start treatment. It is important to remember that PCR often because positive before symptoms appear. Therefore, any positive molecular result should prompt immediate evaluation and close coordination between the transplant team and the infectious disease team. It's very important to remember that PCR often becomes positive before symptoms appear. About the diagnostic, depend on clinical scenario. In acute infection or reactivation, parasitemia is typical high, making direct parasitological methods or PCR is, in this case, or serial PCR. In this case, PCR is highly effective. In chronic disease, in general, the parasitemia is low, is intermittent. And serology is the best test to this patient. PCR is variable, as I mentioned. This algorithm summarizes the recommended approach. Every transplant receipt should be assessed according to type of transplant, allogenic or autologous. Degree of accumulative suppression, for this case, autologous and allogenic, and present of graft versus host disease, and unexplained febrile episodes or other related symptoms. If PCR remains negative, surveillance should be continued according to the protocol. If PCR is positive, monitoring should be intensified. When evidence of reactivation is confirmed, it's recommended to start treatment. In general, benzonidazole is the first selection to treatment. And the final summary is all donors in HCT candidates with epidemiological risk should be screened. And reactivation risk depends on immunosuppression. Serial PCR detects early reactivation. And reactivation is usually detected by PCR before clinical manifestation. And early treatment reduces morbidity and mortality in the. Thank you so much.
Push this. Yep. Okay. So we're going to ask everybody to come to the stage, but just for 7 minutes because we're about a quarter of an hour or more behind, and we'll have a quick Q&A and discussion. Hopefully, the online speakers can partake in the discussion, but I think we'll get the ball rolling while the colleagues. That's Professor Galeano. Professor Trigoso, Professor Rodriguez, and Professor Frutos all come to the stage. But if anybody's got any questions, any points they want to make, Professor Belen, do you want to add anything more, or just start the discussion? And we'll make the most of 7 minutes. So, yeah. with the right microphone. Give us the...
Which one works? This one?
Yeah.
Okay.
Okay.
Yes, now that we have our panelists here, I think it's really challenging to differentiate this kind of emerging viral infections when we compare to the usual complications of reactivation of viruses post-transplant. What are your opinions about that?
Hello, yes. So it can be very challenging. And as Professor Nieviso was mentioning, you need a specialized lab and you need to think about your epidemiology when it comes to these sort of diseases. For instance, toxoplasmosis. If you look at toxoplasmosis, you have high mortality reported in the literature post-transplant. But if you look at our region, toxoplasmosis is not that deadly, mostly because we think of it early and we treat it earlier, but because we're used to seeing it, so it makes sense that the patient's outcome is better. So that's what you need to keep in mind. And I was also very taken aback by Clarissa's mentioning of cross-reactivity between serologies of these viruses, because they can be very hard to diagnose, especially, for instance, dengue fever. In Paraguay, we have these outbursts of dengue fever constantly. We have 4 serotypes flying around, so you can have it more than once. So then you have any patient that has already had dengue fever, when they have fever again and you don't know why, then you do the serology testing and they have IgG. Well, of course they're going to have IgG. They already had the dengue fever before. But how do you actually know that it's dengue fever? And okay, so for 99% of patients, this viremia will resolve itself and it won't be a problem. But when you have transplant recipients, this can be an issue. What exactly are you treating? What's the disease you're handling? So it can be very tricky, especially with our these diseases that are not that common elsewhere and that don't have very good treatments all in all.
Okay, thank you for your. We only have like 5 more minutes left, so we would like to ask to listen the question from the public.
I'm sorry, it's not a question, it's a commentary. We have bad toxoplasmosis, and we have autopsy works in Brazil showing, from Curitiba, showing that on autopsy we find a lot. The problem is that we don't diagnose because you need to do PCR, and it's not available usually. So it's sepsis that is culture negative. Clarice may correct me if, and now for patients that are positive for toxo, we are using the Bactrim 3 times a week, even throughout the transplant, to avoid reactivation, because it can be very deadly.
Yes, I would like to comment on that, on parasites, moving to parasites instead of viral infections. But yeah, I think we are all aware of toxoplasmosis because it's something that it is frequent around the world. But the incidence of positive serology for toxoplasma is much higher in our country, much more higher. So we are expecting to have much more infections due to toxoplasma, and it's very difficult to detect unless you have a PCR. So patients at high risk should be followed, I think, with PCR, because it's the only way you can detect it. If not, the patient will have fever and will die, and we think it's a sepsis due to a bacteria or anything else. But we are not detecting PCR reactivations in our region, number 1. So then I have to say also that there are other parasites that are very significant for our region. Mauricio talked about the most important one is Chagas disease. But we also have Strongyloides stercoralis, for example. They are all parasites that live within us while we are immunocompetent. And when we receive a transplant and we get immunosuppressed, those parasites can reactivate, can proliferate, and can give a deadly disease, toxoplasmosis, Chagas disease, strongyloides. And for Chagas disease, one aspect that Mauricio mentioned is that the epidemiology is changing absolutely. When we were young in the school, we all knew that the kissing bug, the vinchuca, or the bicho, kissing, in Brazil, this is how do you call it? Kissing bug, the remember. So was the vector, the insect that transmitted the Chagas disease. And that now does not exist almost anymore, for example, in my country, in Uruguay. But transmission is different from blood products, but all blood products are screened now. Also, it's very low, the possibility. But now the transmission is from mother to child. And for example, in my country, we have detected a family with Chagas transmission in 4 different generations. So someone whose mother was from Latin America and moved to live in Utah, in the USA, or in Norway, maybe her grandmother was Chagas positive, and he has the parasite. So the epidemiology of Chagas disease is moving from something that was in rural areas of Latin America and transmitted by the bug, by the kissing bug, to a different epidemiology in which the people is distributed all around the world. So it's not just to make you fear about this, but Barbeiro. So the parasites are extremely important and can be a huge problem.
So any more comments from the other panelists? You might want to just say 1 or 2 words. We have to round off. And anything you want to add to these really fascinating discussions. For those of us from Europe, I think it's a big learning curve that we have to do. But anything you want to add to?
Yes, I think that to sum up, we have a really big challenge, because all of these, even if you have a viral or parasitic infection or bacterial, let's say, they all have similar presentations. So we have to keep in mind the epidemiology of the patient. And here, because we have all of them here, we have to be very meticulous in suspecting these diseases. But most important is the challenge of the diagnostics, because we need PCR in almost all of them, because serology doesn't help us.
Yeah.
Only in the pre-transplant evaluation.
And you need it quick. You don't need it like 2 weeks after.
Yes.
You need it today, kind of thing. Yeah.
And for example, in Panama, we have to send most of these laboratories. For example, for Chagas disease, there's only one center here that does that, which is the Instituto Conmemorativo Gorgas, and usually those tests come back like 7 to 14 days. So
thank you for that. I think that highlights the importance of the general diagnostic supported care. We covered some of that yesterday, in the diagnosis of leukemias, but also really the rapid diagnostics of these tropical diseases, and by the most modern methods.
I think that the nurse's role in all these cases is very, very important as a coordinator. I mean, before the transplant, they have to be aware of the donor or the recipient, if they need to control before, to know if they have been traveling, if they have been received some transfusion. So I think that the role of the nurse coordinator is very, very important in all these things. And after, as Mauricio said, so many times the PCR is positive before the symptoms. So be aware that maybe this patient needs, I don't know, maybe a PCR weekly, and she has to be aware of all these things and coordinate all these things that is needed for all these patients. So I think that nurses here have a very, very important role.
Just to mention on that, if the epidemiology data is suggestive of a high-risk patient, then of course serology must be checked before transplant, and if positive, you need to follow up the patients with PCR. For example, for Chagas disease, there is a strict protocol on which times you have to follow the patient. While they are on high immunosuppressants, you have to follow them with PCR weekly, because if you wait for a parasite to appear in the blood, morphologically, this is too late. You need to detect it before with PCR. But another, very quickly, a problem is that serology, maybe Clarice, if she's online, can tell us about. Serology can be, in highly immunosuppressed recipients, can be negative, even in patients that are carrier of those parasites. So this is something that we need to consider also. And sometimes in highly endemic countries, we need to treat patients without having the data that if he's positive or not. For example, for strongyloides, it's better to give 2 doses of ivermectin than to have the risk of a reactivation. And maybe Adriana can tell us what they do for other parasites, because we have Giardia, we have a lot of things.
I think we just have to round off, because from the EBMT point of view, we're very interested in this area, and we're looking into collaborating with WBMT. Dietger and Mickey are really proactive. We've got there's a lot of interest, because the world is a very moving small place, and donors and patients are moving around to European environments. But we're on a steep learning curve, so we're looking at this area of neglected tropical diseases, other tropical diseases. So we're very interested. We'd love to engage in our survey that we're going to launch in coming months. So, and I'll just let Anna round off. And
I only would like to thank our panelists and our speakers for this presentation, and my co-chair. Thank you very much.
Thank you.
Hello, everyone. Thank you, John and Anna. That was a really nice session. With an exciting morning so far. We're running slightly late, but that's okay. We will catch up. Just 2 announcements. So 15-minute break starting now. And the second thing, all speakers, regional speakers, panelists, so if your name is on the program tonight, we've got dinner for you. There's an event planned by the Panama Local Organizing Committee. Meet at 7:30 at the hotel lobby, please. And there'll be 2 buses that will take us to the event tonight. Okay? So 15-minute break and 7:30 this evening. Thank you.
Nos quedamos sin el micrófono principal. ¿Qué pasa? Yo lo estoy usando. A ver, ya, listo.
Check, check. 1, 2. Sí, sí. 2, 3. 1, 2, 1, 2. 1, 2. 2, 3, 1, 2. ¿Se escucha bien? Medio reventado. Uno, dos, sí. Uno, dos, uno, dos. Te lo deja el otro cable ahí por si acaso.
Dr. Nina, are you already here? Okay. So, in our interest to regain a little bit of punctuality, we're going to continue with session 8, Cell Collection and Processing, with chairpersons Joseph Schwartz and Juan Carlos Olivares Gasca. And our first panelist and our first speaker is going to be Nina Worrell with apheresis techniques, indications, and complications. Thank you, Dr. Worrell. Remember, right? Next one, previous one. Okay. And point it over there.
Yes. So, shall we wait until the people are sitting, or? No. So, it's a pleasure for me to talk about apheresis briefly, because we have to hurry, 15 minutes sharp. So, what I already showed you in the previous session is how the total number of transplants are going up in Latin America, and we had more than 6,700 transplants in 2022, and the majority of these were autotransplants, so for those at least we need apheresis, and nearly 40% were allotransplants, and I think also most of the patients received peripheral blood stem cells. So in the mobilization situation, you can use different regimens. It's if you use chemomobilization in your autologous patients, you can either use the disease-specific treatment, which is then followed by GCSF. Normally, we start at 6 days after the first day of chemotherapy, and then you check your CD34 counts approximately on the 4th day of GCSF and on a daily basis until leukocytes rise and stem cells are measurable. And if you do not detect any stem cells at the day where the apheresis would be anticipated, you can add a binding inhibitor like plerixafor or a biosimilar, and then this will enhance stem cell mobilization from the bone marrow to the peripheral blood, and you can collect your cells. Or you use, after disease-specific treatment, a mobilization regimen, which is mainly cyclophosphamide, which is often given in patients with multiple myeloma, and then again at GCSF and check your peripheral stem cell counts on a daily basis after 4 days of GCSF and add plerixafor. In our hospital, we do not use cyclophosphamide as a mobilization agent in myeloma patients because they are not really in need of chemotherapy, and we do not have that many beds in case of any side effects like neutropenic sepsis. So we always use steady-state mobilization, and this is also the mobilization regimen you would use in your allogeneic donors. You give 4 days GCSF, and then we take a blood count on the 4th day of GCSF and look for the CD34. And if the cell count is below 20, we would add at that day plerixafor and then collect either on the next day, or if you give this earlier on the days between 10 and 12 o'clock, you could also use you can also collect 4 hours later. So there the stem cell count starts to increase. For those who are doing gene therapy, but I think it's not affordable at the moment here, in sickle cell patients you would only mobilize with plerixafor, and there you will start with your collection 1 to 2 hours after you have applied plerixafor, and in those patients you would never use GCSF due to the risk of vaso-occlusive disease. So what about the cell numbers? So I think it's internationally agreed that 2 million cells are at least the lower threshold for sustained engraftment, at least in the autologous setting, but it's of course a desire to have a bit more, 2.5 to 5 million cells. This could facilitate engraftment. More than 5 million cells are not very helpful to have a faster platelet and white cell engraftment. For allogeneic transplantation, we have a minimum threshold of 4 million cells, but if you have a collection with 3.9 million cells, you would not put the donor again on an apheresis device, only if this is a higher risk for graft failure, like in patients with osteomyelofibrosis. And the upper threshold would be 5 to 8 million cells, more than 8, increases also the risk for chronic graft-versus-host disease, which you do not want to have. However, if you plan a further manipulation of your stem cells, then you maybe need to achieve higher cell doses. And again, in sickle cell patients, if you collect autologous cells for gene therapy, you should collect 20 million cells, unfortunately, to have enough cells to get manipulated and have a backup either. There are known risk factors for poor mobilization, not only in patients, but also in healthy volunteers. So that's a higher age. For patients, it's the underlying disease. So it's non-Hodgkin lymphoma with a higher risk than multiple myeloma because we collect there the cells in the first relapse situation. So they have undergone more chemotherapy. These are patients who have received extensive radiotherapy where bone marrow sites have been irradiated, patients with multiple chemotherapies, patients who received stem cell toxic substances like melphalan, carmostin, fludarabine, which is not given that much before an autologous stem cell collection, but also those who received more courses of lenalidomide because this regulates the 6-4 receptor up and then the cells bind more intensively to the stroma cells in the bone marrow. Daratumumab has been shown to cause mobilization failures, and also patients and also donors with low baseline platelet counts could be an indicator for bone marrow insufficiency. Okay, when you use chemotherapy, when to start with GCSF and when to start with the monitoring is very nicely depicted in the EBMT handbook I already mentioned yesterday, where there is a chapter on mobilization and stem cell collection. You can take a photo or get the cells. I will not go through this. Too quick. As mentioned, there is no harmonized standard what is a poor mobilizer and when to start with the collection, but I think most centers start when more than 20 stem cells are detected in the peripheral blood. If you aim for a higher collection yield or for a tandem collection, which maybe in some parts of the world are not done anymore because those have access to CAR T cells, but in others they do tandem transplants with multiple myeloma, it could also be a good idea to add plerixafor early, depending on how the costs are higher. Is the apheresis cost higher or is the drug cost higher? With the biosimilars available also here, I think the drug costs are lower, so for that it would make sense to give plerixafor maybe earlier. And if you collect after chemomobilization, just look for also higher leukocyte number. Do not collect when leukocytes are only 1,000 or 2,000 because then at the end you will not have enough cells. What you should consider is lenalidomide. So if you collect after the 4th cycle, it could be that you have mobilization failure, so collect it earlier. If you have intense chemotherapy, like patients with the matrix protocol with primary ZNS lymphoma, you should collect after the 1st or 2nd cycle before extensive irradiation. And for the technical procedure itself, hemoglobin level of 8 is not so less important because you then can bring the cells to the collection port more easily and have an thicker interface. So for that you can have a better collection efficiency, and platelet counts more than 20 or more than 50 in pediatric patients are important for patient safety. I think that the Spectra Optia device is the most common apheresis device used all over the world for therapeutic apheresis now, but also for collection. We do have 2 collection platforms. It's the MNC platform and the CMNC platform. So the MNC platform is a bit more tricky, but is the preferred choice for pediatric cohort because the extracorporeal volume is lower with 147 milliliters, so you do need blood priming only in patients who have less than 900 milliliter total blood volume. You have a lower product volume when it comes to cryopreservation. This is a benefit. The concentration is in this collection chamber here. I have to put. And you have 6 milliliters of cells in a collection chamber, and you flush the chamber then after each cycle with plasma to dilute your cells and get them in the collection bag. The CMNC platform is more the continuous collection platform, which was the platform we had in the old device also, with a higher extracorporeal volume, more than 250 ml. So you need blood priming earlier in patients who have less than 1.5 liters of total blood volume. You have a higher product volume. You have a higher platelet loss. This is to be considered especially in donors when you collect more than one time. And there is a very nice collection preference, which has to be adjusted to have the preferred color in your collection line. And this indirectly changes the plasma flow. And with a higher plasma flow, you get deeper in the cell level and can collect more cells. And I think this is important. Which disease you're collecting. So in sickle cell disease, for example, you have to dive more deeper in the level because your cells look completely different, and the cells you collect, the cells of interest, are more in the darker part. What should you also know is that, and this is what we discussed already, when you have a new device and you do only one collection every 2 to 3 months, you will not get enough confident to work with this machine. So I think the manufacturers are very eager to join you, to help you with the procedures, not only with the first, maybe also with the second and third, because that makes really sense, putting someone on a device and having someone who has a knowledge about how to optimize your collection procedure. If you have to prime the machine, we discussed this yesterday, leukocyte depleted and irradiated blood products, and also a good idea is, especially when you have problems with power supply or with a continuous power supply, just if you have the possibility to use an interruption-free power supply, that would be good when you have someone on a machine. The collection preference tool, which is given here below, there you should use the color between number 2 and 3, depending on what you're collecting. When you're more collecting MNCs for CAR T cells or DLI, you could even go to 1 and 2. And not to forget, the Optia could also be very nicely used for red cell depletion from the bone marrow if you do bone marrow transplants. Anticoagulation in apheresis is mainly done with ACDA, which binds calcium in the peripheral blood, and it leads to this. So for that, it's really important to give continuous calcium infusion, because that does not pose the patient or donors to toxicity, and especially in pediatric patients, I think it's really important, because they cannot tell you that they do not feel comfortable anymore. And in large volume apheresis, which would be 4 to 5 times total blood volume, then you could also, if there are no contraindications, platelet counts are high enough, no bleeding, you could also add heparin. And that leads then to a change in the ACDA ratio, so you don't have to perform then 1 to 12, you could even go to 1 to 22, and this decreases also the need for citrate, less citrate toxicity, and less volume overload. But do not forget, when you then process your products, that you add again citrate to have approximately 1 to 12 ratio in your final products. The symptoms associated with hypocalcemia depicted in this slide, so it's mainly mild to moderate toxicity symptoms we observe during apheresis. So therefore, I would encourage you to check the electrolytes at least before and after apheresis, but in smaller patients, in pediatric patients, you could even check in between to see whether you are still on the safe side. Don't forget also potassium is decreasing, but this is then recovered when the ACDA has metabolized. The stem cell count in the peripheral blood is a direct indicator of your collection results, and that correlates better with the CD34 cell count measured directly before apheresis, but also with the day before. So this could be used as a guidance when to start. And there are also possibilities to calculate how many cells you can have when you have 20 million cells before or 40 million cells before the apheresis. What a good tool would be, sorry, this is really tricky still, is to know the collection efficiency of your apheresis devices. It's easy to calculate the collection efficiency too. And with the collection efficiency, if you restructure your formula, you can get how many blood should you process to achieve a target cell dose by knowing your collection efficiency and by knowing your peripheral blood stem cell count. And what we did in our hospital is that we just put this formula in an Excel file, which is saved, so no one can change the formula, but our technicians or operators can put in the desired cell number here, 4 million cells, the CD34 count in the peripheral blood, and the weight of the patient and the total blood volume, and then the formula calculates how much blood volume should you process to achieve these 4 million cells. And this works really very good. In an autologous setting, we add 15% surplus because you lose cells by the cryopreservation process. So this ends up with mainly a very good result. And for allogeneic donors, even if you have a different weight from the recipient, you just put in the weight of the recipient here, and then you get also the volume you should process. The complications in apheresis are first a difficult peripheral venous access, which is then necessary to have a central venous line placed, but do not place this too far before the collection should start, because then you have the risk for catheter-related bloodstream infections, and then you have maybe a contaminated blood product, and then you should not use this in the autologous setting. Central venous lines have to be dealt with sterile handling. Patients should be also compliant. Citrate reactions we already discussed. Hemoglobin level either. In children, it's a good idea to have a higher threshold, because otherwise you dilute your child when you have no blood priming in the machine, and platelets for a safety issue should also be above 20. So additional to know is when you use peripheral venous access, which should be the first choice, then use a double swab method to disinfect your puncture site, and also discard the first 30 milliliters of blood. Use this for lab testing, because otherwise if the skin puncture is in the product, it can lead to infections again. And central venous lines are anesthesiologists should know that you need a large bore line or an appropriate line for children. It would also be a good idea to do ultrasound-guided femoral line in donors, because it has less risk for complications. Infectious disease markers, I will not go through because this is clear. And what you should know is that, and this is also a FACJC standard, so all these apheresis rooms and the storage rooms should be monitored for temperature and humidity, and it's extremely important in countries like here, because you have a very high humidity. Don't store in a lot of cartonages, but use maybe plastic shelves, and avoid, when you have an apheresis device near a window, avoid direct sunlight on the apheresis device, because this can also harm the product. And what we also have seen, and therefore I tell, don't open the windows, because then you have all your mosquitoes and flies in the room, which is also not so good. No one wants this. In summary, you can optimize the apheresis procedure for both autologous and allogeneic products. The CD34 target for autologous is more than 2 million, or at least 2 million up to 5 million, and for the allogeneic transplantation it's mainly more than 4 million to 8 million, but depending on how you want to process your product, even higher. Whenever possible, peripheral veins are preferable, or central venous lines should be inserted as close as possible to the collection day and ensure sterile handling of these lines. And to avoid citrate toxicity, consider calcium prophylaxis and monitor your electrolytes. Transfusion thresholds more than 8 to 10 gram per deciliter. Optimize your collection efficiency. Keep platelets high enough to have a patient safe. And it would be nice to have a strategy to calculate the blood volume, to not do always 12 liters and have no idea where you end up. And with this, I want to end and want still to show you those two handbooks, the EBMT handbook for transplantation, but also the textbook for nurses, which are very nice materials to get more ideas. Thank you.
All right, so now let's welcome our second speaker. That will be Dr. Amado Carduz, who is a hematologist from Colombia that has been doing some research regarding non-cryopreserved products.
Good morning. Thank you. Thank you one more time for inviting me to this very nice meeting. I would like to know if this is working well. Okay, perfect. As you know, the usual method for preservation of the autologous stem cell while we are applying the chemotherapy for patients with autologous transplant is the classical cryopreservation under control rate. This technique needs a lot of resource, need a special device for decrease the temperature 1 centigrade per minute, and also you need a special tank for liquid nitrogen. That means that this is expensive, needs a lot of resource, needs special training, and it is not suitable for a small center. Fortunately, there are some alternatives that also work very well. One of them. One of them is the cryopreservation at minus 80 degrees Celsius in a passive way. The first part of the cryopreservation is the same. You need a cryovac, you need a dimethyl sulfoxide, you need a laminar flow chamber for doing the mix, but instead of put the vac inside of a special device to decrease 1 minute per 1 grade per minute the temperature, you put the vac inside of a mechanical freezer, close the freezer, and the vac is frozen in a very good way. This technique also has shown very good viability, very good chronogenic capacity after the cells are thawing and infused to the patient. There are a lot of literature showing that one. Because the time, I decided to show you a couple of these papers that support this technique. This study consisted of 2 parts. It was done in Turkey, relatively recently published. In this study, the first part of the study used 20 patients that underwent to autologous transplant for the usual diseases, myeloma, lymphoma, etc. They were transplanted with a cell cryopreserved at minus 80 degrees Celsius, and after a time of 1 month, more or less, for each unit, they were thawing and they were infused for supporting the autologous transplant. And as you can see in the bottom part of the slide, the engraftment was universal and very fast, similar to what is obtained when we use control rate freezing. The second part of the study was done with backup of this patient. All of these patients had backup back for some situation. The backup back were put in the refrigeration, were kept in the same device at minus 80 degrees Celsius, and were kept in this device for several years. Finally, for some reason, maybe because these backup units were no longer needed, the unit were discharged, but before the discharging the unit, they one more time measured the viability, the chronogenic capacity, and as you can see in the slide, after 5 years of cryopreservation under this method, the viability in the chronogenic capacity was above 80%. That means that this is a safe, a reliable method to preserve cells during the autologous transplantation. This is another one. It's maybe one of the largest studies that have been published so far. It was done almost 20 years ago. 300 patients were transplanted using this technique, this approach. The cells were kept in a mechanical freezer at minus 80 degrees Celsius, more or less for 1 month. All of these 300 patients were transplanted. The hematopoietic recovery, and the quality of the hematopoietic recovery was very good. As you can see in your right side of the slide, all of the patients have a very good recuperation of the neutrophil count, 11 days, the platelet count, 12 days. Very, very similar to what occurred when you use a control rate for frozen the cells. That means that this is a good alternative. It's less expensive, but still, this alternative needs cryogenic bag. You need a special bag for that support this very low temperature. You also need dimethyl sulfoxide. You also need a laminar flow chamber for doing the mix of the cells, and you need a mechanical freezer at the minus 80 degrees Celsius, which is not very usual in the banks. The more usual refrigerator in the bank is minus 20, no minus 80. But of course, it's a good alternative for some banks which have this kind of device. But there are also other alternatives. Well, something is happening. And it's use the cells without cryopreservation. This method, this technique is as easy as you can see in the slide. You do the apheresis. After the apheresis is finished, you take the apheresis without switch the blood product to another bag. In our case, we continue to use the same bag of the apheresis without the necessity to use dimethyl sulfoxide, without necessity to use a special medium. We add 100 centimeters of planks because we need to do some buffer. Later can explain about that. And after the samples are taken for quality control, the bag goes directly to the blood bank refrigerator at 4 degrees Celsius. And in this way, it's maintained until 6 days. And after 6 days, you can take the bag and infuse your patient. This technique is very, very, very easy. It's simpler, it's cheaper, and it has been used in Latin America for several years. Something is happening. These are some laboratory data that support the use of this technique, showing that the viability and the cryogenic capacity is very good after 6 days of refrigeration. This is an old paper for our group in Colombia. In this paper, we study 47 patients with malignant hematological, most of them with lymphoma. The cells were kept in the refrigerator for 6 days, and after that, they were transplanted. You can see that the speed of the recuperation in the bottom part of the slide was very good. The neutrophil engraftment occurred at day mass 11, and the platelet engraftment near to day 16. And when we measure the viability was 80% at the 6 days before the infusion, and the cryogenic capacity was 50%. That means that it's very clear that it's possible that the stem cell keep all its capacity of characteristic to repopulation the bone marrow after 6 days of being in a normal refrigerator of a blood bank. This is more recent data for our center. This is the result of 74 patients that were transplanted with lymphoma, and the cells were kept in the refrigerator at 4 degrees Celsius, and we measure the viability just before the infusion, and as you can see, the viability is near to 80% after 6 days of refrigeration. But also, this is support also for a relative extensive literature. This technique is not new for our center in Latin America. This technique has been used in Latin America for more than 25 years. Indeed, there are several reports in the literature showing that this technique is feasible and is safe. Also, this reference come from single center, relative small series, but all of them show the same. It's possible to do autologous transplant, keeping the cell in the block bank refrigerator without the necessity of a big freezer. Finally, under the auspices of LABNT, we could collect a very important number of patients. This study was done using the data from two centers from Argentina, 2 centers from Mexico, and 1 center for Colombia. As you can see, we collect almost 500 patients. These results are patients with myeloma. Almost, what is the name? 216 patients with myeloma were transplanted. The cell was stored in the block bank refrigerator for 2 or 3 days. All of the patients received Melphalan 200. Some of them, because renal failure, received Melphalan 140. And as you can see in the bottom part, the neutrophil engraftment and the platelet engraftment was very, very, very good. And the mortality at 1 day was just 1%, and the overall survival at 5 years, 50%. That means that it's very, very possible to do that in myeloma patients. But also in lymphoma patients. In the same study, we could collect the data from 140 patients with lymphoma that were transplanted using Beam or CBB. Just shorten a little bit the number of days that we apply the Beam. Not during the 6 days, it's not 4 or 5 days, but with the same intensity of dose of Beam or CBB. The idea is not to decrease the intensity of dose. Give the complete dose of the usual protocol for conditioning patients with lymphoma patient. And as you can see, the mortality at day plus 100 was 2.8%. The overall survival was also good. In the upper part, you can say the engraftment of neutrophil was 12 days, and the engraftment of platelet was 17 days. That means completely good. All of the patients, with exception of one, have a very, very good engraftment, very, very good engraftment, a very strong engraftment. We did a comparison between the patient that with cell were refrigerated for 3 days versus the patient with the cell were refrigerated for 6 days. And there was no any difference between the speed of the engraftment when we compare the two groups. That means that it's also possible to keep the cells in the block bank refrigerator for 6 days and apply the more usual conditioning for a transplanting patient with lymphoma. There are a lot of literature regarding the use of fresh cell for transplanting patients with myeloma, at least 10, 15, but I choose these one. The first one is a relative small study from Uruguay. Maybe Sebastian is one of the authors. In this study, the study that you write in your left part, in this study, something happened. Okay, this one. In this study from Uruguay, 23 patients that were transplanted with myeloma with frozen cell were compared with another 20 patients that were transplanted with fresh cell. As you can see in the table, all of the outcomes were the same speed of the recuperation, the same toxicity, but as you can see in the bottom part, the patient who receives fresh cell didn't have any secondary event for the infusion, while the patient who received the cryopreserved back have some secondary event, secondary infusion of dimethyl sulfoxide that is very clear that occur. Fortunately, most of them are not severe, but they occur. And another one is a large study that was done by ABNT at one center in Algeria. In this study, we compared 112 patients from the EBNT register that were transplanted with cryopreserved cells with 300 patients that were transplanted in one center in Algeria. You can see the curves. These curves don't need more explanation. All of them are very, very similar. The speed of the engraftment were exactly the same. Something happened. Okay. But also, there are some literature that support the use of this kind of method in patients with lymphoma. It's less extensive, but it still exists. In this study, also, one more time, a comparison between the WBMT register with this center in Algeria. They compare patients who were transplanted with both techniques. 80% of the patients received BIM, and as you can see that the speed of the recuperation of the platelet, the speed of the engraftment were the same without important what kind of preservation were used. And another one is for our center. In the time that the carmustine was not available worldwide, we need to switch our protocol and substitute the carmustine for carboplatin, but the cells were one more time kept in the block bar refrigerator for 6 days. As you can see, the speed of the recuperation of the neutrophil was 12 days and the platelet 15 days, and the overall survival very, very comparable. That means that it's very possible, it's feasible, it's safe to also use this technique, this approach for transplanted patient, for transplanted lymphoma patient, using the full intensity of the more popular conditioning. But what are doing the Latin American Center? This was a survey that was done 1 month ago. Thank you to the colleague that answered the survey. We asked what was the way that the center were preserving the cells for doing autologous transplantation. We got 55 responses for Argentina. Thank you, Juliana, for your help. For Argentina, for Colombia, Brazil, for almost every country in Latin America. And in the right part of the slide are the responses. In the case of myeloma, 72% of the centers in Latin America are using short-term preservation in blood refrigerator of the bank and not cryopreserving the cells. 12% are using the classical control rate frozen, and 50% are using the mechanical freezer at minus 80 degrees. When we ask for the same question, but talking about lymphoma, in red, 57% was used the passive cryopreservation in a mechanical freezer. 90% still use the short-term preservation in blood bank without frozen, and another 20% was used the control rate freezing. Finally, I conclude that it's very possible to use this approach for transplanting patients with myeloma, also for transplanting patients with lymphoma. In this case, needs most coordination, a very good coordination between the apheresis, between the preservation of the bag, start of the conditioning, but that is very possible. This method have a lot of advantages, but also, of course, some disadvantages. It requires efficient coordination between stem cell mobilization, apheresis, and the administration of the chemotherapy. It cannot be used with conditioning that lasts for more than 6 days. All of the studies show that after 6 days of refrigeration, 7 days of refrigeration, the viability and the chronogenic capacity decrease a lot. Of course, there is a risk that if the patient after collect the cell has some flu, some disease, and it's not possible to transplant, this cell will be lost. But in general, it's a good alternative to start a bone marrow transplant program in a place with low resources. But in our case, that we have the possibility to cryopreserve, etc., we still are using this technique because it's very easy. It's very easy, it's very cheap, and works. Maybe I finish with that one. Thank you very much.
Thank you. Thank you. So it starts to be sound as controversial as no radiation, no freezing, no radiation. So it'll be good for the discussion. It's okay. So our third speaker, last but not least, is Christian Chavanon-Mercier, Director of the Cell Processing Lab, and his presentation will kind of take us directly into the discussion, minimal requirement for cell processing lab. Christian?
Yeah, thank you, Yossi. Thank you, everybody, for having me there. Okay. Yeah, I will try to cover briefly the needs for a cell processing facility, which I believe is an essential component in any transplant and cellular therapy program. Cell processing facility is the wording used in particular in the FACT-JC international standards, but depending on which kind of document you read, you can also see the word tissue establishments, and in the future, at least in Europe, we may have so entities and so establishments as the denomination of these hospital or blood bank infrastructures as a consequence of the publication of the regulations, the European regulations on substances of human origin that covers their procurement and various potential uses in different contexts. Very simple figure to show that, in fact, we are speaking of a flow of activities. Nina Vorel nicely covered the procurement of cells by apheresis, which again is the most frequently used process to access stem cells or immune effector cells. And then the cells will be processed to some extent before they are distributed to the clinical ward and transplanted to the patient. I use two different color codes to underline the fact that depending on the complexity of cell engineering, it will result in different categories of therapeutic products. Cell transplant in blue are minimally manipulated, and advanced therapies that can be manufactured from hematopoietic cells have undergone substantial manipulations that will change the functional properties of the collected cells. And this is one of the goals of the SO regulation in Europe, which is to properly cover this branching between advanced therapy manufacturing and cell transplants. It's so in the context of cell transplant, we will process the collected cells, again introducing non-substantial changes. So collected cell product partitioning, which means being able to perform sterile tubing connections. Cryopreservation and thawing, we've heard a lot in the last and nice presentations, but as your program grows in size and complexity, it will be more and more difficult to avoid to cryopreserve at least a fraction of the products that you process. Volume reduction is necessary to avoid the overload of the recipient. And this is especially important if you treat pediatric patients, can be managed using simple and relatively inexpensive centrifuge. Plasma depletion in case of minor ABO incompatibility between a donor and a recipient. Nina Vorel explained yesterday what is this situation. Red blood cell depletion of bone marrow collections in case of major ABO incompatibility, again, important if you're running an allogenic program, especially for non-malignant diseases, and as a consequence, especially important for pediatric programs. And finally, maybe the most complex category of processing is positive or negative selection of phenotypically defined subsets of cells that are present in the collected cell product. Namely, you may want to select stem cells, which are identified usually as CD34 positive cells, or you may want to select a defined or get rid of a defined subset of immune effector cells, as an example, T cells, because in vivo T cell depletion is known to reduce the occurrence and severity of GVHD after allogenic transplantation. But in fact, once you have identified all these tools and all these toys that can be useful, and you look at what will be your main activity in the near future, most of the grafts really undergo very simple processing, meaning cryopreservation and thawing, volume reduction, plasma depletion, which pretty much is the same process as volume reduction, and partitioning. You don't need to have red blood cell depletion. As already mentioned, a cell processor like the Spectra Optia does that quite well. And in fact, when you will really need it, you can borrow the cell processor from the neighboring and partnering apheresis facility for the few manipulations that you will do every year. And positive or negative selection of phenotypically defined subsets of cells is restricted to a small fraction of transplants. And actually, these are, especially in the pediatric setting, but it's also coming in the adult setting, these are restricted to very specific population of patients. And this entails several changes in the transplant protocol, including variations in the immune suppressive regimen that is administered before and after transplant. So this requires an expertise that goes beyond the processing facility. Cell engineering also means you have to do at least minimal quality controls at reception when the cell processing facility receives the collected cell product from the apheresis facility or from the OR if we are speaking of a bone marrow collection. I'm not covering cord blood in this presentation. During the process, you need to check that at each step, engineering fulfills predefined criteria, and obviously on the final product before the product is released and distributed to the clinical ward and administered to the recipient. These are needed to characterize the cell product and also to evaluate the efficiency of each of the processing steps. Some of the results of QC may be used as release criteria. This is something that you have to define in advance. What will be your release criteria? As an example, for an autologous graft, you may decide you want your graft, your final graft, to contain at least 2 × 10⁶ CD34 positive cells per kilo. If you read the literature in this field, you will very often cross the wording potency assays. This has come to be very popular as advanced therapies have developed. These are assays that can predict to some extent biological activity and clinical efficacy, but beyond that, you can ask experts. Nobody can define a potency assay very accurately, but this is also what regulatory agencies will require for an advanced therapy. Thinking of grafts, you don't have to worry about potency assays. The closest assay that comes to a potency assay is clonogenic assays, CFU-GM, which we barely need for autologous transplantation. The point is that if you are starting your program, you may actually subcontract all or most of your QC to the laboratory medicine that is closest to your cell engineering, cell processing facility. Who do you need to run a processing facility and a QC lab? For cell engineering, you need lab technologists, trained, habilitated, and retrained lab technologists. And in terms of overseeing the activities, this could be physicians, pharmacists, or scientists with experience in cell engineering. I can tell you that in France and in Europe, in general, I believe, these are now mostly pharmacists who are investing this field. You will find very few physicians who are interested in getting the specific expertise for cell processing. And your cell processing facility director needs to have at least 2 years of experience in the field, which is one of the tricky points, because if you're starting a program, you have nothing to train someone on site. So this is where having friends, being part of a network is very useful, because you can send someone to an experienced facility where this person will get the experience needed to lead his or her own cell processing facilities. For quality controls, against lab technologists and usually healthcare professionals that are certified in biology, laboratory medicine. These are, in many countries, mutually exclusive activities based on the same principles. In the pharma industry, you cannot evaluate what you are manufacturing, so different activities. And a qualified person is the person who is legally responsible for the release of cellular therapy products. This means if you run into problems, you may be talking to your lawyer quite fast. Interactions with clinical facilities. Collection facilities, this can be local, but as your program grows, you may wish to procure cells from unrelated donors, so the product will come from outside of your center, either from your own country or from international registries. You should have predefined specifications, acceptability criteria for collections. This means you have to talk to the person who is in charge of the collection facility. We've already talked about release criteria for cellular therapy product. We are used to manage out-of-specification products. It didn't come with CAR T cells. We were already managing out-of-specification products. For example, a product where you have only 1.8 times to the 6 CD44 positive cells, while you would have liked to have 2 times 10 to the 6. And maintaining the traceability all along the process is absolutely essential for the safety of the donor and the patient. So this is what is usually referred to as a chain of identity. At any time during the process, you must be able to link the person who donates with the person who will receive. And the chain of custody describes the major steps in processing. All of that can be recapitulated with proper labeling, and I don't have time to go into details, but ISBT 128 is the usual norm, and this is mandated by the FACT and JC standards on cellular therapy. This will allow to precisely describe the nature of the product, the person for whom it is intended. So this is all that I said is pretty much summarized on this simple illustration. Nina covered donation and, sorry, I got too fast. Nina covered donation and collection steps. I covered testing and processing and storage. Didn't allude too much about the possibility not to use cryopreservation, because that was nicely done before me, distribution and application. Of course, all of this works if you build a efficient quality management system. This is embedded in laws and regulations as well as in standards, such as, again, of the FACT JC standards. This implies building a documentary systems that you update on a regular basis, a corrective action and preventive action plan, that you have all necessary licenses and authorization from competent and the health authorities, and that you have agreements and conventions in places with all of your partners, including those to whom you may subcontract a fraction of your activities. I will, I think I missed one slide. Yeah, this is the most important one, the conclusions. So starting operations of a cell processing facility requires investments in infrastructures, but you don't need a GMP facility except maybe in a few countries. You don't need to build multi-million-dollar infrastructures. Equipment, I've tried to convince you that the number of critical equipment that you need are indeed limited. Some of them you can borrow from partnering organizations. What I believe is you need to invest in people. You need to invest in training and educating good people that will stay with you, because the time you need to train them is quite long. And once they are trained, you don't want them to go elsewhere. And from this viewpoint, the competition with the pharma industry is becoming a problem now, because you train people and then they go to the pharma industry for better salaries. You also need to invest in building a collective organization. You are not working alone, you are working with partners, those who collect the cells, those who infuse the cells, and many others. So build a collective organization that is best supervised with an efficient QMS system. And thus, if you start this activity, you need to define a strategic plan. Don't reinvent the wheel. Just try to identify what are the resources that are already available. Someone yesterday mentioned that in blood banks, there are people who know some of the techniques that you will need to run a transplant program. And of course, start from the easiest procedures and progressively build your program by adding more options and moving to most complex procedures. Thank you for your attention.
So for interest of time, we'll ask the panelists to come on the program. Lorraine, Carol, Amris, and Calixto, and then we'll continue for 10 minutes. Yeah, go ahead now.
All right. Okay, so we have all the panelists here. So it will be interesting to hear what are the thoughts from Cuba and Panama regarding starting a pharesis center and a processing facility. What is your experience? Yeah, for you and in Cuba. How we do?
Yeah. Okay. I'm coming from a center that is in Cuba. We have a small BNT program. It's a small one, but we started in 1985. So it's a long time ago. Unfortunately, we haven't done a lot of transplants as we wish, but we keep doing a little transplant every year. We have so far almost 100. It's not too much, but it's our experience. In our case, we keep everything inside the blown bag. We do it all the time. We have doing fresh cells, Dr. Amal, like you. And it's like you say, I love your work. It's like you say, it's safe, it's feasible. In all the transplants that we have done so far, we don't have any graft failure. I think just one case for a multiple myeloma case. But all of the transplant, all the rest, they're doing okay. All the recovery was, well, they got the recovery when was expected. without any problem. And in that way, we keep it for all this time. Of course, we would like to do cryopreservation, but the conditions, the facility for that need very special conditions. We don't have the resources for that now. But my little advice for anyone who wants to start a BNT program, you can start in this way using fresh cells because the results are good and the patient can resolve the problem. It's my...
Go ahead. Yeah. Oh, yeah.
Okay. En el caso de Panamá, en los centros, pues tenemos experiencia con los dos tipos de criopreservación y tenemos igualmente dividido pues lo que es la parte de aféresis en el banco de sangre que lo realizan y en el caso pues de mi persona lo que es el conteo de células madres dentro del laboratorio de citometría de flujo. Y bueno, entre lo que mencionan de la implementación de un centro de aféresis es algo bueno y considero que una de las cosas más importantes pues la capacitación del personal que lo mencionaba el doctor anteriormente, eso es vital y la comunicación entre el equipo para el éxito de eso, sobre todo para asegurar que las células que se reporten sean las células viables que garanticen el éxito del injerto.
Summarize.
All right, so to summarize, they have experience here in Panama doing it as a cryopreserve and non-cryopreserve, and they believe that training of the staff is very important to have a successful unit.
Thank you. If there are any questions from the audience, but if not, yes, Federico. But before that, I have a question to Nino for the collection part to maybe tell the audience, because when you start, especially in some parts of the world, the machine is very expensive. So, maybe you don't need 5 to start with. So what's kind of your advice when you start a collection facility, how you start, so with how many machines, and maybe one is enough to start with? And
so that's a good question. So first, I think it would be the best option to have a machine where you could do several different procedures, so like stem cell collection, bone marrow processing, but also therapeutic apheresis, like plasma exchange, for example, or red cell exchange, depending on which diseases you have to treat, because then you have one device for all your needs. And I would say that you should start with one device, otherwise one will always stay behind. Of course, then you have no backup machine, but to have a backup machine, I think it's extremely expensive again, and that the device fails is not so often the case.
thank you. Federico?
Okay, I just want to make a comment for Dr. Cardoso that I almost had a heart attack. I'm good. So when he said that the cryopreservation and the -80 freezer doesn't need training, it does need training. I just don't want people to get the idea that you can implement a technique like that just out of the blue. You have to have proper training. And of course, you have to have a very good validation. The method really exists and works, which is it's called dump freezing. But again, you have to have your staff trained and then validate your procedure. That's it.
Yes, I completely agree with you. That means that this technique without frozen the cell is easier, is simpler, but of course, need all the quality control, all of the training, all of the quality control of every blood bank product. You need a very good label, you need a very traceability, you have a lot control the viability, the sterility of the bag, similar to every blood cell that you are using, every product that you are using in the blood bank. Completely agree with you. This needs a strict control of quality, but when I was talking about training, apheresis that do apheresis for platelet collection can do apheresis for stem cell transplantation. The technician in blood bank who taking care of the normal blood cell, platelet cell can take can carry could carry the cell, the stem cell, but it doesn't mean, of course not, that this procedure don't need quality control. A very strict quality control is necessary for every product that is in the blood bank.
Damiano has a question, but before that, I mean, just 1 second. Carol, your perspective, nursing, any perspective on the collection? I guess not maybe on the lab part, but maybe any perspective for nursing.
Well, I think it's very important when you're trying to set up an apheresis unit, who's going to be the operator? Is it going to be a nurse? Is it going to be a technician? Is it going to be a member of the medical staff? I think that's the first important thing you have to consider. And then you have to consider where is the position of the collection facility going to be. Yeah. Because you need help if your patient is ill. Is it going to be within the clinical ward, the day case ward, or in some areas of the world, I know it is done within the blood bank. Yeah. So I think those are the main things you have to do, first of all.
I think those are actually valid points. As an apheresis person in heart, I would say two things. In the US, it is not that technologists or technicians cannot do it, the rest of the world. In the US now, they're actually requiring RNs, nurses, to do it just because it's such a patient. It's grandfathered to the people already doing it in the field, but at least at ASFA, when I was the president, we tried to implement what we call a QOA, qualification apheresis. So at least there is a qualification test that people can have some sort of a program they go to and take the test, and where in the world it exists now to the rest of the world. But I think it's a valid question. Damiano.
I'd like to raise a point for starting a program in low-resource countries. I think I agree with everything is said, that one issue is the capacity of people and training. The other one is actually affordability. And you can have the instrument, you can buy the machine, you can have, and then you don't have the money to buy the reagents or the supplies. And so an advice, or maybe a comment, or maybe asking how you operate, it's very important that the hospital management, the administrators are involved at the very beginning, because it's very common to have someone donating or buying a machine. The politician is going to say, we have a new transplant program, we have a new thing. And then a month later, you don't have the reagents, and the machine is basically dead in somewhere in the hospital. So how do you have any advice on this? Maybe people from I know Cuba is a big issue for that, but maybe, I don't know, Colombia or Panama has any advice on how to develop these administrative efforts?
Bueno, integrando los comentarios y las preguntas a lo que se referían del manejo o quién debe ser la persona que debe realizar el procedimiento, creo que básicamente lo importante es las leyes que se rigen en cada país en cuanto a los temas de quién realiza o es el personal idóneo para hacer un proceso, ¿no? En nuestro país, bueno, el banco de sangre es el que se encarga de manejar las máquinas de aféresis, y pues sí, la enfermera tiene también rol importante de ver la estabilidad del paciente, monitorear junto al hematólogo, pero pienso que dependiendo de lo que establece en cada país, pues como mencioné anteriormente, lo más importante es que el personal sea capacitado y sepa realizar, porque de hecho, en otra experiencia que he tenido internacional en México, vi que las enfermeras son las que realizan el procedimiento de aféresis, pero ellas ya fueron entrenadas y fueron certificadas para el uso del equipo. Entonces, si en un país adquieren una metodología y dependiendo de allí la ley establece, pues que el personal sea capacitado para realizar con éxito el procedimiento y que asegure la calidad del resultado y del producto.
So Juan Carlos will translate the answer, and then we'll stop because we are 20 minutes over time. Then it obviously generates a lot of discussion, but we can continue just to keep on time.
Yeah, so she was telling that here in Panama, the collection is done by the blood bank and the nurses are interacting with the patient, but it is mainly done by the blood bank. She has some experience in Mexico, for example, that the nurses do the collection in the first. So this may change according to the legislation in every region.
So before we stop, the president has a comment, so we have to adjust just for him.
I just wanted to congratulate this I remember, when we first had the meeting in 2011, that was almost 50. Effective practice, and many centers in Asia that have started programs since then have learned from your practice. So I think you should be extremely proud of this. And Laurent as well, I think in your analysis of all the Waston project, you've demonstrated as well that this consistently has not diminished results and have maintained good results. So excellent. So thank you very, very much. Thank you. And yeah, thanks.
Session 9, Complications of HCT and Laboratory Infrastructure, with chairpersons Christian Chavenon and Wendy Franco.
So let me briefly introduce again Dr. Madagascar, who described earlier today HLA typing and how to bring back this information to clinicians, and who will now speak on two topics. So you will have a few more minutes. Two topics: donor-specific antibodies on one hand and chimerism evaluation on the other hand. Thank you so much.
Thank you, Christian, and the organizing committee for the opportunity to talk about these two important topics. So I'll talk about donor-specific antibodies, and particularly about their clinical relevance and the laboratory testing for HLA antibodies, and the reporting and interpretation. Also, again, very, very important how we communicate results, so we make it easier for clinicians to make informed decisions. And then for chimerism analysis, I'll talk about, very briefly, different testing methods, and then I'll talk about clinical relevance. So let's start by antibodies. See, they are very happy. Actually, this is not a novel concept, that antibodies are associated with high risk of graft failure. That was published in New England Journal of Medicine in the 80s. And really, it was shown that having these antibodies was associated with a statistically significant difference. So why now we are talking about it, since this has been known? Why for a long period of time we have not been talking about this? Because historically we did almost fully matched transplants. So it was either HLA identical siblings or matched unrelated donors. And when you do that, there is no mismatches or very few mismatches. So the chances of having donor-specific antibodies, even in highly sensitized patients, is small. But we can see from this graph is that two trends here. I don't know how to. So does this point or it doesn't? Doesn't? Okay. If we look at the curves that have the highest
upward inflection. The green one, which is the mismatched MMUD, who actually has shown since COVID about 4 times increase, 4-fold increase. And also the haplo that has crossed the HLA-matched siblings. So more and more, we are doing transplants with mismatched donors. And when there are so many mismatches, then the chances are some antibody in highly sensitized patient gonna cross-react to that. So HLA antibodies, how do they come about? How do we become sensitized? Is due to pregnancy. And this is particularly relevant to haplotransplant. So if we are looking for a mom that has been sensitized by her husband and her children, then probably many of her potential related donors who are haplo, she's going to have very high level antibodies for. So this is something we need to keep in mind. And again, allogenic blood product transfusion, which is particularly relevant in patients who receive a lot of transfusion or transfusion dependent, and we need to keep that in mind. So this mismatches actually what makes that perfect targets for donor-specific antibody, which have been documented to be a biomarker associated with failure of engraftment. And this has been shown in multiple studies. If we compare graft failure with and without DSA, it has shown in the in studies in Europe and in the USA. And if we do multivariable analysis, we can see that there is a statistically significant risk with failure of engraftment. I would argue that this is probably misclassification and underestimate of the risk, because many of the patients are not classified properly due to the variations in the reporting of donor-specific antibodies and testing for them. So there are patients with no antibodies would be classified as having low-level antibodies, and patients with low-level antibodies that might be classified as not having antibodies. But I think if this study or similar studies are done with very strict criteria of who really has donor-specific antibody and who doesn't, the risk will be significantly higher. It has been shown in almost every clinical context of hematopoietic cell transplant. Haplo, 9 out of 10, 10 out of 10, single cord, double cord. So this has been shown consistently. And in meta-analysis, it was shown that on the average, it's about 7.5 odds ratio of failure of engraftment. So how do we measure antibodies? For the most part, we measure them using Luminex. And this is how we measure it, using MFI, the normalized, that it takes calculation, that takes background and things of that nature. And the most center use a couple of cutoffs. One of them went to call antibodies present, and many centers around the world use 1,000 to call antibodies present. And then they use another cutoff between 3,000 and 4,000 or even 5,000 to call antibodies low level. And in those, many centers actually would proceed to transplant without desensitization. And anything above that usually is associated with increased risk unless you do desensitization. Some centers use even a higher cutoff, above 10,000, which really denotes that it's maybe better to look for another donor because the risk at that point becomes significant. So I don't want to waste your time about this, but in terms of protocols to deal with allosensitization, this is actually one of the oldest protocols from Hopkins in 2015. And it looks at the level of antibodies. If you have antibodies that doesn't rise to the level of positive flow cross-match, that usually below 3,000 to 5,000, and those actually, they would proceed to transplant without desensitization, but they would, this is actually something Demiano mentioned today. If you have patients with borderline antibodies, you want to monitor them to make sure that the antibodies didn't creep up. So you test them on day -1, and if the antibodies remain low, you proceed to transplant and you are done here. But if you have antibodies that rise to the level of flow cross-match, but still negative CDC, which is between 3,000 to 10,000, you actually need preconditioning to make sure that you lower the antibodies to a level that is safe, which usually 3 to 4 freezes. And there are variations. Some people add rituximab, some people add Velcade, what have you. And you test on day -1, and if it is below 3,000, you proceed to transplant. If it is higher, you continue freezes post-transplant, provided platelet will allow that. And then you measure on day +1, and you manage post-transplant. And if it is higher than that, usually consider other options. These are more contemporary protocols that actually use more immunosuppression, and it uses actually buffy coat infusion because granulocytes express both class 1 and class 2 HLA. So if you infuse granulocytes from, or buffy coat from the donor, they would absorb donor-specific antibodies, and then you infuse the product the following day. What do we have? Okay. How do we go back? This one. Okay. So this is a form we developed in our center that really shares the responsibility between the transplant program and the lab. Because oftentimes the lab is working blindfolded. They don't know who is the donor. They don't know when transplant is going to be performed. And we found this to be not very helpful. So we actually, for every transplant, we know upfront. So this part, it's a document, it's a PDF, fillable PDF, that the transplant coordinator fills the top part. They tell us what type of transplant, the patient identifier, the donor identifier, and the planned date for transplant, so that we can calculate 30-day, because we don't want the clinician to be worried when the patient needs to be retested for donor-specific antibody, and also whom to call, who is the clinician, who is the coordinator, in case we find unexpected high level of donor-specific antibody. And on our side, we look for presence of donor-specific antibody, and we classify them based on the levels that I just mentioned, and we predict the cross-match results that we are seeing. And this is how we report the antibodies. I don't think it's useful to report this patient is having 3,584. That's just not very helpful. It's just, I think it would suffice to report at what level, which donor-specific antibody at within which bracket. So is it the level that is safe to proceed to transplant without desensitization? Is it the level that you need desensitization? Or it is the level that you better consider a different donor? So this is the NMDP policy. There was questions about this, that we need to test the patients ideally at time of initial evaluation, and that we do not proceed to transplant with result older than 30 days, and we test within 1 week for patients who are transfusion dependent. Quickly about chimeras. So we actually have a review article that talks about everything that has to do with the technical aspects of how to validate the test, what are the technical performance characteristics of the test. And actually this has been very well cited, including by the American College of Medical Genetics and Genomics in their standards. And this is actually additional article dedicated to validation. And we have actually an article dedicated to clinicians that actually explains when to perform it, how to interpret the results, and things of that nature that probably there won't be time now to go into full details. Just quickly, some of the definitions. Complete chimerism is when the donor DNA is detected. I would say anything, because most of the world uses STR that has a sensitivity of 95%. So anything above 95% for engraftment monitoring purposes is considered complete donor chimerism. Mixed chimerism when you detect both donor and the recipient or donor more than 5%. There is this mixed chimerism could be stable, where you find that over time the values do not change. And oftentimes we see this in non-malignant condition, which is perfectly fine. We could see increasing when the recipient DNA goes up compared to previous results, or it could be decreasing. There is a split chimerism when you have complete chimerism in one or more of subsets and the other subset showing different. So one of the things we always see is that B cells usually takes much longer, so up to 2 years to become fully reconstituted, even in fully successful transplant. Microchimerism, when we have chimerism less than 1%, which requires ultra-sensitive methods like NGS and real-time PCR, digital droplet PCR. Autologous recovery, when we see 100% of the recipient and 0 donor. These are the methods that are used. Particularly, I'll focus on STR. It is highly informative, fast, requires low amount of DNA, and this is actually the most widely used method now. The limitation, it has moderate sensitivity. I'll talk about the digital droplet PCR. It's a highly sensitive and it has high accuracy, but it requires high amount of DNA, which is sometimes very challenging if you are doing subsets, because you wouldn't have enough DNA on every subset. And next generation sequencing, actually, that's my preferred method. It has high sensitivity, high accuracy, high throughput, and it doesn't require high level of DNA. So it's very well suited for subsets, but it is a little bit more expensive than digital droplet PCR. And in some protocols, unless it is automated using robots, it could be labor intensive. The STR, the most commonly used, it wasn't a clinical test to begin with. We used it out of necessity. It's based on the CODIS database of the FBI that is used for crime scene investigation for DNA fingerprinting. So it wasn't done for clinical, it wasn't done to be quantitative, it just was done for fingerprinting. But out of necessity, we used it. And it's a multiplex where we use different colors, so we can measure different loci of the same length using painted with conjugated with different fluorochromes. So this is just quickly, this is how it's done. We identify the recipient alleles. For each locus, we have 2 alleles, one maternal, one paternal. It's exactly like HLA. And then we see the donor, and then we see what post-transplant looks like. So post-transplant, that looks like the recipient, so that's a failure of engraft. If it looks like this, then that's full engraft. But of course, we need to find informative markers. If the donor and the recipient are identical across all markers, then the test becomes non-informative. And oftentimes, we see mixed chimerism, where you would see percentages of the donor and the recipient alleles. There is literature about how some of the subsets actually could be more informative of impending relapse, like CD34. And that's why the subset analysis becomes important. And also, one thing that chimerism can identify is loss of mismatched HLA in leukemia after stem cell. So basically, using chimerism with markers within the HLA region can distinguish between HLA loss relapse versus classical relapse. So it is not like the typical STR would miss the HLA loss relapse. It would misclassify as classical relapse. So if we have both, if we look here on the left panel, we see that the HLA markers and non-HLA markers in a classical relapse, they are identical. But if we look at the HLA loss relapse, when we lose the HLA of the mismatched haplotype, then we would see that the HLA markers are continue to be lost, while we see the loss of chimerism only in the non-HLA. Is this relevant? Yes, because if you lose the mismatched HLA, you lose the target for graft versus leukemia. And this means that donor lymphocyte infusion will not be effective. Transplant from the same donor will not be effective. Transplant with a different donor of the same mismatched haplotype will not be effective. So you really need to mismatch for the other haplotype. So this really has a very significant clinical implication in management of relapse. This is a summary table we have in the article for the clinicians. We say that basically chimerism testing is used mainly for two reasons, either for engraftment monitoring or for detection of relapse. And if we look for relevance, engraftment monitoring is done for all transplants, particularly non-myeloablative transplants and those with increased risk of delayed or failed engraftment, while detection of relapse is done particularly in relapse and diseases with high risk of relapse. The high sensitivity method, having high sensitivity methods such as NGS or digital droplet PCR, is not particularly necessary in engraftment monitoring because anything above 95% is considered complete engraftment, but it is highly, highly advantageous in detection of relapse because you are looking at very minute changes in recipient chimerism level. Time points in engraftment monitoring, we do at 30, but if there is delayed engraftment, like in courts or otherwise, then we need to test further out at 60 days. In detection of relapse when clinically suspected, HLA loss relapse method is not relevant in engraftment monitoring, but highly, highly relevant in detection of relapse. So we also had a workshop last month for correlating different chimerism outcomes using different methods with different clinical outcomes. So in summary, DSA is a significant risk factor for primary graft failure. Results of HLA antibodies are dynamic and decisions need to be made on current sample. Different methods of chimerism testing have strengths and limitations, and method selection must be informed by the clinical application and the availability of resources. Thank you.
Moving to our next presentation, we have the Dr. Gregor Hormon. He is the head of the phenotype diagnostic at the MLL Muniz Leukemia Lab. Please welcome. His presentation focuses on the role of the hematology lab. He will focus on cytology, cytogenetics, flow molecular, and RID. Please welcome Dr. Hormon.
So thank you very much for the invitation and the kind introduction. I hope that you all can hear me and see my screen.
We can hear you. We don't see your screen yet. It was already there?
Can you see the screen now?
Yeah, yeah. Perfect, thank you.
Okay, great. Thank you very much. So I'm deeply honored to discuss with you the role of the hematology lab in this context. At the Munich Leukemia Laboratory, we are following an integrated approach in the diagnosis of leukemia and lymphoma, combining various techniques that, on the one hand, assess the phenotype of the cells, but morphology, immunophenotyping, and on the other hand, comprehensive genetics, starting with conventional chromosome embedding analysis in fish, and integrating a number of molecular techniques that you will see later on. With this, we process about 150,000 samples per year of patients with leukemia and lymphoma. And of course, allogeneic stem cell transplantation is here of utmost importance in the guidance and treatment decision. When it comes to the main questions that we are asked in the hematologic laboratory, well, on the one hand, we have questions regarding correct diagnosis, prognostication, prediction of specific type of therapy, and then ideally, after successful treatment, the question of MRD, of measurable residual disease, or minimal residual disease. Let's start with the first, with a diagnostic and prognostic approach. I will use the example of acute myeloid leukemia to outline some of the techniques that we are using here. Of course, it starts with a very straightforward approach, conventional cytology. Pappenheim staining is here helpful to distinguish the various types of hematologic cells and neoplastic cells, and there are some mnemonic features that allow us to really identify here clear-cut diagnosis. Of course, this can on the one hand be done manually. You just need blood and bone marrow smear, you need manual staining and the microscope. On the other hand, it can also be heavily automated, like for example used in our laboratory with automatic acquisition of the slide and AI, artificial intelligence, supported workflows for cell recognition and reporting. In the context of, for example, acute myeloid leukemia, what are we looking for? Of course, the blast cell count, some clues about the lineage differentiation, and regarding therapy, of course, the definition of complete remission that also heavily relies on the morphologic assessment of the blast count in the marrow in the peripheral blood. Moving on to immunophenotyping, of course, in nearly all cases, we need a complementary approach in addition to cytomorphology with immunophenotyping to have a more robust assessment of the malignant cells. Flow cytometry is in place in nearly each and every hematologic laboratory. The main questions that we are asking here is, of course, also the quantification of pus of potential cells, particularly lineage determination in acute leukemia. It is very helpful for assessment of B-cell and T-cell clonality, and we will discuss later on, of course, the setting of MRD, where flow is one of the backbone techniques to assess the therapy response in our patients. The workflow of immunophenotyping, again, can be manual or heavily automated, depending on your specific needs. Basically, a staining approach with the various antibodies. You will need some IT assessment that is helpful to bring this in your laboratory information system, and then you can measure the cells in your respective cytometer, do the analysis, and issue the report. In the context of acute myeloid leukemia, again, a set of markers needs to be assessed for the proper lineage determination and to have here a robust diagnostic approach. Of course, phenotyping is not necessarily enough to come to a final conclusion. Again, in the context of AML, you know that the vast majority of AML subtypes is now genetically defined. In the latest WHO classification, we had about 85 to 90% of all patients that fall within this category of AML with defining genetic abnormalities. And for this, we need a comprehensive molecular and cytogenetic workup. Let's start with cytogenetics. chromosomal bending analysis, a very old and well-established technique. It is a workflow lasting at least 3 to 4 days, relying on the cultivation of viable tumor material with various steps in between, quite a complex and laborious workflow, and in the end, after fixation of the various metaphases, you have the pictures of the chromosomes and use these to assess the karyogram with respect to terminal operations. Again, this can and is augmented with artificial intelligence in our laboratory to discriminate the various chromosomes. This is very helpful in our hands. In many cases, we have a complementary technique in addition to chromosomal bending analysis, namely FISH, with specific probes that are, on the one hand, helpful to clarify unclear cases from chromosomal bending analysis, but are also very helpful in cases with not enough proliferation, as FISH also can be assessed on non-proliferating interface cells and can therefore complement the techniques from cytogenetics to complete picture. In the context of AML, cytogenetics is of course of utmost importance to define the specific AML subtype. In particular for AML, myelodysplasia related is defining for some of the patients, but also for other specific genetic operations. As you will see later on, when you're aware about the ELN prognostic classification, it is of utmost importance to combine here various cytogenetic and molecular approaches to come to a final prognostic assessment that in turn is highly relevant for the question whether or not to go for an allogeneic stem cell transplantation with the patient. Molecular techniques, you also have heard about some of the techniques in the previous talk. We need a comprehensive molecular assessment to get an idea of all the recurrent genetic operations. That is again helpful for prognostication, but also for MRD monitoring. With molecular, we have a combination of various techniques. On the one hand, PCR-based techniques, in particular relevant for MRD monitoring. On the other hand, sequencing-based techniques, next-generation sequencing, that is helpful for comprehensive assessment. This is an example of a comprehensive myeloid lymphoid gene panel that is used in our laboratory to assess, on the one hand, small single nucleotide variants. On the other hand, it allows also copy number assessment and is helpful for this comprehensive approach. So this combination of additional molecular genetics, again, is relevant for disease classification in the context of, for example, AML. It is highly relevant for prognostication. In addition, we have some potential treatment targets, in particular FLT3, ITD, and tyrosine kinase domain mutations, but also IDH1 and IDH2 mutations that reflect direct targets for specific treatments. It is also relevant to pick up germline mutations that, of course, have a profound impact on the donor selection in patients with germline predisposition for acute myeloid leukemia. And as discussed, and we'll discuss also later on, of utmost importance for patients where we have a molecular marker follow-up in the context of MRD. Combination of these techniques, cyto and molecular genetic, leads to the classification according to the European Leukemia Net with 3 different categories of favorable, intermediate, and worse AML and the respective treatment approaches that we're following for those patients. So much about using these molecular and cytogenetic techniques for the context of diagnosis. What about therapy monitoring? What about molecular response? Well, minimal residual disease, or better, measurable residual disease, MRD, is of more and more relevance for patients for the question on the one hand, if patients should undergo transplantation. On the other hand, also for the post-transplant monitoring and to pick up relapse early on. Of course, cytogenetics and cytomorphology are here heavily limited. We have a very insensitive limit of detection and are not helpful for these approaches. So we are talking about approaches with limit of detection in the order of magnitude of 10 to the minus 4, 10 to the minus 6. And those are helpful to pick up low remaining malignant cells with highly sensitive techniques of, on the one hand, immunophenotyping, and on the other hand, molecular genetics. There are various guidelines for how and why to assess MRD in patients with AML and also how to interpret this. The latest guideline has just been updated with the 2025 consensus about MRD diagnostics in acute myeloid leukemia from the Ian and David working group, where we also have included, and these are the latest recommendations that we find here. It is strictly combined regarding the specific subgroup of the disease. So depending what molecular marker is available, you either have a recommendation for molecular techniques or for flow cytometry. So in the context of favorable risk disease, particularly with NPM1 or with the core binding factor AML, there's a clear recommendation for quantitative PCR as a well-established and highly sensitive parameter for MRD diagnostics. For long years, we know that the positivity of NPM1 in the context of MRD is the most important predictor of long-term survival in our patients, and this is a well-established marker for MRD diagnostics, of course. In the context of intermediate disease, we have on the one hand a new recommendation for molecular monitoring of FLT3-ITD with an ultrasensitive NGS approach. On the other hand, we use flow cytometry for the vast amount of patients with this group of AML. Flow cytometry-based MRD diagnostics combines two different approaches, different from normal and leukemia-associated immunophenotype, to pick up here the remaining malignant cells in the bone marrow of patients with AML after treatment. And again, this MRD positivity is known to be of high relevance for the long-term outcome of patients. In adverse risk disease, we again heavily rely on flow cytometry. In addition, we have at least recommendations after allogeneic stem cell transplantation for an ultrasensitive NGS approach. What does this mean? You can pick up a number of additional somatic mutations, and the vast majority of them is associated with some relevance in the MRD setting. This seminal study has shown that the combination of flow cytometry and next-generation sequencing improves the prognostic outcome of MRD data in patients with acute myeloid leukemia. So to summarize, this led to the current recommendations, where depending on the respective technique, we have clear guidelines and thresholds to define on the one hand MRD positivity or MRD negativity, and there is this new in-between category of low-level positive disease. In the typical setting, low-level positive disease is considered as a warning sign, where a short-term follow-up should be done with the patient. In contrast, in MRD positive disease at the respective time points or in MRD relapse after treatment or transplant, we have a high-risk setting that needs a comprehensive treatment approach, typically associated with allogeneic transplantation for the patient. So to summarize the part on MRD, the hematologic laboratory is here really helpful to guide the management of patients. We use a combination of flow cytometry, of qPCR, and high-sensitive next-generation sequencing to come to clinically meaningful and highly sensitive NGS and flow cytometry results that lead to the respective MRD levels and guide treatment of the patient. To summarize the role of the hematologic laboratory in total, we have an integration of both phenotypic and genetic methods that are highly relevant for the diagnostics of patients with leukemia and lymphoma. A comprehensive genetic workup has become more and more state-of-the-art for many of the diseases. It is helpful to pick up both prognostic and diagnostic, in some cases also predictive biomarkers that help us to ultimately guide the treatment of the patients. Follow-up monitoring, in particular MRD, with validated markers in molecular and immunophenotyping, is of utmost importance for the patients, and MRD testing has become a relevant tool helping to tailor the treatment strategies for individual patients and their risk profiles. So, to summarize and close here, this interaction of diagnostics and therapeutics is definitely the backbone of precision and personal medicine in hematology, and is moving the field forward and to optimize the therapy and the outcome of our patients. So with this, I would like to thank you very much for the attention, and I'm happy to take any questions or discussions. Thank you so much.
So thank you so much for the presentation. If you can stay online with us for a few more minutes, we will have a short discussion. Yes. Thank you. So I'm calling on the podium Didgurni de Wieser, Regia Belkedim, Amaryllis de Leon, and Kenneth Charles, please. Yeah, I think we'll be short because we know you are waiting for your lunch or your lunch is waiting for you. But we'll take a few minutes after these fascinating presentations, underlining, if necessary, the importance of biological findings in both indicating treatments, including hematopoietic transplantation, and following the response. So you are only free. You want to start? Go ahead.
I would like to ask a question. What is your experience implementing all the procedures for stem cells manipulation? And could you share your experience or insights about the key challenge and milestones you have faced from deciding or establish all the routine testing procedures, from the infrastructure until all the routine, for example, in the Dr. Gregor Hurman says, all the cytology, cytogenetics, flow molecular, and what is its importance?
So first of all, thank you, Dr. Herman, for having presented all the methods and possibilities you have. You are certainly, to my knowledge, the best laboratory in the world which can do all these things in 3 days. When I'm sending samples, even from the Ukraine, they are traveling per train to Poland, and from Poland to Munich, to the MLL laboratory, and then we have the results in 3 days. So this is fantastic. I never seen something like this. And the major point is that they are not only good in one technique, but they have all techniques together. And they can compare all the techniques for one patient. And the patient is the center, not the technique. And this was understood quite very early in Munich. So, of course, this is the best you can get. And if you are getting now on low-income country or middle-income country, perhaps you can give us some ideas. But I know that you have also some technical laboratories in Latin America, if I'm correct, or at least you have placed some machines in Latin America. So just tell me what you think on the scope, on the topic on low and middle income country.
Yeah, thank you very much. It's a very important question. I think it's of utmost importance to follow this patient-centered approach. And this can be followed both in the high and in the low-income country. You can combine the clear diagnostic question with techniques that are available also in low-income country. Cytomorphology is definitely widely available. The same is also true for immunophenotyping. This is definitely needed to add to this here. And then it comes to more complicated approaches in the context of genetics. In genetics, we have two main approaches. On the one hand, just PCR as a kind of follow-up technique. This is implementable also in at least mid-income countries. For next-generation sequencing, it has been a very expensive and laborious technique in the last years. The prices are tremendously decreasing now. We see new vendors out there, new machines, and it will be more and more available in the next years, also for diagnostics worldwide. So keep this in mind, have the focus on the patient, and on the other hand, try to restrict resources. Ask the question, how many labs do you need in your country? And with centralization, you can definitely use synergies here and to build up your workflows more efficiently than with a decentralized approach.
Can I make an additional comment? I think this is
A short one.
Short. This is very important because, as you know, we have now new drugs which are targeted, and this is coming very, very quickly in the AML field. So you need to have a diagnosis as soon as possible, and you need also to know the depth of the response. I'm sure that with venetoclax and with azacitidine, we will have a better complete remission as we had before. The data are not official at the moment, but they will come in the next ASH, I think. So this is something which is very important also for the patient.
What is available here, for example, in Panama in terms of analytical techniques?
Buen día, sí. Precisamente el tema, pues, le habla una persona que ha tenido experiencia con citometría desde 3 colores hasta hoy en día que ya hemos tenido, pues, experiencia con más de 13 colores. Y pienso que principalmente, pues, los desafíos es el presupuesto que contengan en los países para dedicar a esto. Pero si bien es cierto, algo importante es también ese equipo, ese intercambio de conocimientos entre el hematólogo que tenga el país y el equipo de laboratorio. En nuestro caso, pues los que hacemos citometría de flujo conocemos muy bien la morfología y eso ayuda también a integrar. En Panamá contamos con citometría de flujos, estamos practicando o conociendo lo que es la citometría espectral. También la enfermedad mínima residual estamos implementando y tenemos conocimiento de esto, sabemos la importancia y los beneficios que tiene la citometría con, por ejemplo, países que no cuentan con estudios moleculares, que son bastante costosos y también llevan tiempo, no 3 días como en Alemania, que puedan tenerse los resultados, pero la capacitación del personal que la realiza puede brindar al médico incluso algunas sospechas de posibles mutaciones hoy en día con los estudios de citometría de flujo. Hay marcadores que orientan a posibles mutaciones como la TP53, el CETPA, RUNX1, y eso ayuda mucho al seguimiento en la enfermedad mínima residual. Importante también contar con equipos que permitan hacer un análisis, adquisición de las células suficientes para llegar al umbral de sensibilidad que se requiere. Aquí en Panamá contamos con citometrías basados en los protocolos de Euroflow y también con otros de Beckman Coulter y otras marcas de citometría, de citómetros.
the Dr. Amarili says that here in Panama there is the test flow cytometry in the centers. She is one of the realized techniques. They use Euroflow. Also, there are molecular techniques in the Instituto Oncológico Nacional also, and in Ciudad de la Salud here in Caja de Seguro Social. They talk very much, have a specific conversation with hematologists, so they are very close, not are different entities. So there is enough experience. They have that support each other, and there is various available cytometers, flow cytometers here in Panama. So we have experience here in Panama, thanks to God. We have all experience, for example, by hers. And yes, he's in Panama. We have all these techniques.
Very quickly, I actually had the privilege of visiting the transplant immunology lab here in Panama. It's actually in this building, and it is a state-of-the-art. They actually have next-generation sequencing for HLA typing and chimerism, which is really more advanced than many labs in the United States, North America, and Europe. So take advantage of this available to you that can give you high accuracy and potentially detection of MRD.
Well, I'll just add, from a nursing point of view, it's very important that we know the requirements for the samples. Like, when you collect the sample, the correct tube, temperature, working hours of the lab. And like you were mentioning for the chimerism, do not forget to take the 3 samples, the donor, the recipient, and after the transplant, so we can do the follow-up of the disease and see what's going on with the patient.
And actually, one of the advantages of using NGS in chimerism is that sometimes you don't need the donor typing, because bioinformatically, you don't need pre-transplant sample, because bioinformatically you can deduct the typing of the genotype of the recipient and donor.
When you think,
I was just going to make a comment. Partly, the whole field is going to get more complex, and the demand for turnaround times is going to go up. And Andika's mentioned 3 days with MLL. That's great. That was a really prototypic single laboratory that does everything. But just to relay, in the UK, there are nice guidance in integrated hematology diagnostics. And it's meant that we've had to rationalize quite a lot. There are 7 genomic hubs, but other facilities have flow cytometry, but it means you can work in a network. The point I'm trying to make is it doesn't all have to be done in fragmented, small, high quality. I'm not saying the quality of labs is not high, but if you get everybody competing for each corner of Panama or each corner of Latin America, it's probably not going to achieve what you want at the speed. So we've gone with nice guidance, networked approach, and there has to be sharing. There has to be some places building themselves up and some places scaling down, because the field is moving so quickly.
Quickly, I promise. So actually, following on this point, I think especially using high throughput technology like next generation sequencing, there is a fixed cost. And if you are testing only fewer samples, then your cost per sample is very high. But if you are centralized testing in a whole country, ideally actually in a region of multiple countries, if you don't have such high volumes, then you really significantly reduce the cost per test.
Yeah. Thank you so much. Unfortunately, we have to close this session because we are already late, but you have the opportunity to further the discussion while having lunch. Thank you so much for sharing with me. Thank you to the speakers. and panelists, and enjoy lunch.
Thank you so much.
So there's going to be 3 announcements right now. The first one, the nurses group, you have already reserved room for your meeting. It's going to be number 42, and the first floor. You can take the elevators to the left where you take your lunches. The second announcement, in order to get back on track, we will have only 45 minutes for lunch, so we are going to start here 1:45 p.m. on the dot. And the third and final announcement, after you take your lunch, past the blue banner to the left, there are several stands that you can go. They're going to give you a little exposition. We have Mayo Clinic, we have the Panamanian Hemato-Oncology Center, we have the Panama Clinic, and many other stands that has laboratories and centers, so that you can have a little bit of knowledge of how we do things locally and something that we have prepared for you. So thank you very much, and we'll see you at 1:45. Para el personal de enfermería, queremos recordarles de que su reunión va a ser en el piso número 1, tomando los elevadores a la izquierda después de donde recogen el almuerzo. Piso número 1, salón 42. Es el salón que ha sido reservado para ustedes. Vamos a tener únicamente 45 minutos de almuerzo. Vamos a comenzar a las 1:45 y mencionarles también de que después de que retiren el almuerzo, pasando el banner de Ciudad de la Salud a la izquierda, tenemos varios stands. Tenemos Mayo Clinic, tenemos el Centro Hemato-Oncológico de Panamá, Panama Clinic y otros más laboratorios y centros de atención para que tomen algo de información de cómo se manejan las cosas de forma local. Muchísimas gracias. Nos vemos a la 1:45.
Do you have a spare program?
Thanks everyone for your cooperation so we can keep on track. Right now we are going to advance with session 9, 10, 11.
I'm sorry.
Don't worry. With session 10, Quality Assurance in ACT Centers with chairpersons Adriana Saver and Joseph Schwartz.
Thank you very much. So the first session will be an overview of principles of quality system in transplant centers, and we have the pleasure of having Carol Charlie here from UK to talk from the universe to talk to us for this talk. Thank you very much, Carol.
Welcome, everybody, and thank you. I've been asked to discuss quality management and to keep it basic. For those of you that went to that wonderful FACT-JC workshop on Wednesday, this might be a bit of a revision for you, but bear with me. So quality is a huge subject. So today I'm going to concentrate on if we can find out why quality is important in our speciality, briefly have a look at what quality is, then have a look at some of the elements that are required to be in a quality management system, and then have a look at, is your hospital quality management system actually efficient for your patient population? So is or why is quality management relevant to our program? Quality isn't just paperwork. It might feel like that at times, but I think it's more of a survival strategy. And many centres over the world now work within the quality international standards of FACT-JC. And these standards try to unify the clinical, the collection, and processing teams in one cohesive unit. Oops. I think our goal is simple. The right product to the right patient at the right time safely. So therefore, you could say that our mission statement is to maintain a culture of safety where every procedure is documented, every product is traceable, and every error is an opportunity to improve. To make this quality management system work, you actually need leadership and engagement, ensuring that top management provides the necessary resources and that all staff understand their specific roles and responsibilities. It's been proven that those centres in Europe that actually work to the international standards of FACT-JC and are accredited, that they have seen improvement in donor and patient outcomes by interlinking the quality management processes, clarifying responsibilities, and ensuring that staff engage with controlled documents. A literature search spanning from Mexico and Paraguay to the Eastern Mediterranean regions of Myanmar has shown that in low and middle income countries, the strategic priorities for the growth and development of HCT vary significantly from one nation to another, mainly influenced by available resources, healthcare challenges, and existing infrastructure. But those centres from the low-income and middle-income countries that have engaged with established HCT quality programmes for training opportunities and then adopted quality management protocols have also observed improvements in patient outcomes as described in this paper from Paraguay. So what is quality? There are many definitions, and on this slide there are 4, all cited from authors working within healthcare. Atkinson says that quality itself is not a static concept. In its dynamic form, it becomes a continuous improvement. But my favorite quote is from Beetleton, and this one has helped me to understand quality. Quality improvement is a combined effort with everybody helping, all the healthcare professionals, including patients, families, researchers, etc. So quality has been around for many, many years in many, many industries, and especially aviation, their quality management system tries to ensure that all aircrew have the same number of landings as they have takeoffs. However, in our clinical speciality, quality management is a relatively new concept compared with those familiar names of quality control and quality assurance that we have known. A quality management system should also include quality assessment, which evaluates quality performance against established standards, and quality improvement that serves as a framework to improve care. Every quality management system must have a framework, and our guiding principle, according to the FACT-JC standards, is our quality plan. It specifies who is accountable for each task. A vital aspect of this is traceability. We need to be able to trace back from the patient's bedside to the donor's initial blood tests and every reagent used along the way. A quality plan must list all the documents and policies and SOPs. These SOPs are like recipes. They improve with time. These documents are not static. If a process is being described changes, the documents must be revised and staff must be retrained before the change is implemented. The quality plan must also describe our safety aspects of the program. Any deviation from the protocols, SOPs, must be reported. The plan must also establish our outcome analysis to be performed and where they are to be reported to registries such as the EBMT or the CIBMTR. And this data benchmarking helps us to ensure our quality is on a par with international standards. The plan will also identify data collection, which is required to measure key performance indicators, such as 100-day mortality and the time to engraftment. And if our medium engraftment day shifts from 14 to 20 days, the quality management system should trigger an investigation. Is it a new reagent, a change in the freezing protocol? The data will tell us where to look. A quality management system should demonstrate how it is done, not as you imagine. And when you start putting a quality system together, it's amazing what turns up that you didn't know happens within your system. I'm going to miss that one. For a quality system to improve patient care, donor care, and outcomes, it is important when errors occur, and they will, that we should follow a just culture. This is a model shared of accountability that promotes an open, fair, and transparent environment that actually encourages incident reporting without fear of retribution. It's important that we do not punish the person, we interrogate the process and ensure corrective and preventative actions to close the loop on every error. I mentioned the quality plan is our guiding principle. So I thought I should just describe the plan a bit more in detail, because this is often the last document to be written, but it should really be the first. And I was very guilty of that as a quality manager. Now, unfortunately, there is no fixed template. on how to write this document. There is significant flexibility in its preparation, allowing your program to design the plan to meet best your organizational needs. But ultimately, it's there to enhance patient and donor and cellular care. It must provide a high-level overview of your organization, operations, and focusing on implementing patient improvement while remaining realistic and achievable. When drafting your plan, it is advisable to establish a working group. Therefore, each facility within the program should carefully consider how to effectively involve all necessary members of staff and stakeholders. Developing a comprehensive quality management system is often challenging and actually time-consuming. All documents such as policies, standard operating procedures, worksheets and forms are actually a foundation of your quality program, and they explain how tasks are undertaken and facilitate the effective operation of your transplant service. These can be paper or electronically based. But there must be an overarching document describing how to write, approve, review, and implement these documents, and these are often known as the SOP of SOPs or the living SOP. All documents must be detailed and clear enough for all staff to successfully follow and complete the task, and should be written by staff who actually know the procedure. Document control. All staff must have the confidence they are using the most recent document. Therefore, it is important to establish a document control system for the approval and review of these documents. No more pulling out of your pocket a scruffy piece of paper to see what levels the cyclosporine levels were last week. We've mentioned the importance that quality is a team effort, and this slide highlights in yellow areas where your nursing team and other multidisciplinary team members should be involved. This should be in the writing and reviewing of documents, audits, and quality improvement. Have you ever considered how many quality management systems are involved in setting up your program, or even within your own clinical setting? This slide shows how complicated the integration of quality management systems can be, and the importance of documentation that describes how the quality systems should be interlinked, defined, and responsibilities described, especially if you are a standalone facility. On top of all these facilities with their own quality management systems, don't forget you have to look after your own quality management system. Good integrated systems should help to prevent transplant delays. Setting up a quality management system takes time, and it's important not to duplicate policies and procedures. Therefore, it's important to explore your hospital quality system to see if it is sufficient for your patient population. Please do not reinvent the wheel. Engage the hospital quality team to help you in this very important task. Now, I've chosen, and I wish I hadn't, the hospital policy for blood transfusion, because after today's talk and yesterday's talk, CMV negative products are probably not an issue, but you'll get an example why I've done this. Does the hospital policy specify the eligibility for CMV negative or irradiated products? Are the thresholds for blood and transfusion relevant to your patient population? If existing requirements differ for your patient population, then you should actually write your own policy for blood and platelet transfusion. This new document must reference the hospital transfusion policy to aid staff in the transfusion procedures. You do not need to rewrite it in your document. And additionally, other policies should be reviewed for their discrepancies and your own policies written. I've already mentioned that it has been demonstrated that quality systems within our speciality improve outcomes, but I also believe that quality protects all aspects of the programme. And looking at the FACT-JC standards for blood transfusion and cellular therapy, you will see that in the clinical standards there are many interlinks for this subject. The clinical unit must have a 24-hour access to CMV-negative products. Nursing and medical staff must be trained in blood and cellular therapy transfusion, and there must be policies in place within the policy procedures and the recipient care. So to conclude, I don't think that quality systems should be a burden. It is our safety net, and it's not just used as a tool for quality, it's also used as a tool for education for nurses and also medical staff, and also as an audit tool. I wish you well in your quality journey. Thank you.
Thank you, Carol. Our next speaker is Dr. Carlos Bashir. Carlos worked many, many years with the FACT office. He's still on the accreditation committee. He worked for many years at Sarah County, Nashville, and now went back to Puerto Rico, director of the program, and actually got them FACT accredited. And he helped many programs in Latin America with the stepwise program. So he's more than capable to talk about how to achieve ACT program accreditation in low and middle income countries. Carlos.
Yeah, thank you, Josie. Careful there, I'm not that old, okay? I meant to say that. It's been many years, and anyways. So this is gonna be an overview also. It's not gonna be detailed on standards. And I would like to kind of go briefly over what I think are the key components of programs that are starting in terms of trying to get accreditation. And then talk a little bit about where are we in Latin America with strategists looking to get accredited. So with that. So why do we want to do this? Obviously it's first to improve outcomes and patient safety. And we can outline 3 or 4 or 10 different reasons on how accreditation can improve that through different processes. But at the top of why we want to do this is all based on patients' safety and to make transplant better for patients. Obviously, it's the international recognition, right? So you have a group of inspectors and organizations that will come to your program and will validate that you comply with all of the standards, and that will show others that your program meets these international standards. And there may be some financial reasons as well. You may attract more patients to come to your program because they also feel that you have all the quality systems in place. And so observational study, it was presented or it was referenced on the previous talk. And it's again, it's only an observational study. It's not very well controlled, but this was done through the WBMT, through the European countries, and included more than 100,000 autologous and allogeneic transplant patients. And they look at what happened before, during, and after accreditation in terms of the relapse-free survival, and they evaluated other clinical outcomes, and showed that as you go through the process of getting prepared, getting inspected, and then after accreditation, that your relapse-free survival and other clinical outcomes improved. There has been other reports in other programs that they also have shown that as you go through these different processes, you improve or you can improve clinical outcomes. Okay. So what are some of the realities and obstacles? And I'm going to give you the perspective that I've been involved with a lot of the programs in Latin America that has gone or started the process of trying to get accredited with the FACT-JC standards. And I'll tell you what my perspective is, both first as having a program and directing a program in the U.S., and the reality, as Dr. Cruz mentioned yesterday, of what my new reality is now that I am in Puerto Rico, that again, we are a territory, but we are, we're a Latin American country in many, many ways. And so, we have, what you can see as you go through different programs in Latin America is that they are in different places in terms of what their quality systems are. From some of them very, very mature to some of them that are very, very immature, very early. There are obviously the financial constraints that we have talked about, needing to implement processes that may cost money. And so that always is, kind of towards the top of what the obstacles can be. You need to get people involved in quality, and in a lot of places, including the programs that I've been talking about quality, and everybody start running in 20 different places because they don't want to, it's just like something else that people don't usually want to talk about much, but it's really important, and trying to get that environment and getting all the persons that you need involved. There are regions and countries that have regulatory oversight. Argentina, the different countries that also have certain oversight regulatory-wise that controlled how they do transplants. And then it's the understanding of what the standards mean. It's another, you start reading through these standards, you try to read the manual, and there's still at times confusion in terms of what is it really that they're trying to ask me in this standard. So I think those are the main obstacles that I've seen as I go through these different programs. So let's just go over 4 or 5 of what I think are the key issues or the key components that as you start getting your transplant program through accreditation or trying to implement quality systems, you need to have. So first you need to identify who are going to be the key players in each of the components of the program, from the clinical collection, processing, data, and some of the other services. And just identified who that key person is going to be, either the director of that program or a manager or someone that is important and has the oversight of that program, and get them involved in your accreditation process. You need to start having regular meetings and getting all of this group together and discussing important aspects of what happens. And what I've seen in a lot of the program is that a lot of this is done, although some of clinical outcomes are measured. Sometimes they have different SOPs, but they don't always come together, all of the different components of the programs, to discuss those outcomes and summarize them and go over what they are. And so I think it's important to have those regular meetings of your quality team to go over outcomes, audits, SOP developments, and adverse event reporting, among other things. So you need to develop your SOPs, right? And so you can use the FACT and JC standards as a guide. You can incorporate some of the SOPs that you have from your institution to when they are applicable. That was mentioned before. Just make sure that you don't, you don't duplicate SOPs or forms that are already in place in the hospital. And then, so one of the aspects that made it easier for our program in Puerto Rico to get accredited is that, and don't tell anybody in Sarah Cannon this, but I brought all of the SOPs from the Sarah Cannon program. Put them all in an outside, in a memory stick, in an outside memory, and I brought them all to San Juan, and we used them as templates. And I know, you write these SOPs and you feel like they are your baby, right? Like, don't touch it because I'm gonna kick you. But one of the things that we may want to think about in the LABMT is just to develop a repository or a template of what these SOPs are, so that we can help programs as they start, getting all of their systems in place, getting the SOPs, an SOP template that you can start with. And then document control, which was discussed, right? So you need to have a document control. You can use the hospital document control system, but just make sure that that they include components of the BMT cell program. Have audits, and just make sure that you start with the basic audits that are required under the standards. This is for the clinical program, but similarly for cell processing and collection. And then finally, just have a system for reporting of adverse events, right? So things happen in the hospital, and we don't necessarily write them and discuss them as a group. It's important to have a system where you report, report, and correct adverse events and problems that may happen in all components of your program, and then just have an educational sessions and systems to educate nurses and physicians and other staff. So where the hell do we start? Or what are the it seems like a project that it's very hard to achieve. So you first need to make the decision, right? You need to want to say, well, I want to do this, and it requires work, but it's doable. But you need to first want to do this. You need to discuss it with your hospital, right? There are some resources that you're going to need from the hospital, and they need to buy into this. Try to identify the quality manager. That doesn't necessarily, ideally, will need to be a person that is just that just has that role. That is not always possible in our programs because of lack of personnel and resources. And you need to use personnel that already is doing other things. But one of the key components of trying to get accredited, in my opinion, is identifying that the quality manager person that is going to drive this initiative. Evaluate cost, get key personnel involved, as I mentioned, review the standards. You can perform the self-assessment. There is now the 9th edition of the standards just came out, and they are translated to Spanish, and Federico is translating the checklist. He said that it will be ready by next couple of weeks. So you can start there. Just have a self-assessment. It will tell you the questions that you need to answer on your program, and it will tell you what's lacking. What is it that you don't have, and then just use all of the resources that we have with FACT and JC in terms of personnel and other resources that are available in their platforms. Just an example of the self-assessment tool. That you can will ask you a question by standards, each questions that you need to have in your program, and then you just go through the different standards on each of the different components through this self-assessment tool. It takes time. This is a timeline of what typically happens in a program in the United States or Europe in terms of when they start. Their first accreditation. It can take as long as 2 years. And it may take longer in some programs in Latin America to get through the whole process. But at some point we all need to start if we want to do this. So just a brief kind of update of where we are. So FACT and JC came together. John Snowden was we started doing this. How long has it been, John? It feels like it's been it's about 10 years. It's been a decade, and so it started because programs in Latin America were looking to FACT and to JC in terms of advice in terms of how to get through the accreditation system, and so we came together about 10 years ago. And developed or identified components from both FACT and JC, and to develop systems to have accreditation programs in Latin America. went through the standards, divide them in steps initially 3, now 2. And it has somewhat evolved over time. It was supposed to be a pilot program. It's a pilot program that lasted 10 years, and I think it's coming to an end. And we're trying to define what next steps are in terms of how we want to move forward. Ideally, we would like to continue moving forward as a combined effort, but you know, we are in discussions of what would be next steps, and in terms of how to continue this initiative. There are discussions about whether moving from 2 steps to just 1 step. And you know, for programs that have gone through this, once you go through the work of doing the first step, which is about 75% of the standards, the second part, or the second step, it's relatively not as heavy load as the first one. And what has happened is that you have these 2 steps, and it just makes the accreditation so much longer, because you do it for 2 years, and then you need to wait 2 to 3 more years. And it has taken really a very long period of time for these programs to go through the accreditation process, not only because of the step system. There are other problems that has happened on both ends, in the program and on the FACT and JC side. But there are some discussions on whether is it really efficient and worth separating this into steps, or just doing it under one. Again, most of the standards are on the first step, and additional efforts are in place now to educate programs and to get them through understanding these different standards. 9th edition, we have been fortunate now to start developing regional inspectors, which I think is going to be critical as we move forward, to have inspectors from our own regions, so that they can go to programs in different areas. It may cost less, because you avoid travel. So we need to continue working on regional inspectors. And then on the programs that are, So these are the programs that are currently accredited. Brazil has 3 programs. Mexico has now 2. The program in Monterrey, and more recently, which is not included here, the program in Puebla. Again, the program in Puebla now has been accredited, fully accredited. And then in Argentina, there are 2 programs, the one in Cordoba and Hospital Italiano. And then there are other programs that are in the process. Hospital Austral, there are 2 programs in Uruguay, pardon the misspelling there. And then there is a program in Cali, Colombia, that has also gone through inspections for the first part of the step systems. There is a portal that is now being used. I think it has made easier the process of getting the information that you need to submit for accreditation. It's relatively friendly to use, and they are in Spanish, and there are tutorials that can be used for training on this portal. There are other educational resources, both on the JC side, as was mentioned before. There are webinars that are also being used. Let me just go. I think I skipped one here. So the LABMT has a quality committee that started or met for some time and then stopped meeting, and we started meeting again. There is a new questionnaire that is going to be sent to programs to ask the components about your program, numbers, quality systems in place, and also interests on whether you want to achieve accreditation. And we're going to start sessions again that are going to be monthly. You will hear more about this in terms of webinars and other educational programs for programs in Latin America that would like to become part of these quality systems and get on board with accreditation. And I think with that, I will end. I think
Thank you very much, Carlos. If you want to wait down, we have one, or up, whatever you want. We have one last question that we have the pleasure of seeing on Zoom, Dr. Monica Freire, that will talk about labeling and traceability of cell products, how to implement ISBT 128 from ground up.
Good afternoon, everyone. Thank you for joining the session. I'm honored to be part of WBMT 2026. Thank you very much for the invitation. And right now, I'm going to share my screen.
It's coming up.
Can everybody see?
Yeah, it's coming up, and it's wonderful. We just can see a border. I don't know if it will bother or not. It's PDF, I guess.
Yes, it's a PDF. Is it okay, though? Can you see it okay?
Would you just test to do the next one?
Yeah.
All right, perfect, working. Thank you very much, Monica. Go ahead.
All right, so thank you very much. Today I will be presenting the topic labeling and traceability of cereal products, how to implement ISBT 128 from the ground up. I'm pleased to have the opportunity to share information about the implementation process, along with a candid look at the realities of the process. Now, with your permission, I will turn off my camera to prevent any delays due to my internet connection. All right, so let's start. A disclosure, I work for ICPA, the non-profit organization that develops and manages the ISBT 128 standard. The objectives of this presentation are the following. 1, explain the 3 key steps for ISBT 128 implementation: research and register, design and notify, implement and stay current. 2, describe the minimum ISBT 128 labeling requirements for implantation. Collaboration is essential. Involving all the relevant staff early on provides the right foundation to move forward confidently in the process. Now, let's look at research and register, assess current systems. Every organization is different, and there is a wide range of approaches in use for labeling and tracking cellular therapy products, from manual, paper-based, to worksheets, to laboratory information systems, and even fully integrated electronic health records. This assessment step is crucial because it helps determine how ISBT 128 can fit into the current system. The reality is that in some situations, integration is relatively straightforward. In others, it can be much more challenging. Now, next, it is important to identify what is needed for implementation. This might include no equipment, in-house software development, outsourcing software development, or purchasing commercial solutions. Putting this information together provides a valuable reality check. It gives an organization a clearer picture of the effort, resources, and investment required to move forward with ISBT 128 implementation. During this assessment, facilities can use the licensed vendor lookup tool on our website to find vendors for software, hardware, and labels. And now that you are familiar with ISBT 128 and have assessed your current systems, the next step is to register with ICPA. During this process, facilities will have the full support of our accounting team, which can be contacted at support@icpa.org. Registration involves a few steps. 1, complete and submit the facility registration form. 2, obtain your facility identification number. 3, sign up for our website member account. And 4, access the ISBT 128 product description code database. That completes the step 1, research and register. Now we are ready to move on to step 2, design and notify. We will begin with design compliant labels and integrate software and hardware. I'm going to use a nature analogy to illustrate this point. So just as an acorn needs water, sunlight, and nutrients to grow into a seedling, designing an ISBT 128 label also requires the right resources to ensure compliance with the standard. All of these key resources are available on ICPA.org, and they include technical specifications for coding, reference tables and databases, terminology, standards for label design, support tools and resources, and expert review of labels and product code mapping. As we continue, we will take a high-level look at how each of these resources helps in designing an ISBT 128 label. So let's get started. Together, we're going to design an ISBT 128 label for HPC Marrow. To begin designing a label, we need to learn how to encode product information. To do that, we need to refer to the ISBT 128 standard technical specification. The technical specifications are precise descriptions of how to encode product information in symbologies such as code 128 and data matrix. When labels are designed, product information such as the donation identification number and the product code is encoded using data structures. This slide illustrates how the donation identification number and product code are encoded within a data matrix symbol. Now, the next step is to refer to the relevant reference tables and databases because they help us understand the meaning of the codes used when encoding information. In this slide, the code A9999 has no meaning until it is interpreted using the registered facilities database. In this database, A9999 is the code for ISBT 128 validation sample theme, and the code S1122 also has no meaning until it is interpreted using the ISBT 128 product description code database. An excerpt of this database is shown on the screen. In this database, S1122 is the code for the HPC Marrow product described on the screen. We will review this product description in more detail on the next slide. And now we need to understand the precise meaning of each term used to describe a product. These terms and their definitions are published in the ISBT 128 standard terminology for medical products of human origin. An excerpt of this document is on the screen. In the example shown on the slide, we can see the definitions for each term included in the product description. So at this point, we have encoded our product information, obtained the necessary reference tables and databases, and we understand the terminology used to describe our product. So the next question is, what do we print on the label and where? To answer that, we need to consult, in our case, the ISBT 128 standard labeling of cellular therapy products. In ISBT 128, each product category, such as tissues, blood, and cellular therapy, has an associated ISBT 128 standard that includes specifications for label size and information placement where applicable, as well as the minimum required information to support product traceability. On this slide, we can see the minimum requirements for cellular therapy labels. We will look at this in more detail on the next slide. For cellular therapy products labeled with data metrics, the minimum labeling requirements are the following: electronically readable donation identification number and product code, eye-readable donation identification number, in this example 8999926123456, with flat characters, in this example 12, rotated 90 degrees clockwise, and the check characters, in this example T, within a box drawn around it. Also, the eye-readable product code, in this example S11224B0, preceded by the word product, and the product class name, in this example HPC Maro. And there you have it. Together we have designed an ISBT 128 label for cellular therapy products with the minimum requirements. Now, as shown on this slide, ISBT 128 also supports flexible label design for cellular therapy products. However, the minimum required information for traceability must always be present, regardless of label size or layout. ISBT 128 standards relevant to cellular therapy include the standard for the Global Registration Identifier for Donors, or GRID, which identifies the specifications for printing and encoding the GRID. On the screen, we can see some label examples. Additionally, ISBT 128 has developed a standard labeling of apheresis collection products for sponsored cellular therapy clinical trials and manufacturing. We can see an example on the screen. ICBA has also developed several support tools and resources to assist users during the implementation process. One of the most useful is the product lookup program, and there is also the Quick K calculator along with other several tools. All of these can be found on the resources on the ICBA website. Once your labels have been designed, whether in-house or by a software vendor, it is highly recommended to submit them to our technical team for review. The team will ensure that your labels fully comply with the ISBT 128 standard, and they can also assist with mapping your existing product codes to the corresponding ISBT 128 codes. And finally, when designing label, please remember to consult all applicable regulations in addition to the ISBT 128 standards. Regulatory requirements always take precedence over ISBT 128, and compliance with them is absolutely essential. Now we move to the next step, notify stakeholders of upcoming changes. This is another critical task. Conducting an impact assessment at this stage can help identify how each stakeholder will be affected and what their specific training needs might be. To conclude the design and notify the step, please remember to consult with ICBA whenever needed. Our technical team is always ready to help, whether via email or virtual calls. Reaching out to ICBA early in the process can make a real difference. It will help you address questions or concerns in a timely manner and can save your organization valuable time and resources down the road. And now we will move to review step 3, implement and stay current. There are 3 important components here. First, validate software, equipment, processes, and labels. Every facility should perform validation to ensure that all systems accurately encode, print, and read ISBT 128 information. To support this, ICBA has developed several resources, including a validation tool for ISBT 128 data structures, which provides practical guidance for validating software. During the validation process, it is also essential to consult the national guidance documents in addition to the ISBT 128 materials. These national documents play a vital role in aligning the ISBT 128 global framework with each country's regulatory requirements, local systems, and day-to-day practices. On this slide, you can see a few examples from Canadian Blood Services, the United Kingdom, and the United States Consensus Guidance for Cellular Therapy Products. Now that the validation is complete, the next step is to train staff and implement the system. Visual training materials are especially helpful. They make it easier for staff to understand the changes and quickly become familiar with the new labels. The examples on this slide show training materials used in New Zealand and at Florida Blood Services. Finally, please remember to stay updated with ISBT 128 developments. Subscribe to the ICPA monthly newsletter for the latest updates, including new codes, terminology, publications, and upcoming webinars. And please also follow ICPA on social media to stay connected and informed. So let's bring it all together. Implementing ISBT 128 happens in 3 major steps. Step 1, research and register. Take the time to understand the standard and lay your foundation. Step 2, design and notify. Do the hard work of building your system and engaging your stakeholders. And step 3, implement and stay current. Validate, train, and maintain. Is it a lot of work? Absolutely. There is no point in pretending otherwise. This is a complex, resource-intensive process that touches every part of your organization. But as you move forward on your implementation journey, take confidence in knowing that there is a clear path, there are tools, and there is help available along the way. Thank you so much for your attention.
Thank you so much, Monica. If you want to stay with us, we'll call our panel. That'll be Christian Chabanon from France, Eugenia Trigoso from Spain. If you want to come up, and Diana Cedeño de Panama, Alexis Cruz Chacon de Puerto Rico. Thank you so much. And Carol and Carlos, if you want to come up too. And we are open for questions. Muchas gracias.
First question, go ahead.
So, this is the question. How do you start? Alexis.
Just need a mic. Yeah. I think it's not on.
I think it's good to talk about quality. Quality is very important as part of, if we want to have a good bone marrow transplant program, we have to think in quality. And it's important to think in that since the beginning. To give an example, in Puerto Rico, we get the FAD accreditation in February 2026, but the process to prepare, it took us more than 2 years. When we started the program in 2015, we did not implement, we implement quality measures, but they were not adapted to the FAD accreditation. And the program was working, we were doing transplant. But then when we decided we want to go forward with FAD accreditation, it was more difficult because we have to go back and start something that was not implemented at the beginning of the program. So any program that is growing or starting should be applying these standards, these SOPs, all this process since the beginning, even if they are not planning to pursue a FAD accreditation, which I think should be the goal for any program, especially in Latin America. We already have 6 programs in Latin America that are approved by FAD accreditation. And I think that's our way to demonstrate that we have the capacity, we have the talent, we have everything that is needed to do things as good as any hospital in the rest of the continent or the rest of the world. And Mexico did it, Argentina, Puerto Rico now. I think it's important. Teamwork is vital to put every person in this team to work with the SOPs, the quality standards, and I think it's possible to do it in any country in Latin America. But quality is very important because it's what will make our service, our care to patients is what will give us better outcomes, and it will give our patients the opportunity to have a better chance of fight their disease and get a cure.
Yeah, and just to give everyone the reference, Alexis Tech, I think it takes 2 years no matter where you are. I don't think it relates to Latin America. When I joined Columbia University in 2004, the big Columbia University, there was no program, there was no fact, and they handed me the book of the fact and said, we need it. So I said to them, that's fine. I took a year, a full year, but at the time I said, I'm not implementing any other process, not blood bank, no apheresis processing. So it takes a long time, no matter what you are. I think that's really, that's true, yeah. And I think you had a question about Panama. Did you have any secrets for us?
Sí. No, en Panamá, obviamente no estamos acreditados con FAC y YASI, pero los estándares que nosotros utilizamos son similares, o sea, estándares nacionales adaptados a los que tiene FAC y YASI. Por ejemplo, nosotros en Panamá solo somos 4 millones de personas, entonces no tenemos todo centralizado. Por ejemplo, criopreservación en un hospital, las pruebas de HLA en otro hospital, la irradiación de componentes en otro hospital, y cada uno de esos centros tiene su gestión de calidad. O sea que realmente, así como comentaron que deberían ser reuniones mensuales, nosotros la tenemos bimestrales, lo de efectos adversos, lo de las actualizaciones, lo de los entrenamientos del personal. Pero sí, así es que trabajamos.
So for those who don't follow, that the problem is you follow similar quality standards, but the problem is you have everything spread at different services in different components of the BMT in different hospitals. Is that right?
Es correcto.
So, Christian, we didn't have enough time last time to get your opinion in the panel from the full cell processing facility point of view. Any pearls for getting accreditation, starting the process?
Well, actually, I think what I believe, we got the first accreditation at my center in 2008. And as an inspector, I did around 10 inspections, and now I am inspecting in a different system, which is OSCI in Europe. And what I learned on playing on both sides is that it works only if you can secure long-term support from your management, both at the hospital level or the blood bank level, institutional level, and the department level. Look at the body language of your managers. And you know whether it will kill all of your efforts or whether you will get support. So this is I think certification or accreditation is by no way a sort of, occult activity that is not as important as working for research and innovations and implementing innovations. It needs to be taken very seriously. And then, as you said, things move on. It takes time, but if you get support, there is a good chance you can make it. Management support is essential so that all people can work together, which brings me to your question. It doesn't make much sense to accreditate the cell processing facility by itself. You have to accreditate the whole program because you can make nice products, but if clinicians don't infuse them properly or don't follow up patients properly, this is absolutely useless. So this is a team effort that must be supported by management.
Well said.
Real question. At the time we applied for FACT accreditation, there was a line that said, before you think of FACT, you have to have, your hospital must be quality accredited by other institutions. It wasn't in the past. And I don't know if it still holds Or do you have to have like a joint commission or something different? No, no longer? All right. Used to? All right.
So, and I think I think it's important to mention that at least the FACT-JC standards are not prescriptive. So if you do a cryopreservation with no, with no freezing, like you showed us before.
So no cryo.
You just have to follow procedures, validation. I don't think any of the organization is prescriptive in any method that a person use in any facility. It just has to be valid methods, validations, audits, et cetera, et cetera. I think it's really important to mention. We are open to also questions from the audience, but until if someone, by the time they get them, again, yeah, you go all over the world and from the helping a lot of facility, a little bit of some advice from you.
Well, for me, the most important thing when you want one facility or a program want to be accredited, the first thing is be sure you want to be accredited.
Yeah.
That is the first step. And after this, you have to involve the entire team. It's not a physician business, not a nurse's business. It's a business for everyone. Everyone has to be involved, and the direction of the hospital. Because if the direction, the board, the hospital is not involved in the business, they are not going to be accredited. Never. First thing, because they have to pay, by the way. So it's important to have the entire thing has to believe in quality and to believe what they want to do. And after this, start working. Have a good quality manager, need the body language of the quality manager and everybody, but after this, step by step. But first is believe what do you want to do.
Yeah, that's true.
Yeah.
So,
I think there are things that we have to do because we have to have, oh, there's a question. Do you want to go first? You have to turn it on. No. Not yet.
It is now.
No,
Okay, just Carlos referred to this taking some SOPs and the quality management plan. It goes on all over. I think I would say share everything. I think Carol had a network of quality managers in the UK and they shared everything. There are these sort of companies that float around, aren't there? There was one from Italy that was trying to charge, several £1,000s to have templates. I think just share amongst yourself. It'll be cheaper. It's less work for everybody to share. So that's one thing. The other thing is about being a FACT or JC inspector. It's something that everybody should consider doing. It's only like once or every 2 years or so it's not incredibly demanding, but you do learn so much by visiting other units. And so get involved and get your hospital to support you because it'll pay off in your own accreditation. And the third thing about what really drives accreditation or the competition is that when the health service or the insurers demanded of a service, all of a sudden policy changes in a country and they say, well, we're not going to pay for your transplants unless you're FACT or JC accredited. And then it becomes a big competition. So try and get a bit ahead of that game, be one of the first in rather than one of the last in. It improves the patient care and it gets your team all together and ready for quality.
yeah, I would just say that there is now a paper submitted to the ASTCT journal that actually showing that if you have an inspector in your program, the program usually does well on the inspection. So we'll see if,
That's great.
And if you have to build up a history if you want to have an accredited service and a quality service within 5 or 10 years, you have to build a history. So you have to get CIBMTR or EBMT reporting It takes a while to have these contracts, to be able to send out data, to teach your data manager. So it's a lot of work. So it's something that you have to start right away. Having a quality management system and a manual for your own service. If you get the example from someone else, it may not work in your hospital. So having this history, it's also very, very important to work in this manual for you. There is a guide on JC and FACT that can help you, but you have to think of what are you going to measure. I work in a FACT accredited institution, and I worked through the whole process, and we decided that we are going to measure strictly what was obliged. We don't want to invent absolutely anything else. And after getting accredited, then we can move on and see what else, what you want to measure. But you have to have a history of measuring those same outcomes. So I know to know my survival, my transplant-related mortality, engraftment, so you have to have a history of all of them. And you also have to have ISBT 128. You have to get prepared, right, Monica? You have to buy it, buy the program, the labels. It's something that you also have to think ahead to have it. And also something that's not in our bloodstream, that is doing audits. We are not used to. You have to build up a system in the hospital where someone is checking the other one. And it's not to find errors, as to be sure that everyone is working with a proper quality. And we don't have people to come for audit from out of the hospital. So usually we check each other to be sure we have a definitely checklist, we know what we are checking, and one is checking the other to be sure that we are doing accurately. And so having it done it over and over and seeing which errors we have, why sometimes the data manager didn't understand what she was supposed to write down, and she kept on doing the same error. So you have to analyze your errors, analyze the reports. Every time something goes wrong, you have to learn from that. So having this culture in our institution is something that can actually have a huge impact on the care of the patients.
No, so I'll just also highlight two things. That one of them that Carlos mentioned, that it's nowhere written on these standards, no matter where you're in the universe, that you have to have a dedicated quality manager full-time. You have to have someone who does the function of quality, but this person can do other functions. So this is for cost reduction. It's clear that people think that, just to make sure that people know that this is the intent of the standard.
But it's very helpful to have one person at least for the whole hospital that knows quality, because it's a different background. And then you can have someone in your transplant program, usually a nurse, that would make the bridge between the quality system from the hospital and the BMT. So it'll be very knowledgeable in both sides, and then it'll be very helpful. But having at least one person for quality in the whole hospital, I would definitely recommend.
The other thing I will add, and it doesn't matter if you're going through the FACT and JC, because now I think the two organizations work very well together, because I think the idea is that to have more organizations being accredited, no matter who you choose. I think the idea is that both organizations in the offices have dedicated accreditation coordinators. So if you have a program like Puerto Rico, they have one person they can call with every question. So if you have a question, you don't understand the standard, you have one address, a call, email, text, whatever, and then if the coordinator that's assigned to the Puerto Rican program or to the Brazilian program does not know the answer, she'll seek for advice. So that's really a very helpful resource to every program, just that you know when you go to it, you have a person at your disposal throughout the process.
And it will be our next section, but really get reports, get CIBMT or EBMT reporting, because when you do the audits to get accredited, you have to have a history of having less than 2% error. And having someone who's not a physician that is reporting and is making mistakes, less than 2% of the critical fields plus random fields, it's very, very difficult. They really have to learn what they are doing, and it happens over time. No one learns from one day to the other, so it's really important to get to learn and to have the history of reporting, and we are on time. Any final comments?
Dr. Ko doesn't
No?
have any comments, so we are on time.
Thanks again to the speakers and the panelists. We're going to have our last break from today. We'll be coming back at 3:15 p.m. And the workshop is going to be titled Patient Donor Registration and Outcome Database with chairpersons Lauren Gardenet and Calixto Hernandez.
Thank you. Calixto?
Hello, everybody. So this is the end of the day, but we have a great session on registry, and this is important to establish a registry, if possible, with outcomes. So we have many famous speakers talking about great registries, and starting first with Dietger Niederwieser from Germany, Leipzig, on the role of registries in transplantation. Thank you, Dietger.
So, let me start with the first slide, if it's functioning. Not yet. No, that's not the correct one. That's von Anna Suveda. That's the bigger one. No? Do you want to come over here? Or it should come. Yes. Okay. So let me start with this. Actually, it's an introductory to the whole session, because you will hear a lot of registries, and you should come out of this room by knowing actually that's very easy and that we are all working on the same direction. So I want to start with the art of music to make it a little different. And you can see here in this slide that Mendelssohn Bartholdy from Leipzig actually was doing similar things, which also we are doing. So he was listening, he was writing, he was collecting, and he was producing and diffusing. That's essentially the things we are doing also in medicine. And you can see here that the whole art of medicine is observation. And to doing this, we have to observe, not only observe, record, tabulate, and communicate. And this was already described by Sir William Osler in 1849 to 1919. So this is something which we should know. And we are all doctors to advance medicine, and this is one of the most important ways to do this. So let me speak about randomized clinical trials first. You know, this is the flagship of science and this invaluable tool in assessing therapies, but it's not the only one. It is not possible in every situation. There are barriers, of course, of logistics, acceptability, small population, and if medicine would be restricted to data generated by phase 3 studies, we would not have a progress as we have now. So trials are also experiments. That means that this is not for the whole population. We have inclusion criteria, so we have an artificial situation designed to isolate treatment effect. So this may even be different from the effects in the real world in which the treatment is eventually deployed. So randomized study, for example, trials cannot analyze access, utilization, and trends, can identify prognostic factors in the general, but only in the population eligible, which is described in the protocol. Evaluate the influence of treatment centers. They cannot. they cannot efficiently study uncommon late effects. Usually the study finished sometimes, and what happened later, years later, decades later, cannot be looked or not usually looked in phase 3 studies. And the treatment effects of things that cannot be randomized. That means you cannot randomize if you have a treatment, not always against placebo, for example, if you have an effective treatment possibilities. So what are the real world data in contrast to phase 1, phase 2, and phase 3 studies? And you can see it here. These are electronic health records. They are laboratory analysis, claiming and billing database, and so on. But most importantly, these are the registries. And you will see here the registries. I would like to describe this in general. This is not, it's not easy. I tell you, everybody says, oh, I'm making a registry. That's not the way to go. Registries are quite complicated. They need definitions, worldwide especially, and they need also a lot of effort. So you can see here that the registries are systems to look at methods to collect uniform data for a population defined by disease, condition, or exposure, and that serves one or more predefined scientific, clinically, or policy purposes. So the advantage over other sources can be designed for research as a primary and not a secondary use, and the fitness for use can be determined also in registries. What they want to intend, what are the aim, the completeness of data and follow-up, the data granularity, the representativeness, easy, and data sharing. So we couldn't, if we don't have a registry, we couldn't know that we are now approaching we approached already 1.5 years ago, the 2 million transplants in 1957. So these were the first transplants done by Don Thomas, and you can see these are all registry data which are available. Or we cannot see actually who is making transplants in the world. That's what Dr. Frutos described, the white spots. This was Paraguay here for a few years ago, and now it's not a white spot, and we have to do this work in Africa. And we are quite positive because we are now setting up a registry in Africa, which is, I think it will work quite well. It also looks at the transplant rate per 10 million inhabitants. So you can see here the differences between North America, Europe, Southeast Asia, Pacific, Latin America, and EMRO. So there is space for improvement per 10 million inhabitants. So almost increase of 10 times to have an equal situation around the world. You can also look at the age of the patient here, data from CIBMTR. You can see that the donor age decreased quite significantly, 10 years younger patients in respect of 1919 to 1994. So these are all important information which we need. We have two essential registries, and I think you should keep this in your mind, please. The one is that we have a center-based activity survey. That means that one center is reporting the data in 1 year on one sheet. So, and we have here the pros and the contras. So easy acceptance is very high. Usually I did this for my department. The high capture rate, easy of reporting. The people are motivated to look at this. The crucial requirement for the efficiency is the type of registry, especially in developing countries. I always hear we don't have a data manager. This is something which the doctor can do, so I know how many transplants I did last year. It's very easy to fill in. So what is important in this case are standardized definitions. I know a very high income country which has a registry for transplant, and we have a registry also of EBMT, and we have a 4-time difference, 4 times higher, because this official from the state regulated registry is counting the bags and not the transplant. And so they are, if somebody has 4 bags, these are 4 transplants for them, so it's not really correct. These things have to be standardized, okay? And this is, I think, very important. And the rules must be accurately set. So this is quite important. And please don't make a new registry. We have enough registry around the world with different definitions, which are actually not, you cannot even compare it. From the scientific point, it's very difficult. You can see the strengths of one of these registry, which is from the WBMT, which, as you know, WBMT is an umbrella of different societies. So we are getting the data from our society, where we have a society in place. But in a place where there is no registry, we are helping them with our registry, which is now an electronic registry, and this is something which you will hear during this talk. This is quite easy, as I told you. One sheet here is for cellular therapy, but we have a similar sheet for transplant. The patient-based outcome registry, it's a more sophisticated way to report, and you can understand that this is sometimes it's 40 pages. You need a data manager there to do that. So there you can see all different things which you need, and the contrasts require extensive data management and sophisticated logistics. This too doesn't concur. In Europe, we used first the normal center-based registry, and then we matched even with the report of the outcome registry. So this is quite important. So the outcome registry is defined by a specific type of therapy. They capture in, for example, the CIBMTR is capturing 100% of allogeneic transplants. These are mandatory. The EBMT is almost similar. Allogeneic, the coverage in autologous is a little different because some of the autologous are not reporting in certain continents. You can follow the patients more than 50 years for thousands of patients. And there is a computerized error checks and reporting and audits which ensure that the data are correct. So if you want to read more about this, there is a paper which we published some 2 years ago, I guess, and there you can see the different indications also for registry. So thank you very much for this. This is an introduction, and Daniel Neumann will continue. He's online.
Yes, this was really nice. Okay. May I just continue, or there is something to say? So I'm just continuing. Is that okay? Can you hear me loud and clear?
Yes, Daniel, you just continue.
Okay.
We see the slides and we see you.
Oh, perfect. Hello, everyone. First, I want to excuse myself that I couldn't be around. Some circumstances hindered me of flying basically to Panama, but this shouldn't be the showstopper here. And as Dietka already mentioned, I would like to continue from the registry perspective and focus on the next step. So how does strong registries and activity captures are moving towards a governed, reusable, so to say, study evidence, because this is basically what scientists and researchers usually are looking for. So the core idea is simple. The EGTR, for example, is already a quite strong backbone for the multinational activity and registry reporting. And some sort of way, this is kind of like a preliminary thing of developing something like a study hub. And this is basically meant to sit on top of the EGTR as kind of a federated study layer. So this should basically allow scientists, clinics, societies, and registry groups to be able to register, join, create programs, define the intended purpose of the data capture, load and build questionnaires, and then create studies within the program. So the important principle is basically to capture the remains where it belongs, the ownership remains where it belongs, and also the study hub adds the governed study layer. So the EGTR basically tries to build the foundation here as being attractive because it brings together different reporting pathways. We have hospitals and centers, national registries, scientific societies, and also with the WBMT transplant activity, but also with the cellular therapies, so to say, multiple activity surveys. And this is already very valuable, highly valuable, because activity surveys work because they are feasible, standardized, accepted, and also scalable, or as Dietke mentioned, they are simply easy to understand and easy to fill out. And their intended purpose also is quite, so to say, straightforward. So centers or certified users can basically report directly. National structures in society can also coordinate reporting, and that gives us a global activity footprint, so to say. But when we move from reporting to study reuse, we need more than just the data values. We need to know also the intention behind the data that has been captured. So was a variable collected for an annual activity reporting, or for example, for something else, for registry follow-up, for example. So the session before already mentioned at least quality and quality management. And for the local quality management, you also have data that has been captured, and maybe the intended data capture is simply for quality management or for safety questions. And this is really essential to distinguish when you capture the data, for what intended purpose this is used, and for what it might be able to be reused, so to say. And this is something that has to be governed and basically also made explicit.
Daniel, can you face the camera? Excuse me, Daniel, we don't see you well. Can you? Yeah, much better.
Is that better?
Excellent, thank you, Daniel.
I'm very sorry for that. Thank you, Laurent. The next point is not all registries capture basically the structures, and they also don't serve the same purpose. So an activity survey is excellent for volume, access, utilization, and monitoring, and it can often achieve really a broader coverage and high acceptance. On the other hand, you have basically the patient-oriented outcome registries for the trajectories, the outcomes, the follow-ups, etc. And obviously, it gets even more granular along the way. So the scientific principle is that you don't collapse different capture intentions into one and the same variable without metadata. And I don't want to praise metadata too much, but it is possible to share data between registries, between surveys, when the intention of the data capture and also the intention is basically captured. And this is really essential. So right now we have a strong capture. Let's take the example of the EGTI again. We have the activity captures, centers report directly, national registries report, scientific societies coordinate everything, and certified users enter their data. At the end, we have basically the activity surveys filled out and scaled globally, which is, I would almost say perfect, but Helen, which has her talk after me, can capture the whole of that. The only thing that is missing, not just for the activity survey, but also a lot of outcome studies, is something we call the reuse gap. So if you want to reuse this for another purpose, right? For the activity survey, it's quite easy because the intention of this is also quite straightforward. But if you go towards outcome registry, you have to be, you have to think of what is the intent of the data that you have been captured and the data items you have been capturing. So the sharing is often manual and it changes live in the document's memory. So you don't have basically a whole library on steps. So what I would say is you need to have the meaning, the version, the purpose, the permission, and the provenance clear before you are being able to reuse the data. And this is basically what we are trying to establish with something like a study hub or something like that. So if you think of something like a study hub from registry capture to reusable evidence, because it's not really, how would you say, efficient to capture it just for one intention, but it would be good, and this is also basically the worldwide direction, to use the initially captured data for secondary purposes. So it's also necessary that you have the intent, what is captured and why it is captured, documented as well. So we in the eGTR, obviously we capture the activity, and we also know the context and the meaning behind it, because this is also given in the sheet. Right? But this is also what you need for every data capture, coming from patient-reported outcome measures to some other patient-reported registry as well. Also, you need the permission how much data you can share before you come basically to any sense of evidence that might be the result of a study that is ongoing. I mean, what already works is, right, we have the center reported activity, the national society pathways, the worldwide visibility, at least in the WBMT, in the eGTR, and we have standardized activity survey structure. And this is also something that kind of needs to be preserved and make study reusable in a systemic way, right? So what is still difficult is how can we share data not just manually, but maybe also using IT, and how can coding intentions made more explicit, especially explicit for IT along the way, because we have still a lot of manual work, a lot of documents, and a lot of knowledge simply in our brains, but not in the so-called metadata, right? And this is necessary to establish something like a reusable evidence. We need the context, we need the governance, and also the provenance of the data, and not just, so to say, the values that is being entered. Why this is meaningful? Because registries usually intend to live also for a longer way. And if you take just the AML, for example, as a coded value, right, which is quite useful, but you can see that along the last almost 60 years, the focus, the scope, how AML is defined and what is understood by it changes along the way. And those changes also need to be known to the ones who are basically making or trying to create the evidence from the data initially captured, right? Because AML in the 70s were quite differently defined at the end at the AML than in the 2020s. You can obviously scale from that. So it's really important that you know the context classification area, the risk model, the line of therapy, because only then it is safe to reuse it. Right? Obviously, this develops over time, but at one point of time, you have a decision where you say, okay, this definition of, let's say, AML as it is today is not sufficient anymore. So we need to change this for the simply capture of the data. Right? And therefore, it's necessary to know what was meant, who defined it, and when was it valid. Right? And this is something we are trying to push forward in EGTR, so to say, as well. So we are trying to add modular questionnaires, a governed study setup, a self-management, so people are a lot more self-confident and coordinate in their own respect, and also a secure execution. So we know the audits and the exports and the analysis readiness, so to say. Because the key is not just to add more boxes to the questionnaire, but it's making the capture purpose and the study reuse a lot more explicit, because this would help not just the clinicians or data manager who enter the data, because they don't have simply bigger questionnaires because they are not useful. They have one questionnaire, but they need to define the intent behind it, right? And not 10 more pages of questionnaires to be filled out. So therefore, we have a huge MVP architecture behind the EGTR, but I'm not going into detail behind that because this is a lot of basically technical stuff, but I can go into that if you're interested. But what we are trying to achieve is also getting a lot more IT-oriented flow, because a lot of clinics do have IT systems in place. And it's essential, and
Daniel,
we have also...
Daniel, we
Yes,
are running
sorry.
out of time. One more
Yes.
minute.
I just have one more slide.
Yeah.
We're trying to make this IT accessible. So you simply shift from the clinic system, the data, to the study hub in a standardized and interoperable way, right? And then we are able to also know who, when, why evidence is basically generated. So, like I said, this is my last slide. This is something we are trying to build upon, because you have the activity survey, you have the outcome registry, center and patient-based, but at the end, for evidence, you always need to think about the holistic, let's say, patient journey, and what has happened before you can create studies and make evidence out of it. So,
thank you very much. Thank you, Daniel. You stay with us, thank you. And now we're moving to Hélène Baldomero from Switzerland about the transplant activity survey of the WBMT. Thank you, Hélène.
Do we have the... Oh, here. I want to make sure I can use the... I'll wait till the slides come up. Oops, later on. I want to go back. Just with the pointer doesn't work? This screen, yeah. No. No, I want the green dot. Okay, doesn't matter. I'll be a human indicator. So you got a brief introduction there to the various levels of the WBMT Global Transplants Registry. I'm going to go straight in a little bit more detail into what it actually looks like, who's reporting the data, and then show you just a brief overview of some of the latest data we have. So, as you probably realize this already, it's maybe mentioned a few times, the data is provided by our WBMT members, the scientific societies worldwide. And they might be a national registry, they could be a regional registry, and currently, when we analyze the data, we will analyze it either at the global level, or the data that's reported within 1 year, or within the 5 WHO regions. And in 2022, that's the most recent survey year that we have, approximately 2,000 centres submitted data via their signed local, international, or registry, national, or centre level, reported data to their local scientific institutions and then onto the WBMT when we got data from 88 countries. So in alphabetical order, I'll just describe those regions. So the first region, the Eastern Mediterranean and Africa, that's the AFBMT, which is actually currently in development. We have some countries which have been reporting for quite a few years, and we have 4 or 5, maybe even 6, 7 countries that are going to start transplanting. These are the ones which are white on the map that we've seen a few times. We have the EMBMT, which is the Eastern Mediterranean group, and we have the new group of the P, that's Pakistan, Bone Marrow Transplant Registry. That's a national registry. This consists of 12 actively reporting countries. So when I talk about the number of countries and the number of centres, it's only those who are actively reporting. So if you have 5 centres in your country and only 3 actively report, then I will relate to 3 centres for that country. Then we have Europe, that reports their data via the EBMT. There we have 42 countries. Next, North America, which is Canada. We have the Canadian Transplant Group and USA, the CIBMTR. We have 2 countries. We have 12 countries actively reporting within the LABMT, which is middle. Also, middle and South America means from Mexico down and Cuba. And after this meeting, I think we're going to get a few more countries. We will get a few more countries. And with 20 countries reporting from Southeast Asia and the Western Pacific. So that's the APBMT, and then the Australian, New Zealand TCT. So this map you've seen a few times, but I'll just explain it a little bit more. So these are the 5 regions. So we have the Americas. So we have North America, Middle and South in blue. Europe, that's the continent of Europe. Some people will think it's the EU, but no, it's the whole continent of Europe, including Israel. We have the African continent in orange and the Southeast Asia and Western Pacific in red. So when we present our data, it will be either globally or usually within these regions. Oops. This is an example of the activity survey. This is an Excel version of the survey, which you can also download from the website. So you have the choice of entering your data directly into the database. But if you have many transplants in your center or in your country, that's actually quite difficult to do. So it's often quite useful to be able to fill out the survey, check your data, and then enter it directly into the database or submit it to your international registry, who will then submit it to the WBMT. So on the left, we have the main diagnosis for transplant. This is a transplant survey. And we've kept it quite simple because we've had 35 years of reporting data via a survey like this for the EBMT. And it's proven to be, if it's not too complex, you're more likely to be successful. We have the outcome registries, which can have the level of complexity that you want for most studies. But just for an activity of 1 survey per year, it's good to keep it simple. So we have the, on the left side going down, we have the main indication, the reason for the transplant. Across the top, we have the donor type, first the allogeneic one, so we have the family HLA identical siblings. Then we have the mismatch related, which are primarily the haploidentical donors. About 80% or 90% will be haplos. Then comes the unrelated donors, and then followed by the autologous, and on the far right, the totals. And then we have stem cell source, bone marrow, peripheral blood, cord blood. So it's relatively simple. And the data then is reported, like I said, via either the multiple various ways, the society, a national registry, an international registry, regional registry, and it's all by certified users that Daniel was talking about, where you have password access, and you only have access according to the profile of your authorized use. This is cellular therapy survey. This is a similar sort of format. You've got the reason for the cellular therapy on the left. CAR-T is the first column, and then we also, when possible, trying to collect data on other cellular therapies like natural killer cells, dendritic cells. The reason for giving it, we could be GVHD when it comes to some of the cell therapies, or it could be like for non-Hodgkin's lymphoma for the CAR-Ts. We do not collect DLIs because the DLIs are not an advanced cellular therapy. They're more a cellular infusion, as a result of a situation that's occurred after a transplant protocol. So they are not to be reported to the database. And so the benefits of reporting on the eGTR database, it's, as Daniel said, it's easy, it's user-friendly. We have automatic checks built in. You can correct any errors you might have made easily. There's a few analytical tools. It can support registry development in startup countries like we did in Pakistan, and obviously the LABMT have been using this now for about 8 or 10 years as their regional registry. It's been extremely successful in this situation. And you see secure access for authorized users only. So you apply for a role-based access, and that goes via your registry. A private person can't just apply for an access. And it could be center level, country level, regional level. And the data privacy really is ensured. So if a center gets a password to enter data, they can only see their own data. They can't see data from another center. And the same goes for a country. If it's a national registry, they can see their data, but no other country. And then we have the regional registries like the LABMT or the CIBMTR, or no, sorry, bad excuse, example that one, or the EBMT where we've got several countries. There, if you have a password access, you can see all the countries within your registry. And it's very important that it's not an outcome registry. It really is purely an activity, what you've done, and every year you report a single sheet. So this is what the database looks like when you log in. You've got 4 functions on the left, the home, which is this. You've got a data entry screen, an analytics screen, and then the centers where or depending on your access, can see the list of the centers who are reporting at the center level. So I know the LABMT will provide help and support to anyone who's reporting in Middle or South America. But Daniel and myself, who run the WBMT data office, are available for any form of help you might need. So this is what it actually looks like in the database. So you can enter the country or center or region that you want to continue to enter the data with. You select the year. You select whether it's an adult transplant data or pediatric transplant data or a center that does both. You can choose if it's a country, you can say how many centers are reporting to that country. For example, my country, Switzerland, we have 10 centers. So I would choose the European region, the country of Switzerland, and say 10, and enter the country level data. Otherwise, you would search for the actual center that is reporting center level data. You have the possibility to save a draft in case you need to walk away and you haven't finished. And you could, you can see that, I don't know if you can, yes, you can see it quite well. This is exactly the same format as that Excel survey sheet you can have access to as well. The gray parameters are the totals which are automatically generated, which enable you to check the totals at the end to make sure you haven't made a mistake. It's easy to make a typo. And then once you've submitted the data, it goes directly to the server. The cellular therapy data is exactly the same thing. You choose the region, you choose your country, the year, pediatric or adult data. It's a survey that I showed in the Excel form, and you do exactly the same process as if you were entering transplants. So for export, so the process of actually accessing the data is very, very similar. So if you want to export your function, we say LABMT want to do the analysis on the 2023 data. So the person who has the authority to do that would choose the Southeast, not Southeast, I can't remember, South and Middle America. They would choose the year, they would choose all the patient age groups because they report adults and pediatrics separately. You then press load data, and then you have a possibility of exporting an Excel-style survey format, or it's a list of countries with the totals across the top and the countries on by row. And this you can use. We've selected Excel because we find that's the best use for most people generally around the world if they want to manipulate the data and make figures. Okay. So now I'd just like to give you a brief overview of the most recent data of 2022. And you can't quite see the message at the bottom there, but it's unpublished data, and I'm afraid we can't share this with you outside of this meeting. The publication is being prepared, and once published, then it will be open access to look at the plots and the data. So as you can see from 2006, that's the first survey that we did for the WBMT. You've had a steady, constant increase until 2019, which was followed by the pandemic-related decline and subsequent recovery. And when you look at the autologous, which is the top line, the blue, you can see the pandemic dip, and then you can see a recovery. But the recovery isn't what would be predicted numbers. It isn't as high as the level we would have expected had we not had the pandemic. So this is obviously indicating that something else is going on. And I think, as you all know, this is probably most likely the introduction of CAR T therapies is causing the decline in the numbers of autologous transplants. And the moment we have the 23-24 data, I think this will be much clearer. When you look at the red line underneath, that's the allogeneic line, you have the same effect. You have a less of a decline, but then it actually, if you did a trend line there, it actually increases back to the levels had there been no pandemic. But also we're seeing actually even stronger decline there in 2022. Again, this is almost certainly used due to the other targeted therapies which are now becoming available. So look, now we always see division. Okay, I have to go a bit faster. So if you have this split now, allogeneic on the left, auto on the right, you can see the differences between the regions. These are the absolute numbers, and you can see a steady increase, even if the numbers are low, all regions are going up. And with the orange line on the left, and the allogeneic, that's the Southeast Asia. So in 2015, they had a strong increase in the number of centers reporting from China primarily. So here we have an increase in new centers, in addition to an increase of the centers that have been reporting since 2006. So it's not always easy to know if the activity is due to new centers. We have to know the number of centers, of course, or if it's an increase with new centers reporting or activity within the centers. Oops. So this is also a regional analysis. You can see on the left, Europe and North America have the identical number of more autologous transplants as opposed to allogeneic, also almost the same proportion. South America, Latin America, is the same as Europe and North America. But when you look at the Eastern Mediterranean and the Southeast Asia, they have a higher proportion of allogeneic transplants. So in Europe, North America, and South America, the main indication are the lymphoproliferative disorders. Whereas in the other two regions, they have a lot more leukemias and a much higher instance of transplantation in non-malignant disorders. So when you look at the donors as well, on the left, it's the overall unrelated and family. And you can see in 2014, the families overtook the number of unrelated. Looking at that in more detail on the right, you can see in the blue dotted line, that's the increase of the haplo-identical transplants coming in. And they've overtaken the number of family donors, the family sibling, HLA-identical sibling, which are now on decline. And it's not going to be long. It would be interesting to see, actually, if the haplo-identical transplants overtake the number of unrelated, or just maybe increase in parallel. So if we look at that also by donor, by region, you see North America and Europe are primarily unrelated transplants. We look at South America and Southeast Asia with the majority of haplo-identical transplants. In the session we had earlier about donor choice, they've already described the reasons for these things, so I won't repeat that. And interestingly, when you look at Eastern Mediterranean and Africa, they have 79% of HLA-identical sibling transplants, which is quite different to all the other regions in the global registry. Looking at the allogeneic and autologous, this is a pie chart of the 2022 activity. And the easiest thing to do here is to look at the colors. We have the myeloid malignancies in shades of green, the lymphoproliferative disorders, shades of blue, solid tumors yellow, and shades of red are the non-malignant disorders. And you see for allo, it's 56% myeloid malignancies, 26% lymphoproliferative disorders, and 18% for non-malignant. On the right, the autologous is quite different. 90% of the lymphoproliferative disorders, of which 57% of the plasma cell disorders, primarily myeloma. If you look at the regional level, and it's a detailed slide, but if you look at the colors, you can see in Europe, The proportion of green, myeloid malignancies, is very similar to North America. It's a little bit less in Southeast Asia and Latin America. And the same goes for the lymphoproliferative disorders, with on bottom left, LABMT, the highest indication of ALL for an autologous transplant. And on the right, again, Eastern Mediterranean and Africa have a completely different picture. When they have the majority of about 45% on non-malignant disorders. And for auto, you see also a similar thing, the dark blue are the plasma cell disorders in virtually every region, varying from 47 to 67% of the transplants. You have a higher number of non-Hodgkin's proportion of transplants for autologous within the Southeast Asia, the bottom right, and a higher number of solid tumors in Eastern Mediterranean. So this just gives you an example of, of what you can do with the data. There's many things you can do, but that was just an overall example of when you look at regional data versus global data, you can actually see lots of different patterns developing. And with that, I'd like to say thank you. I think I've probably overdone my time. Okay.
Thank you, Helen. Perfect on time. And now we're moving to the LABMT with Juliana Martinez-Roland from Argentina.
I want to thank Panama Society of Hematology and WBMT to inviting me. It's a great honor to be here. In this occasion, I will present transit transplant in Latin America. Let me see this. Wow. The conflict, no. Wait. Conflict of interest here, none, unfortunately. Yes. Latin America comprises a huge region that includes 20 countries. They share some aspects that language in most of them, but differ in others, like economy, health policies, and resources. Here you see the different amount of population that is very variable. I don't know how to... Here you see the life expectancy in Latin America evaluating in 2024. In April 2025, the result of the LABMT survey of the period of 2019 to 2022 were published in bone marrow transplantation. 12 countries participate with 166 reporting centers. More than 6,000 transplants were performed in this period. Oh. You can see in this graphic that haploidentical transplants continue growing, while matched sibling donor and unrelated transplant remain stable even in the pandemic year. That's probably due to the affordability and easy access of cyclophosphamide and the higher availability of donors in the family donors in the haplo setting. And in the other hand, in the unrelated settings, potential barriers could be cost, longer time to complete the unrelated donor cells procurement, regularity and administrative aspects. We analyzed 2022 separately to analyze the proportion of allogenic transplant by donor in this year. You can see that haploidentical transplants plays a very important role in our region. The allogenic transplant rate that Helen shows Chile as having the highest transplant rate. In the absence of outcome registries in Latin America, we conduct in November 2025 a survey focused in donor alternatives and center policies. We have a very good participation with 14 countries and 138 transplant reporting centers. In this figure, you can see the number of centers reporting over total centers registered. That's what Helen asked me 5 minutes ago. It was very good because 92% of the participating countries, we obtained the information between 50 and 100% of the centers. Here, do you see the topics in which the questions were defined? We focus, as I said, in the transplant modalities, center policies. About transplant modalities, 51% of the centers answered that they perform all transplant modalities. 33.5 all except unrelated donor, and then the less percent the other options. This could be reflect what I said before, the potential barriers to unrelated donors. The other question was about if in this patient that do not have identical matched sibling donor, what is your approach? 42% answered that they use identical donor as first option, and 57% initiate the search of unrelated donor, and if not suitable match is found, they proceed to upload transplant. No, falta una, ¿verdad? Sorry, I don't know why, no. I'm not going. Here. With the current evidence that's shown, as you comment, Dr. Neil Wizard, that donor age now is considered a very important factor, a prognostic important factor, we ask about what was the center policy in a patient who have older matched sibling donor. What would they choose, the older matched sibling donor or an alternative donor? And 49% of the centers used the old matched sibling donor, and 28% use proceed and upload transplant, or 22 an unrelated transplant. This is moving so fast, I think this is what would be changed in the next years. Another prognostic factor could be, for our region, the length of time between the initiating the search, donor unrelated search, and the procurement of the unrelated donor cells. 54% of the centers answered they need more than 90 days to complete the procurement of unrelated donor cells. 36%, 60 to 90, and 30 to 60 days, 13%. This changed with the years. I remember that in Argentina several years ago, we take more than 6 months, 6-9 months, and it was impossible to do those patients that need the transplant urgent with high risk, for example. And this was a very important barrier to perform it. Oh my God. It was the good result that PTCI shows as graft versus host prophylaxis. Some reports and some groups suggest that it would be possible to stop the immunosuppression early. There is no strong evidence about this, but we ask about what they do with this information. 42% of the centers maintain, in absence of graft versus host, obviously, 42% of the centers maintain 3 months the immunosuppression, 43, 6 months, and 15 more than 6 months. This, I think, is important to be analyzed in the future because we have not strong evidence if we can stop earlier the immunosuppression. We ask, no, wait. No, por Dios. We ask about regional donor registries. And here do you see countries who have donor registries and the activity of these registries. These are the donations in 2025. Individually, we ask the official costs of the procurement of the unrelated donor cells, and is very variability. Daniel of Redom told me that in Brazil, this price were not for native Brazilians, not for Brazilian people, but this data was I obtained. Wait. Haplotransplant today is considering a standard of care. Remains some concerns about cardiac toxicity with several protocols evaluating the dose reduction, and new strategies to prevent relapse were under investigation. I think that we have a long road in front of us with combinations with strategies to reduce relapse. I personally think the haploidentical transplant for Latin America was a very important issue because allowed that 95% of patients who need a transplant could have a donor. For us, I spoke by Argentina, but I think that is the same in the other countries. It were very difficult to find an unrelated donor by the ethnicity, by the cost, by the time of length to obtain. So it was a very, very milestone in the story. I think this is very important. Oh. About access to cell therapy. The economic impact. Manufacturing is very costly, as you see, with plus indirect cost, patient travel, lodging, caregiver, loss income. Cost increase more than $600 to $1 million to make CAR T cells. That makes difficult for us. Less than 4% of the centers in the United States are certified to provide CAR T cells therapy. Wide availability in US, in Europe, and in China. Different access across European countries, and limited access in developing countries. Brazil have approval of commercial CAR T cell therapy, protocols in Mexico, Brazil, and Argentina, and the gap between the Latin America and the rest of the world is driven by limited financial resources, infrastructure limitation, lack of regulatory frameworks, and insufficient governmental support. Cell therapy has changed therapeutic decision-making in the management of B-cell ALL, B-cell lymphoma, and potentially multiple myeloma. Cost continues to be a barrier to access. Policies to implement CAR T cell therapies are still lacking. Thank you.
So we're moving from Argentina to Chile. Mrs. Julia Palma. Thank you.
Okay. Thank you very much. Thank you for the organizer for this kind invitation, and Professor Nido Weiser and Professor Sebastián Galeano, because of the opportunity to show the work we are doing in the Andean region. I would like to focus you on the Andean region. This means from Chile up to Venezuela and Colombia, 6 countries. This is oncology pediatric patient population. This is not adults. This is very important for me because the focus will be in some way different. I don't have any conflict of interest, but I would like to share with you what means Orasconu. This is the Andean Health Organization Hipólito Unanue. And this is very important because the representative in this consortium are the ministries of health from the 6 countries. And this makes policy possible to be applied in the context of stem cell transplantation. For this reason, I would like to talk about the evidence, the framework, the registry, and policy and sustainability. How is my view after working in this field for many years and trying to see this from this different way. Why is the access important in the Andean sub-region? Because the incidence of children with cancer is 13.8 per 100,000 patients, and you can see that the mortality is very high. It is 6.8 for 100,000 patients, and this is important because the normal rate, mortality rate is 4.8, so it's 2 points higher. And for this reason, we must focus what is happening and why have we this disparity between this Andean region and this difference between the socioeconomical and the health system barriers, which is very important in our countries. And you can see that we have a framework of South-South cooperation between Orasconu, PAHO, and the GICC with the World Health Organization. And this is a framework we must have in mind and keep in mind also for the adults. It could be very important. You can see depicted here that we are 6 countries, and we found out in the survey that we did that we have 27 transplant centers in these 6 countries for children. 34 items were in this questionnaire with 150 questions for the centers, and this was a very important data collection. We did a survey and we published this data with the different things we try to measure. We ask about infrastructure and equipment, about workforce and training, about financing and coverage, quality management, barriers, and facilitators. And you can see how different it can be in the different countries of the region. Perhaps, for example, in Bolivia, we have 1.6% of the transplant we should do because they send them abroad to Brazil or to other countries. In Chile, we have 100% of the coverage done because we don't have waiting list for patients who need the transplant currently. Very important was TKMS in Chile, who started 8 years ago, and we have donors for our patients if we need an unrelated donor. So you can see that, for example, pediatric exclusive units, only 28%, mixed units are the others, and then you can see that only 50% of these different units have centralized real-time monitoring of the results. This means a centralizing the government monitoring of the results of the transplant activity, and only 4% of palliative care and pain management. So we visualize different barriers and facilitators. One is the high cost of the medicines. You can see, therefore, we have a facilitator that could be the regional collaboration. We were talking yesterday about this, limited infrastructure and certification. It was very nice, the talks today, how we can work together and we can have policies and laws for facing this. We have shortage of specialized personnel. This is also very important, doctors and nurses, and we can try to support this training. For example, in Chile, it was recognized a specialization of the nurses in oncology field, and now we are working for a nurse practitioner. Now the incomplete multidisciplinary team, this is also, we can face this with a quality management program and the unequal access to donor. this needs a national donor registry like we have in Chile, in Colombia, and in Peru. So the evidence is that we have inequity to access. We need to we need to have a data system to share this and to understand this a little bit more. And we need a policy, a national policy for stem cell transplantation. We need to short the gap. And for this, we decided to have one answer was to have big data, to have good data and to have a registry for the Anden region for the pediatric population. So this was the missing piece we found. And the view we had in the region was with the support from St. Jude I'm representing to have a multi-level assessment. We started to think about having a survey for the centers, to have a survey for the meso level for the countries, and to have a survey for the macro level for the region. This means the GICC region. And we thought this could be a product of the regional South-South cooperation. We published this, and you can see we could train with the transplant course we did. Indeed, Paula Viveros is here. She was the coordinator of this course, and we did a transplant course for pediatric patients with 28 classes and with evaluation, and more than 3,000 people were trained in the region in 1 year. 5 countries received the regional referral guide we are launching now in September, and this was very important because it was an Anden region guide for transplantation. Then we tried to map all the centers and the networking we have in the region for pediatric hematopoietic stem cell transplantation in Spanish. And now we identify all the different centers, and we are working very close with San Juan de Dios in Barcelona, and they are supporting us a lot. And now we started the registry. So each of these different 4 products was a product we did together with the people from this cooperation under the framework of the Cure All framework. Because you need to talk about centers of excellence, university health coverage, you need to talk about regimen of treatments, and transplant is part of the protocol of treatment of patients. It's the end part of the treatment, and then cell therapy if you need it. But it is part of those, you need to talk the same language. And then to evaluate and to monitor this with the registry. So why a registry? Because we need to measure, we need to improve locally, this is obviously, and we need to advance in knowledge, because this is the only way to do it better. And our focus was the HISTOS platform with 2 objectives. One was to store the hematopoietic stem cell transplant data for the 6 ministries of health, to have a dashboard to visualize all the data in real time, to build the HIS2 open source platform for the data collection. This is something we developed with the University of Chile with the mathematics and engineers, and to have a key factor to be configurable, multi-device and multi-level. This means you have a view from the micro level, a view from the meso level, and a view from the macro level. And this was interesting because we could build this registry from a micro center level, then from a meso country level, and then from a macro region level. This was our objective, and we could design 3 models and 1 platform in the HIS2. The model was a consolidation of each center, then a model of follow-up, because we included all the follow-up of the patients up to 5 years with 1 record per each patient, with automatic indicators across the transplant course, and a visualization of a dashboard with the results. And this means demographics, background, donor, transplant, in the different ways you can register all the data, because we use the EBMT and the Forum 1 study database for defining our follow-up and complication database, and the outcomes after 5 years. And this is a consolidated registry we will start in the next month. The first phase was to do this and to start the reporting for every 6 months, and to have on board all the centers and all the focal points. This means we work with somebody from the Ministry of Health, and from PAHO, and from Orascono for each of the countries, and then we have one representative for each of the transplant centers. This is important to have a network for working all together. And the second phase is the follow-up model per patient outcome with a visualization and the dashboard across the different three levels, micro level, meso level, and macro level. And the indicators of these are the indicators for transplantation for the Andean region for all the 6 countries. This is important because you have to invest and to see if the money you're investing are in the good place. And some 2 weeks ago, all the 6 ministers were in Lima. They had a meeting, and they decided that cancer is a priority. They will strengthen the information systems, and they need to compare data and to have tracer indicators. And this is important for this discussion because I was talking about this with Paula Friedrich, who is the leader for South America from St. Jude. I'm a sub-regional consultant for the Andean sub-region. And we were discussing how important it is to work together and to have a common view in order to try to have WBMT perhaps in the center and to make an input from all these different registries, not only from the diagnosis and the kind of transplantation, also from the follow-up and to work together. And I think this is a pilot study in the Andean sub-region for children, but it could be very important to work it together and to think that aligning indicators and standards to the Andean registry connects to the global network. I think this is important. And we used all the FACT-JC standards because when we started in Chile in 1996, one of the first guys who started in UK with the JC standards was in Chile. And he helped us to define how we can start the transplant unit in the country. And this was the way I started to work as transplant leader in the region. We have for finishing, 4 pillars to turn a registry into a lasting impact because you need sustained financing. This is very important. You need a regional cooperation because if you don't have this, it's impossible to reach it. You need data governance because of the laws. You cannot share very easy data if you don't have agreement with the different interoperable, secure, disaggregated data who are very important from the ownership point of view. And you need a political commitment. If you don't have commitment, you don't have resources for transplantation. So to build on the Andean transplant registry was very important because of this Lima meeting 1 or 2 weeks ago. And I would like to acknowledge the World Health Organization because of the GICC. 21 countries of the Latin America are part of this GICC. GICC means the Global Initiative for Childhood Cancer because cancer is very important as cause of death for the patients, for the pediatric population. I would like to acknowledge St. Jude Global and GICC and Cure All America. PAJO, because we work with them every day. Today, they know what I am presenting. They will ask me, and they are very pleased to work together with this organization and with WBMT. I presented this data to Sebastian and the steering committee some months ago, and we were all together in this meeting. And to Horas Cono, which is the core of this organization. And Liliana Vasquez, who is the PAJO Technical Office, and Rodrigo Guerra, who is the engineer who developed the registry. With gratitude to the National Committee, transplant centers, focal points across the 6 countries, Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela. Thank you.
Thank you very much, Dr. Palma. And now I think we have an online presentation from Argentina, Laura Aguirre, related to HCT Activity Registry, Donasur and Incucay. Dr. Laura is connected?
Yes, good afternoon, everybody, and thank you very much for the invitation.
Great, go ahead.
I need to share my screen. Here. Well, today can you see my screen?
Yes, we do.
Okay. Thank you. Today I will provide an overview of the, one second. Here. Well, today I will provide an overview of the system through which transplant activity data are reported and managed in Argentina. This includes Sintra, our national information system, and DONASUR, the official regional registry used by the Ministries of Health to report transplant activity. I will start with a brief overview of INCUCAI. INCUCAI is Argentina's National Institute for Organ, Tissue and Cell Donation and Transplantation. It is a decentralized agency within the Ministry of Health responsible for coordinating, regulating and overseeing donation and transplantation activities nationwide. INCUCAI coordinates these activities through the network of 24 provincial procurement and transplant organizations, ensuring equitable and transparent access to transplantation for patients across Argentina. The Directorate of Donation and Transplantation of Bone Marrow is the National Hematopoietic Stem Cell Donor Registry that operates under INCUCAI. Its main responsibilities include the recruitment of volunteer donors, the coordination of donor searches and cell procurement, and improving patients' access to transplantation. Sintra is the National Donation and Transplant Information System. This is the platform used in Argentina to manage, monitor, and oversee organ, tissue, and cell donation and transplantation activities. The system is used by different authorized users, including hematologists, transplant teams, and donor recruitment staff at donor centers. Each group works with role-based access with permissions restricted to specific modules and levels of information to ensure confidentiality of data. For bone marrow transplantation, Sintra allows the registration of transplant and donor search requests, the recording of transplant activity, and the collection of patient outcome and survival data. It also supports the registration of unrelated donors through the national network of donor recruitment centers across the country. As you can see here, this is our current network of transplant centers, 33 teams in total, including 12 public and 21 private programs distributed across the country's regions. Every request made by the hematologist is recorded in Sintra from the moment it is submitted, including the assignment of the transplant center, and is continuously updated to reflect the patient's or request status, including donor search request. Sintra also records transplant and survival data. Each transplant team enters detailed clinical information, including engraftment, stem cell source, and the conditioning regimen, and whether TBI was used. Follow-up data are collected at 3 months, 6 months, and annually, including graft failure, disease status, acute and chronic GVHD, infection, relapse, and subsequent treatments. All of this supports the generation of survival curves, which can be further stratified by transplant type, underlying disease, transplant center, and patient age. This follow-up information allows the Scientific and Technical Directorate of INCUCAI to use outcome data to support the evaluation and reaccreditation of transplant center, although it would be benefit that from including more variables for a more detailed analysis, and efforts are currently underway to make this information more complete, working with the Argentine group for bone marrow transplantation. All this feeds into CRECI, which is Sintra's Public Reporting and Statistics Center that provides open access to transplant types, age distribution, transplant center, funders, and overall transplant rate. For example, here you can see Argentina's transplant rate per 10 million population by province, which clearly shows where access is strongest in the country and where we still need to improve. And this shows our unrelated donor statistic from the National Donor Registry, including the number of donor types, pending cases, and the rate of registered donors per 10,000 inhabitants by province. This information also helps guide target actions to strengthen donor recruitment in underrepresented provinces. Well, regarding DONASUR, it is the official reporting platform for donation and transplant activity in Latin America and the Caribbean. It was established following an agreement among the ministries of health of Mercosur countries in 2011, and was developed by INCUCAI with the support of PAYHO and the Red Consejo Latinoamericano de Trasplante. The platform collects data on all types of transplantation, including organs, tissue, and cells, and provides public access to this information. Here is the access to the web. Today, 19 countries report to DONASUR through different structures, reflecting the diversity of the varying levels of development of their national transplant systems. Data are submitted by National Transplant Institute, ministries of health, or in some cases, directly by individual hospitals. DONASUR collects detailed information on transplant activity from participating countries, including transplant types, funding sources, demographic data, activity in public and private institutions, and overall transplant rates. One important point is that to date, 4 countries have started reporting their bone marrow transplant activity, that are Argentina, Paraguay, Ecuador, and Bolivia. DONASUR also captures information about each country's institutional development, for example, whether there is a dedicated national donation and transplant agency, whether funding is public, whether there is financial autonomy, whether a law regulates transplant activity, and basic population data. Looking ahead, we have 4 main objectives. First, to expand the number of countries reporting to DONASUR, so we have a clear picture of transplant activity across Latin America. Second, to incorporate additional indicators to assess regional capacities. Third, to improve data collection and reporting in Sintra according to patient risk stratification and other variables that have an impact on survival outcomes. And fourth, to interoperate with other regional and global registries in order to avoid duplication of data entry. Well, thank you very much. Here I am also including the contact of Mariano Sorati, who leads the development of Donazul, in case you have any specific question for him. Thank you.
Thank you very much, doctor. Please stay with us. Now, in order to continue the session, we are going to invite Dr. Will Saber from USA, outcome registered CIBNTR.
Okay, thank you. Thank you so much for the invitation to be here. It is my honor to tell you a little bit about the CIBMTR. And I have to say, it's going to be a monumental task to go over the registry in 15 minutes. I know everybody's tired. Lucky for you, I can speak fast. And very, very similar to Juliana, unfortunately, I don't have any conflicts of interest as well. So, here we are. This is the CIBMTR as of today. This is the Medical College of Wisconsin campus. So we have two campuses, one in Milwaukee, one in Minneapolis. This is a Milwaukee campus, and we moved there to this new building 6 months ago. So it's a very pretty building. Whenever you're in Milwaukee, you're more than welcome to come and visit. Okay. So the CIBMTR is a prototype example of this concept of real-world data and real-world evidence. It's an observational database. It informs us about patients' health and the delivery of health care through other means other than clinical trials. And then we obviously try to interpret this information, which is the real-world evidence. And how do we do this? Well, the law of the United States as of now, since 2005, that all the programs that perform allogeneic transplants are mandated to provide data to the CIBMTR through this Bill Young cell transplantation program. In addition to that, with respect to the CAR T-cell space, also the FDA mandates that every patient who receives integrative cell therapy is to be followed for a minimum of 15 years. So a lot of the commercial companies, you use the CIBMTR as a mechanism to provide that long-term follow-up. So we have lots of data, and we try to make the best out of it. We're the data managers. So I'm going to be touching on some of these themes today, and very quickly. So the first theme is a theme of observational research. And so using all this data, you can answer many questions. One of them is transplant activity, what's happening across transplantation platforms. And you've seen, I think you've seen the slide several times today and yesterday as well, showing the rate of allogeneic transplant, autologous transplant, and CAR T-cell space over the last few years. You can also ask questions about who is getting transplant. So here you can see that this is the age of patients getting allogeneic transplant, and you can see that in this, I don't have a pointer, but that gray zone bar, you can see that this is the expanding proportion of older patients, 65 plus, and you can see even that yellow margin that's getting bigger and bigger over the years. These are the 75 plus. So, and then we can also ask questions about how the clinicians are performing a transplant. And after the publication of the BMT CTN 1703, this is the graft versus host disease prophylaxis preferred regimen in allogeneic transplant in unrelated donor setting, just for example. And you can see in red or purple the increasing use of PTCY as the preferred GVHD prophylaxis platform. So, and we can also look at outcomes. So this is an outcomes registry. So we can look at the survival of these allogeneic transplant recipients over time. And you can see the dashed blue line showing that, over time we have shown progress and improvement in survival of these patients. Then we can go also to the CAR T-cell space, and we can ask questions about the indication. Again, I think you've seen the slide already over the last couple of days showing that, diffuse large B-cell lymphoma and myeloma are the two main indications for CAR T-cell therapies. And we can also ask questions about outcomes after the CAR T-cell infusion. Okay, so we organize ourselves to manage all this database into 10 working committees. The working committees are critical. These are where a lot of the research activities happen, and very similar to what Daniel was presenting earlier today about the variables and the concepts about the questions that we could. So when we're trying to update our forms, how do we do this? So on the leukemia committee, for example, we convene our chairs every few years and we go over our forms and we can say, are these variables are relevant anymore, or what's happening, what do we know today that we didn't know 5 years ago, and what should we do, what should we collect now moving forward? So these working committees really is the heart of the CIBMTR, and I can't emphasize that enough. So a few other important recent developments. We have now a patient-reported outcomes protocol that's managed by my colleague, Dr. Rachel Casares, where we are actually part of our consent that we can reach to patients directly and we can ask them to tell us how they're doing. So we collect baseline patient-reported outcomes, and then we also reach out post-transplant and we ask the same set of questions again and again and again. And you can see right now, this is actually a little bit outdated. This is as of May of last year. There are 2,000 patients enrolled in this program, which allows you to really maybe ask questions about whether PROs are predictors of transplant outcomes. And she's also expanding to the CAR T cell space as well as of last few weeks. Very recent, but also a very important innovation that we've done is once we publish a paper, we upload the database, the data set of that paper to our portal website. Anybody can download the data set, and you can see the manuscript link to the data set, which tells you the exact data, the dictionary and the variables and who is the population that was enrolled in the data set. And then you can analyze this cohort now to maybe answer a novel question. You don't have to wait for the cycle of tandem meeting, submit a proposal, get accepted, wait for a statistician. If you have your own statistician, you can certainly download these data sets free of charge, and you can do that work yourself. All right, so now we're going to move to the experimental research. In the CIBMTR, we take a very active role in interventional studies. So sometimes we do the intervention trials ourselves, for example, led by my current boss, Dr. Bronwyn Shaw. She is very interested in improving mismatch unrelated donor transplant outcomes. So you can see here, she among others in the NMDP, led this continuum of studies. She first started by the 15 mismatch unrelated donor study, which is published now, and then she moved to the ACCESS study, and now she's almost done with the optimized study, and then we recently opened the Accelerate program. All these 4 studies sort of in succession are meant to allow us to understand how we can perform mismatch unrelated donor transplantation in a much more safer and much more efficient way. And then we also support the BMT CTN in so many ways. A lot of the clinical trials that's published with the BMT CTN really heavily rely on the CIBMTR to inform their study design, to inform who should be enrolled, which centers the study should be open in, how many patients do you need to answer that question that you're trying to answer, and how to monitor the study actively as a study being conducted so that you can finish on time and get the answer quickly. So this is an example where this is really all that played very well in this one key paper that I was fortunate to be a part of. It was published a few years ago comparing transplantation to non-transplant treatment in older patients with MDS. All right, so now we're going to move to also again, another newer program that we started a few years ago is the Precision Data Science and Precision Medicine program. And the reason we're able to do this work is because we have clinical data, we have biological samples, and I just told you that we have also patient-reported outcomes. So in the National Marrow Donor Program, we have a biobank, and we have lots of samples on recipients and donors. So one can interrogate these samples and link to the clinical data and answer really very important questions. And this, for example, was done in this particular publication where the investigators used the CIBMTR. They were able to get the patient-reported outcomes. They linked to the specimens, and they were able to do RNA-seq of these specimens, and they linked to the clinical variables, and they were able to answer a question about unfavorable transcriptome profiles and social disadvantage in transplantation. They would never have been able to do that unless you have all these different sources of information on the same patient population. Another project that I was also involved with, this is along my colleagues from the NMDP, where we used samples on MDS patients and we did whole genome sequencing on them, and we were able to generate novel biomarkers that are associated with survival after transplant. And when we tested what's called the C-index, which is the predictive capacity of a model, once we integrate the genomic information, the C-index went from 0.5 to 0.84, showing really the importance of the added genomic data. All right, so now we're going to move to how CIBMTR has been taking an active role in informing policy. So obviously, I think a lot of you are familiar with the center-specific analysis activity that my colleague, Dr. Doug Rizzo, is in charge of. And it's a mandate from the United States government for us to do this. So we evaluate centers' performance by examining center outcome relative to the network, to the overall network, after risk adjusting according to the case mix that center is seeing. And then this is sort of the report. It looks like this. You have the actual survival that was observed, and you have the predicted survival, and you have the 95% confidence intervals, and you can see basically did the actual survival fall within that range of the 95% confidence. If yes, then they get a 0, which is as expected. If they fall below the lower margin of the 95%, then they get a -1, which meaning they're underperformer. And if they perform better than the upper margin, then they will get a +1. This is very important. I think Adriana mentioned today that the CPI, the Program of Quality Audit, is very important. You know why? Because centers that fail the CPI, they actually don't get enrolled in this analysis, which a lot of the third-party payers in the government, in the country, look at this report very carefully. And they penalize centers that get a -1, or they were not even participating in this report. So, and we've done actually a work showing what is the impact of the center-specific analysis on the field. And we've published 2 papers. The first paper, these were the citations, but basically the first paper showed when a center gets a -1, the subsequent volume actually diminishes at that center, meaning that the third-party insurance really, they changed the destination of their patients. The second paper, luckily, we were concerned that when a center gets a -1, they change this patient selection behavior. We were very concerned about that, which we called, it's kind of like the unintended consequence. But luckily, when we examined a lot of variables, we were unable to show that, which was good news. In addition to that, the CIBMTR and the BMT-CTN really responded very effectively to a number of mandates from our Center of Medicare and Medicaid Services, Medicaid, the government insurance. They asked questions about, is transplantation safe and effective in certain older population? MDS was the prime example. They also now moved to myelofibrosis. They're asking questions about myeloma. They're asking questions about sickle cell disease. We answered the MDS question. The other projects are still ongoing, and because we answered the MDS question by 2 different publications, we were able to get now a decision by the government to pay for allogeneic transplant for older patients with MDS. This is totally driven by the BMT-CTN and the CIBMTR as a response to a governmental mandate or governmental question. All right, so now we're going to move to the clinical decision support environment. So I think this is very important. When we are trying to decide on a transplant, there are 3 things that you're thinking about. First is the disease risk. Second is the patient performance and the patient's health. Third, how are you going to do the transplant? These 3 factors together really allow you to make the ultimate decision, should you take the patient to transplant or not. And if you have to think about it as a risk-benefit, and I wouldn't be standing here if we had a perfect therapy. If we had a perfect therapy that is 100% effective and has 0% risk, there's no more discussion. But the reason I'm standing here and discussing is because we don't have that. We have a therapy that is not 100% effective and has associated risks. So you need some instruments to help us decide which patient benefit from this treatment. So we have actually tried to add to the tools that we have. So this is, CIBMTR really helped the BMT-CCN in developing this protocol and publications. It's called the CHARM trial. It's published now. The primary paper was published last year. The secondary outcomes paper was published just 3 months ago. It's led by Dr. Andy Arts and Mohammed Surur. I was a protocol officer, where we built on the HCTCI. And we tested 13 different published fitness parameters. 7 of them made it to the final model. These are the 7 as shown here, which is KPS, pre-transplant albumin, pre-transplant CRP, percent of weight loss over the preceding 12 months, age at transplant, the HCTCI, and the cognitive health by the Montreal Cognitive Assessment Tool. And when you aggregate all these 7 variables together, you come up with a CHARM score. And when you divide the CHARM score into tertiles, you can see this. It discriminates between different tertiles with respect to overall survival and also 1-year TRM. And now we have a calculator that is housed on the CIBMTR portal, free of charge. You can use it anytime when you're trying to counsel a patient about the risk of 1-year NRM. You enter, just have an example here, a 72-year-old patient with an albumin of 3.8, CRP of 3.1, HCTCI score of 3, KPS 90, MoCA score of 28, and you can see that their 1-year NRM rate is 19%, okay, which can be used as part of the conversation that you can have with a patient. A second calculator that I actually very personally am very proud of was published this year in Blood Advances, and we developed and validated the first clinical, 100% clinical risk score to predict acute GVHD. And again, very similar to what I showed you, we have a calculator on the CIBMTR right now portal where you enter these variables, and it gives you, if you can look at that little box on the right side, the 100-day probability of 2 to 4 and 3 to 4 acute GVHD. And we called it the GRI. And then we have, obviously, the standard, I think many of you might have used this before, the standard 1-year survival calculator. So I'm just trying to give you some example, some flavor of some of the instruments that we have that hopefully allow for clinicians to provide counseling, standardized counseling, not subjective assessment, not your gestalt, but very objectively driven advice to the patients. All right, so finally, I want to tell you about some activity that we've been doing with respect to education. So here I have to mention my colleague who passed away 2 years ago, Dr. Kristen Page. She really led the development of this Page Scholars Program. And now we have a number, every year we accept a group of younger junior faculty, I mean, I'm still young, but they're younger than me, assistant professors across the country. They spend a year with us really working as junior chairs or as even scientific directors. They really, some people have this idea that the CIBMTR is a black box. We want to get rid of that. We want to be transparent. We want to be able to allow people to really understand the inner workings, and some of them join us. So this was the inaugural cohort. These folks were fantastic. Some of them went on to have a grant, like Brian Ball. Najla Al-Jordi, actually, she's now the scientific director of the GVHD Working Committee. She actually joined us, and they really all went on to do great stuff. Now we have our second cohort of Page Scholars. They're finishing up actually in just a few weeks from now. So we're very proud of that program, and we think it's going very well. All right. So in conclusion, I just showed you some example of what we've been doing in the CIBMTR. I cannot present everything in the CIBMTR in 15 minutes. So please just, if you have any questions, just come up to me, send me an email. I will try to help answer any question you have. If I don't know the answer, I will get you the answer. Because even I've been there for 20 years and I still don't know everything. So this paper published by Dr. Kristen Page before she passed away give you some information about the CIBMTR and how the registry help transplantation research. And I will finish up here. Thank you so much for your attention.
Thank you very much, Doc. Thank you very much. The following presentation is by Dr. Ana Sureda from Spain. outcome registry from EBMT.
So these are the slides. So good afternoon, everybody. First of all, thank you very much for inviting me and for allowing me to participate in this 10th WBMT workshop. And I want to give a special thanks to Sebastian, because without him and his jacket, I don't think that I would have been able to survive the cold room for these 2 days and a half. So, okay. So I have a half conflict of interest because I was the president of the EBMT and I stepped down at the end of March this year. So I want to make the best out of it regarding the EBMT registry, which is going to be the topic that I will be discussing with you in the next 15 minutes. So as you know, the EBMT registry was established back in 1974, and it's basically the backbone of all the EBMT research and educational activities. And I would say that as per today, we have reports in terms of stem cell transplantation in more than 700,000 patients. So we have around 1 million stem cell transplantation procedure in the EBMT database, and we have around 20,000 patients already being treated with CAR-T. And as you know, oops, I think that I'm going too fast here. Yeah, exactly. So you know that the EBMT registry platform was promised for many, many years, and after several attempts in 2023, the new registry platform was alive. We are still working on it. We are still optimizing the system because we need to still streamline some of the capabilities, but we have been able to construct a platform which is more user-friendly or friendly user. I never know which is the first word when I talk in English, and that hopefully is easier for everybody to use. Okay. So I think that one of the major characteristics of the new EBMT registry platform is that it has adopted a common data model together with this OMOP mapping that basically guarantees a standard way to structure data. It improves data quality, collaboration, and accessibility. And basically what it's really more important is that it facilitates global collaboration and international data exchange and research, which basically this is what we really want to do. So, some very high-level, highlights regarding the forms. The core data set, which was previously the MET-A, is required for all patients. And you may remember that to have the full membership of EBMT, you have to report all consecutive transplants that you are performing in your institution, both autologous and allogeneic stem cell transplantation. Unfortunately, EBMT is not capturing right now all patients being treated with CAR-T being performed in EBMT centers. And it has patient baseline data, diagnosis forms, and treatment specifics. Nowadays, not only stem cell transplantation, but also CAR-T and gene therapy. So we have the follow-up data forms. I'm going to get used to this pointer by the end of the presentation with the 100 annual and extra event forms, and then the extended data set that has additional variables, for example, regarding antimicrobial prophylaxis and CMV management. So with that, this is what we have in the registry. As I have mentioned before, we have almost 20,000 patients being treated with CAR-T and around 1 million transplants, both autologous stem cell transplantation and allogeneic stem cell transplants. So who is reporting the data? So here you have a global map, and you have the EBMT reach. And we try to be as much global as possible. So EBMT nowadays has more than 7,000 total members, coming from more than 700 centers and more than 80 countries. Of course, not all the members are basically reporting data to EBMT. Okay. So how are we using the data that centers are reporting? So I want to mention, first of all, the activity survey that it has been mentioned several times during this meeting. But I want to thank Helen Baldomero sitting here and Jacob Pasweck for the excellent work that they have done. I mean, reporting, I think that since I was not involved in EBMT, the activity survey, which was not exactly related to the EBMT registry. And basically, the activity survey, as we have been able to see in this session, has allowed us to have a longitudinal view of the field in terms of growth of transplant procedures, changing indications, evolution of donor source, changes in stem cell transplantation techniques, and basically global trends. So we had a change, and this is the last information coming from the last activity survey that was taken over by the Scientific Council of the EBMT under the umbrella of the EBMT registry, and this is the last publication by Rafaela Greco and the rest of the Scientific Council of the EBMT in BMT 2026. And again, crossing these 1 million stem cell transplantation procedures and these 20,000 patients being treated with CAR-T. I'm sure that you remember these slides from yesterday's John Snowden presentation. So what are we doing with this activity survey? So we can see changes in disease indication for both allogeneic stem cell transplant and autologous transplantation here from 1990 to 2024. And as I will be mentioning tomorrow in my presentations, we are seeing a decrease in autologous stem cell transplantation in lymphoma patients, basically because of the advent of new cellular therapy strategies. So what else? We can have a look at how the donor source is evolving over time. And here you have data from 1990 to 2024. So we are seeing a kind of plateau in terms of matched sibling donors. Cord blood transplants, I mean, they are significantly decreasing, and they have been significantly decreasing for the last few years. And we are seeing an increase in matched unrelated donors or unrelated donors, and also on haploidentical donors. So looking ahead on modifications in the activity report, we are going to work on having more specific information between adult and pediatric populations to allow a more precise analysis. And we will try to streamline trend monitoring, health system planning, and eventually to be able to assess equity of access across different countries, which is not an easy task. So what are we doing with the data that EBMT centers are reporting to the registry? So we are trying to give as many outcomes as possible, and basically, you know that EBMT is basically working with retrospective analysis. And with the registry data, we can define clinical practice, and we work on indications, prognostic factors, donor selection strategies, conditioning regimens, GVHD prophylaxis, and so on. And here in this slide, you can see a few examples together with this slide of several papers that have been published by the different working parties of the EBMT. So as it has mentioned before, CIBMTR, we are talking about working committees. In EBMT, we are talking about working parties that are basically the leads on the scientific activity and the scientific output of EBMT. But more importantly, we can also work on long-term follow-up data. So we have enough patients in the registry, and these patients have been followed long enough to give information regarding, as you can see here in this slide, on trends in allogeneic stem cell transplant for favorable risk acute myeloid leukemia in first remission, chronic GVHD trends over 30 years, and also information regarding patients being allografted in the elderly years for acute lymphoblastic leukemia. So here you have some data, and I think that these data are really very informative because they indicate that we have been able to improve the long-term outcome of our patients, in this case being allografted for an AML with better overall survival over time with a decrease in non-relapse mortality. And these trends in terms of overall survival are being kept in the young population of patients and also in the elderly population of patients. I'm very happy. Here I have a conflict of interest because I work a lot in relapsed refractory Hodgkin lymphoma, so we have just published data in Lancet Hematology coming from the Lymphoma Working Party of the EBMT in 20,000 patients being transplanted because of relapsed refractory Hodgkin lymphoma, analyzing the long-term outcome over time. And here you can see data from patients being autografted and in this slide, patients being treated with an allogeneic stem cell transplantation. But of course, we can also work on donor strategy. So looking at the rise of haploidentical donors, trying to expand the access of every single patient to an allogeneic stem cell transplant, and the use of different GVHD prophylaxis, taking into consideration the different donors that we are using nowadays. And here you can see some examples regarding that. So all these registry data, basically they constitute the nucleus for all the working parties EBMT publication, and EBMT is publishing more than 100 papers per year, and basically this reflects the activity of the different working parties. So, but in addition to stem cell transplantation, and I think that thanks to the work of Christian Chavanon sitting there, Jürgen Kubal, and other people in EBMT, in February 2019, the cellular therapy module of the EBMT received the positive qualified opinion by EMA, and EBMT has been working not only in collecting data from patients being treated with CAR-T and trying to produce scientific activity in the same way that we have been doing for stem cell transplantation, but also EBMT has actively encouraged centers to report data on patients treated with CAR-T cell therapies to support the post-authorization studies that are being mandated by EMA. And in this slide, you can see the first 5 ones that EBMT undertook. Some of them are already closed, and we are bringing up new studies depending on the new indications and the new constructs that are being approved by EMA. So what about the future of the EBMT registry? So the future vision includes the integration of artificial intelligence, the enhancement of data collection and standardization, the expansion of global collaboration, and the assurance of ethical and security considerations. So one slide regarding benchmarking, and this is something that has already been mentioned also by CIBMTR. So this strategy was already launched quite a few years ago, and this enables centers to assess their performance against other centers across Europe. We started with stem cell transplantation. Why not to continue with eventually CAR-Ts? And here I want to mention the leadership of Riccardo Saccardi, that unfortunately passed away several years ago, and also the leadership of John Snowden, who now is taking care of the benchmarking strategy in EBMT. Super bad. And as the field expands to CAR-T and to gene therapy, we think that it's really very important to increase and to streamline collaboration with other societies. And here I'm bringing this paper that was published 2 years ago in combination with ISTCT regarding current challenges in cell and gene therapy strategies. And we have actively worked with other transplant societies and other scientific societies to try to harmonize as much as possible definition to be able to integrate or to utilize data coming from different registries, which it's really very important. EBMT is well known by all the retrospective work that we have been doing for many, many years, but we will try, and this has been a work in progress from many, many years coming from the board of EBMT to expand our scientific activities, not only to retrospective analysis, but also to prospective non-interventional observational studies, and eventually to prospective clinical trials, to interventional trials. And we have already started conversations with CIBMTR, and maybe this is a dream for the future. Oops, I haven't done anything. Okay, to try to establish a biobank and eventually virtual biorepositories, basically to allow transparent and equitable access to samples for specific innovative PI-led basic and translational research questions, and to facilitate an adjunct for sequential sample collection for long-term follow-up safety evaluations. Again, artificial intelligence integration into the EBMT registry that has the potential to enhance stem cell transplantation outcomes through advanced predictive modeling and personalized treatment strategies. There has been already some work being done by different working parties. And here you have an example on the prediction of poor survival after stem cell transplantation in myelofibrosis using machine learning techniques, and with a very recent paper coming from the Chronic Malignancies Working Party identifying a population of 25% of the patients that do very poorly after allogeneic stem cell transplantation. So basically, in summary, and I'm going to go back to this global map. So the EBMT registry tries to be as much robust and flexible with the new platform, GDPR ethical and legally compliant, basically based on data collection and standardization, trying to promote global collaboration and to provide registry data, and future perspectives for the registry to enhance basic and translational science, to implement AI and modeling, prospective clinical trials, and biobanking. And with that, thank you very much for your attention, and thank you very much to, all the EBMT participants, and basically to all the EBMT centers that give data to the registry in, let's say, without earning anything, but basically with their efforts. Thank you very much.
Thank you very much. Thank you very much. Okay, we are going to continue now with the roundtable discussion. We are going to invite the panelists, Sebastián Galeano, Linoska Mendoza from Panama, and Marlene Chavez from Costa Rica. If there is any question, or the panelists want to start, Galeano?
No, we are all going to talk together. Adriana starts.
It's not a question, it's just for, I think it's important. I think it's just important for the countries to learn the way we did the Brazilian BMT registry, that we partnered with CIBMTR, and the data from our centers go to the CIBMTR. We have a formal contract, and then comes back to Brazil with no identification as a country level. It's the same as we have with WBMT. All the countries can get the data back as a country. And so it was very, very helpful, because everything we have on computer and online checking, and then we get this data back. And it's very important, it's been very, very helpful for us. And it's a model, I think from it, they may be open to other countries to do it the same way.
I would like to emphasize this is one of the options for cooperation, in this case was between the Brazilian Society, the SBTMO, and the CIBMTR. But this gives a very important profile for us, because these are outcome measures. And well, tomorrow we'll talk about infections, but we can see that even the cause of death for our region is different from what it is observed in North American centers. And this is extremely useful. But well, we have here Marlene and Ninoshka that have been the responsible for their own countries in reporting the data to the LABMT, and the data of the LABMT is reported to the WBMT. So that would be nice to hear from you. What is your experience with collecting data?
Yes, thanks for the LABMT, because thanks for Sebastian Galeano to help us, because it's very difficult to get the data, because I don't have the data manager. It's provided for me, always. And it's a benefit, report the data, because you have your patients, how many transplants for years. Is that very important, because you need to know your complications, what you needed in the future, and support for, go to the governments for support for us. It's very important for that.
Marlene?
Sí. I really prefer speak Spanish. It's better for me. I speak more quick.
No problem. We can translate also.
Es importante la recolección de datos. Sin embargo, en Costa Rica ha sido difícil porque la mayoría de centros pertenecen a la seguridad social. Son 2 centros que hacen trasplante halogénico y un tercer centro que hace solo autólogo. Sin embargo, la información es de la seguridad social. En ese sentido es difícil exportarla hacia otros sitios sin autorización de nuestras autoridades. La investigación en Costa Rica también está muy regulada, y para hacer un trabajo de investigación o para colecta de datos tiene que pasar por los comités de ética, que son muy estrictos en cuanto a compartir estos datos. Aún así, tratamos de hacerlo. A veces los compañeros sí tienen problemas, digamos, para reportarnos, aunque son pequeños los niños, sobre todo porque son menores de edad, son datos de menores de edad, y eso también implica un problema para compartir información. Y los otros muchas veces es que no, a pesar de que estamos en un radio de 2 kilómetros de distancia, también se dificulta un poco la comunicación, o por lo menos que tengan los datos para poder, digamos, subirlos a LABMT.
Yes, Marlene was mentioning that she's from Costa Rica and she was responsible for collecting the data from Costa Rica, but some of the centers in Costa Rica are part of the social security system, the national government, and they have important restrictions to share this information. I think that this is one of the main important issues that we are going to discuss now, because this information is also important for the governments. And how can we facilitate this, and how can we share information, and how can we cooperate all together? That will be very important. This is one of the issues that they have in Costa Rica and in other Latin American countries also. So, Alice? Yes?
Yo, hablando ayer con lo que hace la Organización Panamericana, creo que sería importante que PAJO también se involucrara un poquito más en hacer, compartir con los gobiernos, o sea, a través de los ministerios de salud, que es importante el reporte, y ver la figura de PAJO a través de eso no es transmitir estos datos a una entidad que es privada, por decirlo así, porque el EBMT no son nacionales, sino no pertenecen al gobierno, sino son organizaciones no gubernamentales. Entonces, siendo PAJO, podría ser un enlace como para captar esta información.
Absolutely agree. She was mentioning that involving, for example, PAJO, which will give support to the governments to be sure that this data can be shared, and how we can integrate this with national authorities and with the Pan American Health Organization. So that will be very important. Yes, Ditker?
It's not only for you to understand how many transplants you did in the last year or so. I think it's important more, in addition, for your politicians to give you the money, to tell them that you are benchmarked with other countries and you need more beds, for example. It's more important for PAHO. You have seen yesterday which numbers they were showing. So this is one of the most important outcome of this meeting, that we have organized to talk together with PAHO yesterday, and I gave him also all the data from Latin America, so they know what we are doing, and we will do in future, we will cooperate much more. So that's the most important point here. For politicians, for giving money to us, to make our transplant, to make science and so on.
Absolutely. Now we have Julia Palma and Laura Aguirre also that are working with the Pan American Health Organization to improve the knowledge on data. And that would be very important. We have Juliana.
A letter to Costa Rica explaining the role of the registry, the importance. We sent it, I don't know, 2 months ago. I don't know what happened with this letter.
En este momento nosotros no hemos tenido conocimiento de esa carta porque por lo menos a mí no me llegó ni a los directores de los centros de trasplante. No sé por qué.
I can check, but Andres is here because Andres sent it, and then we ask if you receive, and we resend the letter. So I checked again. I don't know. I received 3 names to whom I have to direct this letter, but I would check.
Anyway, I think it will be important to involve also Pan American Health Organization and the national authorities, also with LABMT also. But maybe Julia can comment on that, and we have Laura, no? Laura Aguirre connected in the Zoom meeting. And John, first Julia and then John.
Okay,
and then Laura, if
thank you.
she's there.
I think it is very important the point you are mentioned, because we could have a meeting with Pan American Health Organization with Liliana Vasquez, who is in charge for cancer, childhood cancer, and from this point of view, we started to work together. I think if we show to the other PAHO members the results of those we are doing, I think they know, but not so clear as we need. We can show this as a model. We could apply to other, for example, for adult transplantation, and I think it's easy to do. We can do it. Absolutely.
Thanks very much. John?
It was just a point about benchmarking and linking the FACT-JC standard B4.7.5. You have this, are you in the expected range? It's like the hemoglobin, isn't it, kind of thing. But it's very important. Above or below, and probably the majority of us are going to be within those 95th percentiles or so, or 2 standard deviations. But it's really important that every centre knows where they stand, not just for JC and FACT accreditation, but just to have that confidence that you're doing the right thing. And maybe you could compare yourself with CIBMTR or EBMT, or develop your own system, but you need to know where you stand on a year-by-year basis. And I think we've got these systems in CIBMTR, which inform the EBMT, thanks to Doug Rizzo, Steve Spellman, and Whale, and so on. But they can be translated into other parts of the world. Some ability to incorporate socioeconomic factors and do other clever statistical adjustments as well to make them fair. But please use the registries for this reason. I think it's a good one.
May I comment one minute on that, because I think it's very important. This in this region, Latin America is extremely heterogeneous. So we are centers that are not reporting. Most of the centers are reporting to the LABMT, only the activity and the basic aspects of we can say the basic data without any outcome measure. There are some centers reporting to EBMT and to CIBMTR with very sophisticated outcome measures. And I think that we need to think something in the middle with some basic aspects, for example, overall survival, if the patient is alive or not 1 year post-transplant. That will be very useful for the authorities, as Laura Guerre mentioned in CUCAIM. But this is where I think that the WBMT can make a good important impact in this. That will be very important. I don't know if Laura Guerre is online. If not, we have Wahil from CIBMTR. Wahil, yeah.
Yeah, I just have a quick comment. It's not about the regulatory aspect, but it's about burden aspect. So in the CIBMTR, there's a very, very active process right now we're engaged in. It's still ongoing. This is why I didn't want to put it in my slides. We're trying to use AI to extract data that will help reduce burden on centers dramatically and with maintaining accuracy. So it's work in progress. It might take another 6 months, a year, where we can start really talking about implementation. But the initial pilot data looks very, very promising. So it's not just about AI in the analysis stage, but actually we're also using AI in reading PDFs directly and taking the human component out of it.
I have a quick question. I heard that Dr. Marlene was mentioning that there's an issue with in Costa Rica for having children data shared with the registry. So we do, at least in the United States, but I think everybody, I just like to confirm, every patient, every parent has to sign a consent form to share the data with CIBMTR, with any registry. I have not heard anybody talking about the consent form, but I think there should be a uniform consent form within the registry, within the LABMT, so that the authorities, the ethical committee of the hospital, or any Ministry of Health would be reviewing this consent form, knowing that the patient or the families agree, if they agree, but also inform the patient how important it is for having their data become science. So I think the consent form that probably everybody has in a different way could be reviewed, and maybe it could be even a matter of consensus on the language, on the terms, on the outcome component, or on only the demographic that is collected. But I think it's a very important piece of building a registry.
Sí, en referencia a eso, sí es, los padres pueden pueden involucrarse en esto. Sin embargo, como la sombrilla que abriga todo lo que es el programa trasplante es la Caja Costarricense de Seguro Social, que es por el gobierno, ese es digamos, de donde se extrae el dato, es a través de la institución, aun cuando los padres consientan, dan permiso para hacer trasplante y para todo el tratamiento de su hijo, pero el dato en sí, digamos, pertenece a ese hospital y ese hospital está regido bajo la sombrilla del gobierno. Pero, como le menciono, todo esto es por regulación de la ley de investigación. Antes del 2000, la investigación era muy florida, sin embargo, vino una ley de investigación y ha hecho, la verdad es que creo que pasamos al extremo, muchos pensamos que es como llegar al oscurantismo de la investigación, porque se pasa mucho en cuanto a que no se pueden compartir algunas cosas. Sin embargo, para mí la figura que puede ayudar a mejorar esto son las figuras de las entidades como OMS, la PAJO, porque siempre los ministerios de salud responden a estas autoridades. Y aunque sean ONGs que son con un alto nivel científico, BMT, LABMT y todas las otras organizaciones, siempre, digamos, la figura de la OMS y OPS Pajo, todo esto puede ayudar a recolectar todos esos datos. Es, digamos, reportar. ¿A quién reporta uno? A alguien que es un ente privado o si es algo que mundialmente es una autoridad reconocida de salud.
No, just to mention, for public centers in Costa Rica and in other countries in Latin America, to report even basic activity of the center, it is necessary to have the national government authorization, and this could be very easily done if PAHO is in agreement with that and tell the governments how to do it, no problem. But of course, I agree that particularly if we are planning to move to another step in which we will have some basic data on outcome, it will be absolutely necessary to have an informal consent as we have the centers that we are sending data to WBMT or to CIBMTR. But this is an additional step that will add a minimum complexity, but a little bit more complex. So we need, I think it should be done progressively. Mickey and Dietker, maybe you can.
Any other question from the audience? Any other comment, please?
Yeah, no, I was just wondering. No, stand up. Okay. Last week there was a publication on the rates of secondary cancers after B-specific antibodies, and at the end of the paper, if I read it correctly, there was a suggestion that maybe the rate of secondary cancers was slightly lower than after CAR T cells. My point is, how do we envision in the future that cellular therapies no longer stand as single treatments, that they are only steps in a patient journey that is even more complex, during which the same patient may receive different cell therapies at different time points, and in between will receive other categories of medicinal products. So how do we compare, how do we position transplant and other forms of cellular therapies in an ever-growing, more complex treatment landscape?
You're referring to the sequencing. Christian, you're referring to the sequencing of the treatments that is completely changing. Well, I cannot answer you. I don't know.
Yeah, I don't claim to have the perfect answer, but it does require a very different statistical approach entirely than what we have been doing. It requires more of like a multi-state modeling approach, but you have to also understand what the patient looked like almost at every step of the journey, because you don't want to be biasing your design. But I think you need something more like a multi-state modeling approach. I mean, it's a very, we've talked about this in the registry whenever we're analyzing CAR T studies, and it's a very complex question. And I think it will require us to acquire data in a very different way as well, because you're going to have to acquire the data on a longitudinal fashion and assess performance scores on multiple time points and try to make it fair, because otherwise you're going to end up with the wrong answer.
Well, I remember you're talking about the multi-state model.
Yeah.
And when we were studying in myeloma, autologous stem cell transplantation and then allo stem cell, or vice versa, or two tandem, so we use that. But now in myeloma, it's not only two transplant procedures that we're comparing 10 different treatments.
So my colleague who spoke yesterday, Marcelo Pasquini, he's a very strong advocate of trying to come together and perform pragmatic clinical trials, real world, very simple, but really represent the complexity of what you just described as one way to try to tackle this. But I don't think AI would help us, actually. AI has limitations. It will end up with a biased answer. But you have to collect the data very differently, and the field will have to come together to try to, that's what pragmatic clinical trial would look like. But then you have to have like multi-state modeling approach, because it's a very complicated picture right now with all the sequencing.
Right, but what I didn't expect any definitive answer, but what I like in your response is that we have to think of how we capture the data, and I liked, I don't know who made the remarks that we also have to think there is strategy to capture the data and strategies to use them and analyze them, and how do we make these two strategies get together.
It's just a very short comment. It's just a very short comment. It is happening in other cancers. I think people are doing this sort of work like in myeloma, but also in prostate cancer. This is sequencing. It's getting very complicated, particularly with these chronic conditions and relapsing conditions. And so it's not unique. So I think there's some, as Wales says, it's statistical methodology and modeling and everything that can be applied with the right expertise.
Okay. Any other comment? Well, I think we can finish this session. Thank you very much.
Can I? Thank you. I like that we finally finished 2 days with Christian's almost philosophical question of how we're going to go from here. And so thank you all for staying with us for 2 days. And I think we had a lot of information. I'm going to do a quick roundup, so don't worry, I won't hold you too much back. But I'll just tell you one thing. If you look at the program, it's supposed to end at 6:40, but actually that's all part of us managing expectations. We added 1 hour in somewhere so that when we finish early, you think, oh my gosh, what good organizing we have done this today. Anyway, can I have the next slide? I've done this kind of 2 or 3 slides over the last 2 days as I listen to the talks and to the session. So let's quickly run through a quick recap. So look at this. We had I think it was very, very important that we had an opening session that was attended by a government official, because this clearly signals that this is an important and significant meeting that the ministries of health are paying attention to. We then had a very nice insight into the Panamanian health system and how that works. And I was pleased to see that within the health ministry, there was a special transplant section within that. And I think that's important for countries moving on. We've talked a lot in the last session about PAHO. We had the PAHO perspective. And really what Maurizio highlighted was that there was a disparity in transplant rates across the countries of Latin America. We've got Chile, for example. You've just heard wonderful presentation where rates are comparable to Europe and America, to really 10 times less the transplant rates in Ecuador. And really that disparity should be a starting point, or should be the inspiration to try to narrow the gap. But what we've also learned is that, again, what feeds in, if you get wrong data, you're not going to get the right information. And what it sounds as if PAHO is getting information is not the best. And so this is one output from the last 2 days workshop, that perhaps WBMT can play a role in helping, and LABMT as well, could help a role in providing that vital information to PAHO. We then also learned, and actually that was in one of the slides, that mortality from pediatric cancers are generally higher in Latin America. And I think Julia as well presented that same data. So again, that provides the impetus for governments, because childhood cancers are always looked at as a priority within governments. And if you look at that and mortality rates are lower, that should inspire governments and should inspire health officials to think of how we should develop therapies, including transplantation, to try to improve them. And then PAHO again presented a strategy for donation and transplant running across to 2030. And I was very pleased that Kenneth, I think, stood up from Trinidad and said that actually not all countries have been included in this survey, and just tells you that sometimes we forget about the smaller countries and the countries that may not figure into discussion. So I think that's something that to think about, and I hope that after this meeting, one of the other outputs to come from this is that the Caribbean countries, Jamaica, Trinidad, Tobago, can come into the fold of LABMT and can start being part of the huge family. Next slide, please. Next slide. And then I think, I think PAHO does sort of get it because they showed this in one of their slides. And if you look at all the issues to do with priorities, they're exactly what we've been trying to discuss over the last 2 days. They're to do with governance, to do with regulation, to do with how to finance sustainable programs, to talk about regulatory gaps. We talked a lot about workforce shortages, about training, about how you train staff and they leave you as well. Infrastructure was talked about, uneven distribution across different countries. And then, of course, the last session to do with data, and then finally on that. We then looked at funding, and I think funding looked as if it was patchy. Many was self-funded. Others relied on a combination of social services and on insurance. And that is a direct effect on how transplant rates are seen in each country. I think a lot of the workshop did deal with training, retention of medical and nursing staff. I'll deal with that a little bit later. And then, as expected, blood supply, blood safety always comes into the picture. So as transplanters, don't forget the importance of blood bankers. Don't forget the importance of basic supply that is needed to be safe to sustain your program. We then covered, I think in the afternoon, the indications and what we should be doing for transplant in this region. And it looks as if, like very much in the rest of the world, hemato-oncology remains your main indication. Although interestingly, and I'd like to learn more about this, there were pockets of unique indications, seen in certain regions. Osteoporosis was mentioned, and clearly Mexico is one of the leading centers in multiple sclerosis. I was talking to the Mexican colleagues, and I've got patients in the UK who come across to Mexico for treatment for multiple sclerosis. And CAR-T really largely still a dream for many of these countries, but it sounds as if there is talk and there is, promising a look into academic research CAR. And for example, I know that in Brazil, they've partnered to look at, with Caring Cross, to look at a big national program for this. And Puerto Rico, of course, for various reasons, I think outlined by the speaker, does have access to commercial CAR-Ts. So the action point really from this for WBMT is that we really continue to learn from one another as much as I learned from this. And I think LABMT are in a fantastic position to please facilitate this. And what I would suggest is that from our side, we will try to repeat this template survey and send it out to countries in a year again, just to monitor whether some things have changed or what has not changed, or whether new problems have arisen. And hopefully this information will help us not only to plan for future workshops, but really to help in planning future training projects, because it sounds as if a lot of what has been requested to us is training and support as well. Next slide. I promised last slide, I think, or two last slides. Next one. And then, and then what else did we talk about? Yes, we had really nice talks from, a nice talk from Christabel about how he started his program. And when you start a program, I think that there was a nice message came through. Look around you. Look at the technical expertise that exists around you. And that can be the solid organ transplant. And I've emphasized again, a lot of expertise, a lot of, highly trained staff in the blood bank that you can make use of. We then learned a little bit about overseas training, and that's important, but not the only story. We talked a little bit about twinning, telemedicine, and we saw the good work done by the Italian team going into frontier regions in the world, into Iraq, into Palestine, and trying to set up programs. But even there, we saw both successes as well as a lot of hurdles and roadblocks as well. We then had a big session on minimal requirements for starting a transplant program, and I think within that, WBMT can certainly help. We've got quite nice guidelines, both on the website and published through, that we can help you with. And then we talked again about transplant indications, and we learned that really, I think across the board, across all countries, the consensus was that myeloma was a good way to start, because of the long history of usage, but also because of the low transplant mortality associated with this that has been repeated in many, many publications, and of course the introduction of non-cryopreserved stem cells. And I think the main limitation to transplantation for most of you really was advanced age and fitness and comorbidity. We then had fairly provocative comments made, which I was very pleased with, and discussed upon, to talk about how practice can be tailored or changed according to different regions. We talked specifically as to whether radiation is really needed or whether you could go by with non-irradiated blood. We talked about outpatient transplants. But I think overall the message that came through is whatever you want to do may not be wrong, may not be right, but please collect data. Please audit, and please use that then to confirm safety and efficacy. And once you have that, you're standing on firm ground. Training, we talked about training, and we asked ourselves whether there should be a fixed curriculum, and I think whether there was a difference. I was talking with Christian between a transplant physician and a transplant leader. The nursing achievements within WBMT are well known, and I think Reggie and your team with Carol and all have led the way, and it's impressive to see a worldwide group of volunteers who are able to do this, and I can already tell you that during this workshop there have been several requests for training. Clearly, we can't meet every request, but we will look at criteria, and I think we might have to look at critical mass of individuals or countries grouped together for us to train. And finally, again, transfusion remains a big hot topic. I think within the WBMT, I think even Hildegard and Dan were extremely interested to learn about replacement donations and how common they are. And again, we understand the limitations of this in different countries, but clearly, again, make sure that whatever you're doing, that it is safe. So if you're doing replacement donations, make sure that they do not increase alloimmunization. We talked about the fact that maybe blood banks in different countries are fragmented, needs a little bit more centralization, central processing, and a coordinated national strategy. Final slide. Next one. And then I think today, this is what I kind of captured. We really dealt with what I would say the essential components or pillars that anchor transplantation, not just the clinical care. And this went from HLA, matching HLA systems, to how we select donors. And clearly, haploidenticals are here to stay and clearly are a big factor. In fact, one of the most significant factors in improving access in Asia and in Latin America as well. And of course, donor safety should be emphasized. And then we learned about specific endemic infections, dengue, yellow fever, and I come back again to Christian's comment that these are no longer restricted infections. We see them in Europe all the time now, and I think the world is changing, and there is much that we can learn from you. And then we went to practical, and I think that was a fantastic session, practical guide to apheresis. We learned and continue to learn about how you cryopreserve your stem cells either by dump freezing or not even freezing at all, and that these are impressive, and I've said this before, practice-changing, data-driven, peer-reviewed experience that really informs the world and inspires the rest of us. And then the laboratory, of course, is essential, and how you make incremental improvements. And I think that's already being seen in Latin America. And I was told of an impressive state-of-the-art facility here in Panama. So maybe think whether you can have regional hubs for this, and how certain countries around the region, which may not be able to do this, could then use these regional hubs. And then we finally ended with what I always am slightly trepidatious about in terms of quality systems, accreditation, and data and registry, because they can sometimes be a little bit dry. But I have to say that the last sessions were fantastic. We have seen how LABMT have grown and the wonderful work that's being done by Julia really in trying to reduce disparity in pediatric care, involving government, involving PAHO. We saw Juliana present fantastic work from LABMT showing what the different practices are. So again, that was an inspiring session for me. By the end of the day, I would tell you that I've you know, what has always been useful in workshops like this are the lunch breaks, the tea breaks, and the bus journeys. If you sit on the bus and it's loud, you know that the workshop is good because people are talking about it. And I would say that productive conversations have been had, and already we're starting to think about certain collaborative projects. And as I've told you, the fact that Jamaica and Trinidad have been included in this workshop, I think has been very important, certainly for me personally. So I think that's my summary of the workshop. So thank you all for coming. We've got a third day ahead tomorrow, which is symposium, and that really will try to cover some of the current topics and the current advances in transplantation. So please do attend. And I think we start at, oh gosh, okay. We start at 8 tomorrow. So, and finally, again, just to remind, there is dinner tonight for speakers, regional speakers, and panelists, 7:30 at the lobby at the hotel. So thank you all again. It's been a pleasure. Thank you. Yeah, of course.